Good afternoon, everybody. Now I invite Dr. Manish Jain on the dais. He has done his MBBS, MD, and DNB in nephrology, fellowship in nephrology, and he's holding the post of director, Department of Nephrology at Medanta, Gurugram. He did his MBBS from PGIMS, Rohtak, and then post-graduation in MD Medicine and later DM in nephrology from Chennai. He then did his clinical fellowship from University of British Columbia, Vancouver, Canada. He has won awards like FISN by Indian Society of Nephrology, FICP by Indian College of Physicians for his outstanding work and continued service to the society and community. He has been awarded Nephrologist of the Year, National ET Healthcare Award 2022. He is also part of many multinational trials and has many publications in the field of nephrology. He has written chapters in various books, including chapter Kidney Transplant in Elderly and Diabetes, in the prestigious Oxford book on renal transplantation in developing countries. He is also a teacher and guided DNB students in nephrology. I welcome Dr. Manish Jain.
Thank you, sir. Thank you for kind introduction. At the outset, I would like to thank organizing East Delhi Physicians Association. Before 1970, the incidence of AKI in pregnancy was severe enough, like dialysis requiring therapy was between 1 in 2000 to 1 in 5000 pregnancies. But this was a dialysis induced. But number of AKI incidence is decreasing as like our obstetric causes, as our care is getting better. And this has like decreased to 1 in 20,000 pregnancies now. But in developing worlds, the incidence of pregnancy has been estimated as high as 20%, and it's a significant cause of fetal and maternal morbidity and mortality. So frequency distribution of AKI during gestation is bimodal. If we see one peak is early in the pregnancy, that is 12 to 18 weeks of gestation, and this is most commonly like septic abortion is like used to be the one of the most common cause for this. The second peak is like into the third, basically third trimester, 35 week of gestation till purpurium, and this was primarily due to the preeclampsia, HELLP, fatty liver of pregnancy, bleeding due to the bleeding complications, especially abruptio placentae, and then sepsis, one of the most common. So what are the normal anatomical and physiological changes we see during pregnancy? Anatomical, we see that kidney sizes increase by almost 1 centimeter. There is dilatation of the collecting system, right is more than the left. Hemodynamics difference is there, our vasodilatation is there, so that's why renal plasma flow and GFR increases. So the normal creatinine of 1.2, if it was there, that will further decrease to 0.7, 0.8. So there is an ultratubular reabsorption of the protein, glucose, amino acids and uric acid. You can see the glycosuria. Electrolyte imbalance is there. So kidney size, as I have told you, it increases by 1 to 1.5 centimeter. Volume increases by 30%. There is a physiological dilatation of the collecting system. GFR also increase. Uric acid, serum creatinine, burn, sodium all falls down. So there is a lower nadir and effect of the hemodilation. So even the small changes in the creatinine level, it signifies the large declines in the kidney function. So causes, we can divide the causes as like our typical teaching, pre-renal, renal and the post-renal. So pre-renal hyperemesis gravidarum is like one of the commonest in early pregnancy. Then postpartum hemorrhage, intrinsic infections, sepsis, preeclampsia, HELLP syndrome, nephrotoxin exposures. Then our GNs, lupus nephritis, TMA, acute fatty liver of pregnancy. Then post-renal, though rare, renal and ureteric calculus and obstruction from the gravid uterus. So if we see the trimester wise, first trimester hyperemesis gravidarum and septic abortion are the common one. Second and third are almost like the overlaps. So if we see both the things like causes according to the time as well as the pathology, pre-renal early like pregnancies, bleeding, miscarriages, hyperemesis gravidarum, ovarian hyperstimulation syndrome, ectopic pregnancy. In late pregnancy, the bleeding and postpartum also bleeding can be there. Intrinsic APLA is there, sepsis, septic abortions, autoimmune disease. If someone has an underlying CKD and which has not been detected, that progresses. Severe preeclampsia, HELLP, acute fatty liver, all these are the causes. So hyperemesis gravidarum, what happens? There is an abnormal GI smooth muscle relaxation from the hormonal laxatives. So this is the first line treatment is the dietary changes. They should like empty stomach should not be there so that nausea can be avoided. Adequate fluid intake should be there. Antepartum pyelonephritis, purpureal like cesarean section. After that we can have the cause. Prolonged ruptures of the membranes. Post-abortive infections like unhygienic practices. Sometimes like lack of abortion, lack of proper antibiotics. They are getting like these things done by the basically RMP Jhola chaps. Then retained products of the conceptions. So frequent UTIs in the pregnancy also leads to the hormonal and because of the hormonal and the anatomical changes. So progesterone on estrogen both can cause. Progesterone causes the dilatation of the kidney pelvis, hydrouretus, and this promotes the urinary stasis. That's why we should tell them to have a frequent micturition, do not hold urine. Estrogen associated with increased incidence of bacteria, that also contributes to the growth of bacteria. Anatomic changes, bladder position changes from the pelvis to the abdominal, and there is an increased bladder capacity due to the decreased tone. Asymptomatic bacteria, like most of the societies recommend that they should be regularly screened, but recently UK National Screening Committee has like recommended that it's no longer required, but definitely asymptomatic bacteria can be a problematic. But many, not all the studies, untreated bacteria will lead to recommend that they will have a low birth weight, preterm delivery, as well as the higher chances of further getting a systemic infections. So this is about TMA, pregnancy associated TMA. It's a microangiopathic hemolytic anemia will be there, thrombocytopenia will be there, and the organ damage. So this can be difference, like overlap is always there, but TTP, HELLP syndrome, complement mediated TMA, and the antiphospholipid. So this is because of the hormone ADAMTS13 activity, then mutational analysis. Treatment is the plasma exchange or the co-administration of the fresh frozen plasma along with steroids if required. HELLP, delivery of the fetus and the placenta helps into that. Typically there will be elevated liver enzymes, low platelets, LDH will be there, hemolysis will be there. Complement mediated TMA, genetic analysis should be done, then anti-FH antibody titers should be assessed. Then the C5 inhibitors, acluzimab can be used, a costly drug but not available. If complement inhibitors are not available, then the plasma exchange is conducted, though efficacy is limited. Antiphospholipid, they should be like antibodies should be done. If they have a previous thrombotic event, they require both the low molecular weight heparin as well as the low dose aspirin. But if there is a history of pregnancy, but without any previous thrombotic event, then either of the one drug can be given, either low molecular weight heparin or low dose aspirin is a like safe drug. But previous pregnancy losses are there, then they might require IVAGs. So TTP is basically a deficiency of ADAMTS13 or the presence of an inhibitor to ADAMTS13. So there is an increased von Willebrand factor activity, procoagulant state is created, and then there is a widespread microscopic thrombosis, and it's a medical emergency. So it's treated with the plasma exchange basically to remove the inhibitor and the plasma infusion to replace the ADAMTS13 protease enzymes. Diagnosis, we all know thrombocytopenia, schistocytes, neurological manifestations, and the most important one of thing, absence of the coagulation abnormalities, which is like if it's altered, that's typically found in the DICs. So this is a normal ADAMTS13 activity. So it is cleaving this von Willebrand and multimers are there. But when it's a deficient, this gets accumulated. So this ADAMS13 is a plasma protease that cleaves the large VWF multimers into small multimers. But if there are deficient enzymatic activity is there, that leads to the accumulation of these large ultra multimers into the endothelial surface, and then the platelets attach. That's why there is a platelet addition and aggregation, and there is a thrombocytopenia. So complement may associated TMA, there is an accelerated activation of the alternate complement pathways. So during pregnancy, this gets further activated, and this can be there. This is our classical, like we used to read in the microbiology books, complement pathway through a classical lectin and the alternative pathways. So mechanism of complement regulated dissociation, basically this causes the DBP is there is the loss of function mutation of the complement regulators, and there are the autoantibodies against the factor H. So once this is there is the excessive activation of the alternate pathway, which leads to the platelet aggregation, and then the microthrombi formation are there. This membrane attack complexes gets activated, and which leads to the endothelial injury and further lysis. So plasma exchange should be started when TTP or atypical HO is suspected, while waiting for the ADAMS level. Eculizumab is for the treatment for atypical HOS, definitely beneficial is there, but that's required for a very long time and a very costly one. Preeclampsia, it affects 5 to 8% of the pregnancies and accounts for the almost 1/5 of the pregnancy-related AK cases. Gestational hypertension after 20 weeks of gestation, along with the proteinuria or any other organ dysfunction. So that is the one which is like definition of preeclampsia. Pathogenesis, as there is a altered, if you see the normal pregnancy, first graph diagram is the spiral artery is there. So the decidua, this is further maintained. But when there is a defective trophoblast invasion of the spiral arteries, there is a deficient spiral artery remodeling, and this causes a placenta ischemia. The blood flow gets compromised. There is an increased secretion of SFLT1 and a decreased availability of VEGF factors and the PIGF. So this leads to the systemic inflammation, endothelial dysfunction. So all organs get affected. Kidney-wise, hypertension, they will have a glomerular endotheliosis, proteinuria, they can have acute pulmonary edema, pedal edema will be there, neurological manifestations, headache, seizures, liver enzymes gets elevated, and then there is a coagulation abnormalities along with the thrombocytopenia. So this basically same a pathogenesis of preeclampsia. This I have taken a photograph from the chapter, so it's like this. Predisposing condition like first pregnancy, multiple gestations, older maternal age, history of preeclampsia and prior pregnancies, history of CKD, hypertension, thrombotic disorders. So this leads to the same impaired trophic invasion of the maternal spiral arteries, which leads to the defective placentation and ultimately increased thromboxane and decreased prostacyclin production. So disruption of normal pregnancy induced vasodilatation is there, which leads to the systemic vascular endothelial dysfunction and target organ damage. So all this, like previously as I told you, all manifestations are there. HELLP syndrome, there is a hemolysis, elevated liver enzymes, low platelets. It occurs 3 to 15% of the patients. For even severe AK and HELLP syndrome, there is a high chances of recovery once delivery is there. So in addition to kidney changes in the preeclampsia, there is associated coagulopathy is there. That results in the bleeding and a tubular necrosis. Acute fatty liver of pregnancy is rare, but once it's there, its manifestation is it's life-threatening. Exact pathogenesis is unclear, but these are the LCHAD deficiency, long chain acyl-CoA dehydrogenase deficiency is there. So fetus is often homozygous for this mutation, and intermediate products of fatty acid oxidation gets accumulating in the maternal-fetal circulation. So this leads to the unable to metabolize the increased level of these intermediate products, and this leads to the accumulation in the liver, leading to the hepatotoxicity. It presents mostly after the 30th week of gestation. Diagnosis is by the clinical and laboratory grounds. So AK is more common, and liver biopsy will show the microvascular fatty infiltration of hepatocytes, swollen hepatocytes, minimal hepatocyte necrosis as compared with the preeclampsia, and prompt supportive therapy with reversal of coagulopathy is needed, and immediate delivery is essential, but the prognosis is definitely not good. So these were the Swansea criteria for AFLP clinical features, though all this can mimic and all overlap is there: vomiting, abdominal pain, encephalopathy, lab values, increased bilirubin, hypoglycemia, leukocytosis, increased liver enzymes, increased urine creatinines. So this is the difference between the HELP, AFLP, AHUS and the TTPs. Mostly that's third trimester. Atypical HUS is the one which is postpartum. AKI is severe in atypical HUS. Renal recovery is possible, but atypical HUS has a high chances of going for an end-stage renal disease. TTP has a fair recovery as compared to the others. CNS findings typically in a HELP and a TTP. TTP is different from the other ones by the neurological involvement. Coagulopathy is not there in the basically atypical HUS as well as the TTP. That's the difference point. That's why we need to do the INR. Ammonia levels is normal except in the acute fatty liver of pregnancy, and effect of delivery on disease, there is a atypical HUS and TTP doesn't make any difference, but AFLP and HELP recovery can happen after the deliveries. Lupus nephritis, diagnosing lupus nephritis for first time during pregnancy or trying to differentiate it from TMAs may be a problematic as they share the same clinical features. So pregnancy predisposed to lupus flares or exacerbates it, it's not clear, but definitely problems happen. And risk of flares during pregnancy increases with the increased SLE activity before conception. Low complements, increased dsDNA, active urinary sediment, and a proteinuria of more than 500 milligram. So what should be our approach to patient in patients with lupus nephritis? Patient is on HCQ, calcineurin inhibitors, they can go ahead. Mycophenolate should not be, if they are taking mycophenolate, they should not go, that should be stopped previously. Low dose aspirin can be given. When we should wait? When their lupus nephritis relapse or flare is there, they are already on treatment with mycophenolate and multiple pregnancies are there, or miscarriages are there. But if severe disease history is there, then they should not be advised for to go for a pregnancy. Severe cardiac disease, pulmonary disease, advanced chronic kidney disease, or a history of stroke. So during hydroxychloroquine and sulfasalazine can be easily given. Among immunosuppression, if they are on mycophenolate, they should be switched over to azathioprine, cyclosporine and tacrolimus can also be given. Steroid should be less than 20 milligram. Other drugs like rituximab, ababacep, even mycophenolate, all should be stopped before pregnancy, before they conceive basically. So lupus nephritis and a difference now, a short one between a preeclampsia. Lupus can happen anytime during pregnancy. Preeclampsia is after 20th week of pregnancy. Hypertension may be present, both, it can be combination. Extrarenal SLE signs will be mostly there in the lupus nephritis. Serum uric acid level is generally seen higher in the preeclampsia. Complements level, if it's an active one, may be decreased in the lupus. Anti-dsDNA will be increased in the lupus. Active urinary sediments will be present in the lupus nephritis. And otherwise urinary calcium excretion is one of the marker, but not too specific. So kidney biopsy, if we are planning during pregnancy, should be considered in patient before 32 weeks of gestation. Most common indication is de novo GN, but it should be and preeclampsia, HELP, acute fatty liver diagnosis can be made without kidney biopsy. Unless it is required, we should avoid the kidney biopsy. Few words about renal cortical necrosis. It can be patchy or diffuse, and it is a diffuse, basically ischemic dissection of all the elements of renal cortex. Progress to end-stage renal disease is a rule in diffuse cortical necrosis, though it may take some time. 20 to 40% might recover to a certain extent. So what are the two possible pathogenic mechanisms which contribute to the development of cortical necrosis? There is a renal hypoperfusion resulting from the blood loss or hypotension, such as in postpartum hemorrhage. Then there is a vascular endothelial injury, which can be through the direct mechanism like HUS, eclampsia, snakebite, like that one, or an indirect mechanism via the circulating substances, which happens during the sepsis, pancreatitis, or intravascular hemolysis. So these are the other causes of thing, but these are the two mechanisms by which our renal cortical necrosis can happen. So obstetric complication like abortions, puerperal sepsis, abruptio placentae, postpartum hemorrhage, and eclampsia are the main causes. 60 to 70% cause of developing this renal cortical necrosis. So other 30-40% are like non-obstetrical causes, mostly due to the sepsis and HUS. Absolute anuria, urine output less than within a 24 hours, or anuria basically within 24 hours less than 100 ml, are usually presenting features of acute RCN. Because of systemic nature of illness, It's usually bilateral. We won't find a single unilateral RCN. Prolonged anuria in a clinical setting of hemorrhage, sepsis, shock, DIC suggests the clinical diagnosis of renal cortical necrosis. Hematuria, which is a microscopic or gross, can be seen in patient with RCN. Renal biopsy is a gold standard to confirm. Typical histological features of RCN is the ischemic necrosis of all the elements of renal parenchyma and cortical region. But if a good ultrasound, even a CT scanner can also pick it up. So this is a cortical necrosis, and then the causes, as already I have discussed, septic abortion, late pregnancies, HUS. So if you see this CT finding, the arrows are there. If you can see the second one, the contrast one, it's a full kidneys like necrosis is there in the outer part. Post-renal AKI, basically it's a physiological hydronephrosis is there, compression of the ureter at the pelvic brim by the growing uterus. So there is a smooth muscle relaxation induced by the increased progesterone. Mostly cases are the right-sided, almost 1/3 can be a bilateral. True obstruction can be due to the calculi, urinary stresses and lithogenic factors of pregnancy can contribute. Bilateral renal calculi or unilateral renal calculus in single functioning kidney can cause pre-renal AKI, surgical intervention such as, post-renal AKI, and surgical intervention such as ureteroscopy, placement of the urethral stents or nephrostomy tubes will be required. Obstruction from the gravid uterus is also possible, but that's a rare one, but highly morbid event. So it's a general management. Pre-renal, this post-renal is there. Pre-renal azotemia, hyperemesis gravidarum, volume resuscitation should be there. Sepsis, volume should be restored, appropriate antibiotic should be given. GN, steroids and immunosuppression, and urgent delivery should be given, should be taken. Immunosuppression, you have to modify it accordingly. The nephrotoxic, this mycophenolate and rituximab and other agents should be avoided. Acute fatty liver of pregnancy, urgent delivery should be conducted, and administration of steroid for the fetal lung maturation is required. TTPs, plasma exchange is there, and then the empirical treatment with a high suspicious before the Adams 13 activity returns. Complement mediated HUS, eculizumab is there, high clinical suspicious is required, and usually administered after the failure of the plasma exchange or once the diagnosis comes. Obstructive uropathy, you relieve the obstruction. Severe kidney injury, renal replacement therapy is required, and indications are same as to the non-pregnant population. Thank you.
Distinguished delegates, you must agree that we had a very professional, prudent and practical approach to talking of about 60 years back when I was a student in medicine. At that time, the obstetric causes and the septic causes were the most common cause of acute renal failure. Do you think they are still or they are newer entities like at the time autoimmune disease, SLE and all those things were almost unknown, and we did not see any patient. Though in MD I got a case of scleroderma with neurological complication. So do you think, clinically speaking, in clinical practice, the same order we see the patient?
Now septic causes have improved, sir, and incidence of AKI is also better in the big cities because of the proper ANC care is there, regular monitoring is there. The initially, like first time without a proper medical measure. So that was one of the most common cause for AKI. So that was there. But as we have got a good antibiotics and profiles are improving, good ANC care. So definitely incidence has gone down in big cities especially. Still the sepsis is the one, but late trimester, this syndrome, eclampsia is there, bleeding is there, then HELLP, these contributes much more. Screening in what form, sir? Renal, we should always do basically, everyone will do the KFT levels, the urine examination. Whenever we are doing a lower abdomen ultrasound, we can do the upper, you can just see the kidneys also at the same time. Otherwise, nothing in specific until unless significant history is there.
So in your practice, how many times you've seen a pregnant lady being transplanted? 1 month I've seen 2 such cases, and previously also they progressed to CKD and they are on dialysis.
With blood transfusion, this should not happen until unless there would have been an underlying chronic kidney disease or something which would not have been diagnosed, Or basic?
So in these two patients, they were evaluated with ultrasound. They were carrying normal ultrasounds also. The kidneys were normal, but they had a sudden blood transfusion reaction that progressed further.
Might be a like severe ATN would have happened, but until as biopsy is done, we won't know the causes, ANA or some these levels.
You have seen such cases in your practice?
Not too much. We never had any obstetric department. It's recently there with us in Vedanta. But during previously also we had not seen like this. Until less underlying chronic kidney disease or something renal pathology is there.
Thank you so much, sir, for the wonderful overview. Just one comment regarding the importance of peripheral smear in a female with underlying autoimmune disease coming with AKI thrombocytopenia. So until we see the schistocytes in the peripheral smear, we would always miss upon the conditions like TTP, TMA, and HUS. So that is something very important. So thank you so much, sir.
Any question or queries from the audience, please? Well, if there are no questions, I must thank you, Doctor, for you must be lauded and applauded. Laud and applaud their presence, and I'm sure their presence will add value to this conference. And with this, we come to the end of this session. Thank you. Thank you, sir.
Thank you, sir. I would like to speakers and chairpersons, please move for. Request our chairpersons, Dr. Vimal Nakra sir, Dr. Rajiv Gupta, Dr. Rajiv Lochan, and Dr. MPS Chawla to please come on the stage.
Dr. Rajiv Gupta is not here. I request Dr. Kher sir to kindly come to chair the session.
Dear friends, without wasting any time, I think we'll start with the next session of this evening. We have none else than Dr. S.C. Chawla, who is known to all of us to speak on the subject. Subject is very wide, but I'm sure he'll be able to do justice to it. Subject is nephrology today and tomorrow. When we were students, it was today. Well, it is tomorrow. When we were there, the only thing was by kidney खराब हो गई यार अब आयुर्वेद या homeopathy करा लो तो ठीक रहेगा नहीं sir. Now we have lots of things. No, but we have lots of things. So Dr. Chawla is a graduate from Amritsar and his DM is from PGI Chandigarh. He, I think, was the first nephrologist in East Delhi. He worked as a professor for a short time, then he shifted to East Delhi, then started dialysis and nephrology in East Delhi, then he shifted to Max Patparganj. Now he's heading both Patparganj as well as Vaishali. And he looks after, he's more interested in teaching rather than working. He teaches DNB students. On to you, Dr. Chawla.
Thank you, Dr. Lochan. The subject which I am going to speak is nephrology past, present and future. And my task has become extremely difficult without Dr. Vijay Kher sitting on the dais. Wouldn't be able to say any stories where he is not involved or I was not involved. So it's becoming very difficult and I'll be picked up for all my errors very easily. Anyway, the outline of this topic which I am going to speak is that how was the nephrology started? What is the history of dialysis, the vascular access, the history of renal transplantation, history of immunosuppression, then the start of nephrology in India, and since we all stay in East Delhi, the start of nephrology in East Delhi. The present day nephrology, that is how much is the dialysis and vascular, what kind of dialysis and vascular access is there today, what is the state of renal transplants today. The future of nephrology stands into the novel diagnostic methods, the novel therapeutic alternatives, and the various medications which are on the rise and have important role. Although there was knowledge about the kidneys being involved in certain diseases, nephrology as a branch is quite young. The world's first society of nephrology was the French Société de Pathologie Renal, and its president was Jean Hamburger. The first meeting was held in February 1949. First meeting of the International Society of Nephrology was held at Evian in Geneva in 1960. So less than 60, 65 years old societies. The father of nephrology, John Putnam Merrill was known as the father of nephrology, but Richard Bright was born in 1789, was a British physician who was the first to describe the clinical manifestations of kidney disorder known as the Bright's disease. And the old Boyd still has Bright's disease as the glomerulonephritis described, and we went through that in our pathology lectures. John Putnam Merrill was an American physician and medical researcher, and he led the team which performed the world's first successful kidney transplant. He is generally credited as the father of nephrology or the founder of nephrology, which is a scientific study of the kidney and its diseases. The term dialysis was coined by Thomas Graham, the professor of chemistry in Glasgow in 1861, when he observed crystallites diffusing through a semi-permeable membrane, that is a vegetable parchment coated with albumin. The first human treatment occurred in Germany, where George Haas performed 15 minutes of complication-free dialysis on a terminally ill uremic patient. Dr. William Kolff is considered as the father of dialysis. This young Dutch physician constructed the first artificial dialyzer, that is the artificial kidney, in 1943. In 1930s, when Kolff watched helplessly a young man dying slowly of kidney failure, he decided to find a way to make a machine that would do the work of the kidneys. World War II erupted, and that time, although the materials were scarce, Kolff improvised using sausage skins, orange juice cans, a washing machine, and other common items to make a device that could clear the blood of toxins. In 1943, he created a rudimentary rotating drum dialysis machine using cellulose tube that was wound around a wooden slat drum which dipped into the dialysate bath at the bottom of its turn. Rotation of the drum powered the movement of the blood as there was no blood pump. Dialysate was made by adding known quantities of salts to tap water, and ultrafiltration could be achieved by adding glucose to the bath, although this was unpredictable. During the course of the next 2 years, he treated 16 patients with acute kidney failure but had little success. All that changed in 1945 when a 67-year-old woman in uremic coma registered consciousness after 11 years of hemodialysis with Kolff dialyzer. He published his work in the seminal report, New Ways of Treating Uremia. Kolff's machine is considered the first modern drum dialyzer. In the late 1940s, Kolff came to the United States, where he continued his research. With dialysis on its way, next was the vascular success. Now, the problem is you are devising a method to clean the blood, but the biggest problem was how to get the blood out and let the blood go in. Dr. Belding Scribner, a young professor of medicine at the University of Washington, came up with the idea of connecting the patient to the dialyzer using a plastic tubes. And if you look at this photograph, this is a primitive photograph of an arteriovenous shunt, where one tube is getting into the radial artery, another into the cephalic vein, and they are connected with a U-tube outside the body. The Scribner shunt, as it was called, was developed using the newly introduced material, that is Teflon. With the shunt, it was no longer necessary to make new incisions each time a patient underwent dialysis. In 1962, Scribner started the world's first outpatient dialysis facility. Pioneering work in renal xenotransplantation had been performed by Emmerich Ullmann in 1902 when he transplanted a kidney between two dogs which lasted for a number of days. Around this time, Alex Carroll was working on the methods of vascular anesmosis with the end-to-side Carroll patch still bearing his name. Russian surgeon Yuri Voronov performed the first human deceased donor kidney transplant in 1933. The ABO incompatible allograft was implanted into the recipients of the leg and the patient expired 2 days later. The first intra-abdominal kidney transplant for a patient of end-stage kidney disease, which was actually polycystic kidney disease, occurred in Chicago on 17th of June 1950. Richard Lawler performed his first and only kidney transplant on a 44-year-old Ruth Tucker. The ABO-compatible graft lasted 10 months, but the patient lived a further 5 years, apparently with her small residual renal function. The first living donor kidney transplant was performed by Jean Hamburger in Paris in 1952, but allograft failure occurred at 3 weeks. Now this photograph shows you the donor and recipient and the doctor explaining, John P. Merrill explaining the dialysis machine. The first successful live donor transplant was famously performed by Joseph P. Murray with the assistance of Merrill at Brigham in 1954. Ronald Herrick donated one of his kidneys to Richard Herrick, that is his identical twin. So it was easier since it was an identical twin, who was suffering from chronic nephrosis. Richard lived for 8 additional years. Then the problem was how to immunosuppress and let this transplant grow. Peter Medower and Frank Burnett won the 1960 Nobel Prize in Medicine for the work that they defined rejection, immune tolerance, and early attempts at immunosuppression. The whole body irradiation was sporadically used and then unsurprisingly abandoned due to poor tolerability. Cyclophosphamide, thiopurine, and high-dose steroids were used before azathioprine, and low-dose steroids were found to having the efficacy. In 1965, one-year allograft survival rates was over 60%, with living-related grafts even higher. Further advances in the 60s included the development of anti-lymphocyte preparations, Paul Tarasaki's seminal experiments leading to tissue typing and cross-matching known as Tarasaki plates, in which it was done. Cyclosporin was adopted in the 80s and led to further process reduction in the early rejection rates. Logistical and legislative changes throughout the world allowed the deceased kidney donation and facilitated kidney transplantation, becoming a mainstream therapeutic option for end-stage kidney disease. Now, I'll come to the history of nephrology in this country. And this is probably synonymous with the life story of Professor Kripal Singh Chugh, the mentor, the teacher, and the guide to many of us, including Professor Vijay Kher, myself, and lot many other nephrologists sitting in this hall and in this city as well. Professor Chugh, while he was doing his MD, was fascinated with the kidney diseases and wanted to do a thesis on the kidney, but nobody was accepting him to do that thesis. He forced his way. Later we came to know about his nature, and he always was like that he could force his way wherever he wanted, and finally made the Punjab University people agree to give him a thesis on kidney biopsy, and he was the first man in this country to have started the kidney biopsy. During his MD, he ended up reporting on 50 successful renal biopsies, and in 1958, his thesis as the first systemic study in the field of renal disease in India, and in 1961, it enabled him to become the first qualified nephrologist in this country. The first twin coil artificial kidney dialysis machine arrived in India in 1961, donated to Christian Medical College, Vellore, from the Christian Mission of USA. His Excellency Shri Gopeshwar Prasad Sahi, the erstwhile Maharaja of Hathwa in the old state of Bihar, was the first person to receive dialysis with that machine. The first dialysis treatment in North India was performed on July 3, 1963 at PGI Chandigarh on a patient with acute renal failure. The dialysis bath was prepared. If you look at this photograph, this will show you the dialysis bath which is there lying at the bedside of the patient. By adding pre-weighted chemicals to the 100 liters tank, which contained warm tap water and was maintained at body temperature by a heater incorporated within. The twin coil required 2 units of blood for priming. Access to circulation was obtained with an arteriovenous cannula through a cut down in the radial artery or a femoral vein and another cannula in the radial vein. The cannula would be kept operative for only 1 or 2 dialysis treatments, and it did not take long to use all the excess sites. Now, finally, Dr. Chugh started dialyzing the patients with the Keel dialyzer. Keel dialyzer, if you look at the patient side, is a long dialysis machine. It's not a machine, it's actually a dialyzer. It had parallel plates and there were membranes inserted in that, and it used to be prepared in the dialysis room of the PGI Chandigarh. The dialysate fluid was made and put into a drum on a height. And if you look at that drum on the height, this contains the dialysis fluid. And a tube was taken from there to run into the keel dialyzer there, and the patient was dialyzed. 1 year after hemodialysis therapy was introduced to India, the first peritoneal dialysis in the country was performed once again in PGI in 1964. At that time, the PD catheters were not available, and we devised the PD catheters by making holes into a tube, which was actually the twin coil dialyzer's tube, and we started introducing that catheter with a trocar and cannula into the patient's abdomen and dialyzed the patients with that. Sporadic attempts were made for the continuous ambulatory peritoneal dialysis in that era, but failed. Though CAPD now is a very successful modality and is fairly commonly used in this city as well as in the other areas of this country. Now this photograph is showing you something very interesting. On the right on the top is the kidney biopsy needle, which Professor Chugh used, and Dr. Vijay Kher and me have also used that to a good time. And now is the modern needle with which you are seeing. The difference is enormous and tremendous, and the procedure also has changed its side. The renal transplantation in this country, the first successful kidney transplantation in India was performed in 1971 at CMC by Drs. Mohan Rao and K.V. Johnny, both of them who had been trained at Adelaide, Australia. In 1972, Dr. Inder Dhawan performed a transplant at All India Institute of Medical Sciences. But later in 1974, Dr. Rajveer Singh Yadav and Professor K.S. Chugh started the renal transplantation in PGI Chandigarh. The first recipient was an 18-year-old man who lost his kidneys to a membranoproliferative glomerulonephritis. And this gentleman spent around 5 years after the transplant working in the same department as the laboratory assistant. As far as this city is concerned, East Delhi's first dialysis machine was established in 1992. Till the year 2000, there were hardly any dialysis centers in this area. In the last 2 decades, East Delhi's got more than 50 dialysis centers. That is how we have progressed. We started renal transplantations in 2007 in Max, Patparganj, but initial few years we couldn't do many transplants. Later we were able to do around 100 transplants, and then we again had a lull. And now once again, over the last 1 year, we are actively involved in the renal transplantation service. And our twin center, that is Max Vaishali, Max is actually far ahead as far as the renal transplantations are concerned in the numbers as well as in the skill. Now these are the machines which will show you the change from so-called dialyzer machines which we discussed and which we saw in the photographs. These are the modern machines. Dialysis, this is a modern dialyzer. There's a dialysis machine, there's a hemodiafiltration machine, and there's a CRRT machine, all three in the row. The vascular access today is used as a modern hemodialysis catheter. There can be a tunneled cath or a permacath, and the arteriovenous fistulas, AV grafts. We have a stalwart among us by the name of Dr. Sanjeev Jasuja, who's a master in doing these catheterizations and AV fistulas. Once he's there, you'll be able to learn more from him. Easier to do transplants now with the numbers increasing progressively. 1 year graft survival rates is more than 95%, and 5 year graft survival rates are more than 85% according to many studies. A host of immunosuppressive agents including rituximab, basiliximab, ATG, mycophenolate, tacrolimus, sirolimus are available now to protect the transplanted kidney. Better antibiotics for the prophylaxis and management of peri post-transplant infections and better diagnostic modalities for the rejection are available now. Now we'll come to a little while for the fact is that what are the current CKD managements. There has been a tremendous amount of advancement now over the past few years occurring in this field as well. We've got a host of drugs which have come up to retard the progression of renal failure. More important ones out of them are ACIs and ARBs, MRAs including Finerenone or Levelsa, SGLT2 inhibitors, alpha-ketoanalogs, phosphate binders, and ESCs. Now, what is the future for us? Where are we? We have said we've got good dialysis machines now, we've got transplantations, but we are still not where we were, because what we're treating is nearly the end-stage renal failure. But what our aim is to see that the patient does not reach the end-stage renal failure. The blind spot for CKD diagnosis. The biggest problem which we have is that we come to know about the CKD after a major chunk of the kidney has already been involved or has already died or already not working. So the blind spot for CKD diagnosis, that is the reliance on the current EGFR threshold to diagnose the CKD, means that by the time the CKD is diagnosed, over 50% of the functional kidney mass has been lost, and the combined risk of CKD progression and premature death is already increased by around 2 to 7-fold. So what we really need at the moment is to have some kind of diagnostic modalities where we can start diagnosing the patients in the very early stage of renal disease, and at the same time, not only after the start of the early disease, we can capture the population which is at risk to develop the kidney disease and try and stop that, or at least slow down the progress of those kidney diseases so that we can have a better life and a better survival. Now this is a very busy slide. This shows you the new methods of diagnosis which are coming up. Some of them are already been approved by the FDA, some are in the pipelines, but once all these come up in this, we'll have a good armamentarian with us to diagnose this. Now what do we have? We have modalities now to assess the number of nephrons, how many nephrons are present in the body, how many not. Low number related is related to the kidney disease. Early detection of chronic kidney disease, the better assessment of acute kidney injury, improves the organ evaluation and organ donor evaluation. Like if you are able to assess the number of nephrons in the donor, you are sure whether you should be able to take that kidney for donation or not. The production of risk in drug-induced nephrotoxicity, and it allows to develop the strategies doing the dosing of the drug and the toxicity of the drugs. Now, what are the modalities which are used to assess the number of nephrons? These are some of the MRIs and PET scans. The iron oxide ferritin is bound to the GBM, that is glomerular basement membrane, and can be detected by the MRI and thus lead to the detection of the number of glomeruli present in the kidney. Similarly, the radio CT PET scan, that is the iron oxide which is radio labeled and that is used in the PET scan, can give you the number of nephrons and the number of glomeruli in that. Sodium MRI is another developing line. There's a flow of sodium from the cortex to the medulla to the pelvis, and that is assessed by the sodium MRIs which can be done or which are being done experimentally as yet, not very common. Then of course the functional MRIs, that is allows to measure the kidney volumes and blood flow in the renal arteries, renal water content and the tissue oxygenation. Out of them is one is bold MRI, that is blood oxygenation dependent MRI, which measures how much oxygen consumption is happening at various areas of the kidney. The DW MRI and the HP13C MRI are the non-invasive assessments of oxidative stresses and mitochondrial pyruvate dehydrogenase activity after renal ischemia reperfusion injury. Once these modalities are available, you will be able to catch hold of the patients in a much early stage and would be able also to know the pathogenesis of the disease as well. Then what we have is the methods to assess the fibrosis. If how much fibrosis the kidney has got, and that we have certain biomarkers, CNA35 CT and ESMA-based MRI, two techniques by which we will be able to assess the fibrosis occurring in the kidney. Contrast-induced enhanced ultrasound is becoming more and more important because it's a totally non-invasive technique and will be able to give us a very good information about the renal functions. Then proteomics and metabolics, again, some of the markers, that is CKD273, a marker of chronic kidney disease, THSD7A, the primary membranous nephropathy marker, NANA-D metabolites seen in the AKI risk population, FAT1, in the membranous nephropathy again, and anti-nephrin antibodies seen in the minimal change disease. And there are few more in the pipeline as well. These are the markers which will be able to give us the idea about the presence of a disease much earlier than we can diagnose it with our present methods. Similarly, there are other biomarkers which are going to be available, which will be giving us the insight about the renal damage in the chronic kidney disease as well as in the acute kidney disease. These can be PCX, KIM1, TNF-alpha, A2HPDI, and AKI biomarkers, DKI biomarkers. They all will be in due course of time available to us. The last is a cell-free DNA, which is also available at the present moment also, which is diagnosed, which is used for the diagnosis of rejection and some of the other kidney problems, which will help us to find this disease out. After this, we'll come to that, what are the newer therapeutic techniques which we are expecting or which we are wanting to develop and which we are going to have in due course of time. The most common, which you must have listened a lot of, is a wearable artificial kidney. This is a dialysis device which will allow the patient the mobility and get dialysis while performing their day-to-day work. That is a small machine which will be embedded or which will be attached to the patient itself. Patient can move around, do his work, and the dialysis can be carried out at the same time. Xenotransplantation, that is another field which is becoming very important, and all of you must have read in the newspapers as well that a pig kidney was recently transplanted into a human being and stayed there for some time actively. This is a future of the kidney transplant, and if we are successful in doing that and we break the codes of that, probably we'll be on a much, much better and a much stronger footing. Stem cell based therapies have been used for quite some time with the disputable results. Some people show that there have been good results in this and rely on the kidney revival and the kidney tissue revival in that. Bioengineering bioartificial kidneys, that is a renal assist device. This is an interesting phenomenon. In this, there are two things which are combined together. That is one part which filters the blood for the uremic toxins and the other toxins, and the other part which works as a kidney and does as the endocrine or hormonal function of the kidney as well. Similarly, implantable bioartificial kidney also has a similar kind of a structure. These two are in the experimental stages, and if successful, once again will change the scenario of the treatment of chronic kidney disease. Then a glomerulus or a tubule on a chip. That's of course the latest thing, that you have grown the renal tissue on a chip and inserted into the body, which will give you all the functions of the kidney available to itself. Now, there are the common medications which are available now, which are on the rise to treat this. The more common is the non-steroidal MRAs, that is the mineralocorticoid receptor antagonist. Out of them is Finerenone, which has got a beneficial effect on proteinuria and CKD progression. Epidemiology they are undergoing clinical results. Aldosterone synthase inhibitors, once again, is the inhibitor of aldosterone synthase enzyme, or CYP112B2. These all will be helpful in reducing the proteinuria and retarding the progression of renal disease. Endothelin receptor antagonist, that is ERAS, sparsentan, it's a dual endothelin angiotensin receptor antagonist. It's available in February 2023. It received the accelerated approval by the USA FDA for treating IgA nephropathy. Main concern for ERA is a sodium retention. It may be hypothesized that co-administration with SGLT2 inhibitors may improve the safety profile. HIF stabilizers, voclosporin are the other drugs which are there. Thank you very much. The future for the kidney disease is very exciting.
Thank you, Dr. Kher. Wonderful talk. A very nostalgic journey. Sorry, Dr. Kher. Oh, Dr. Chhabra.
One and the same thing, don't worry.
Very nostalgic journey from zero to today, and yes. I think days are not far ahead when there will be kidney selling person sitting outside. Ye wali kidney lagwa lo. And I don't know, Dr. Kher is the next speaker. I should ask him for his comments, or should we wait for his talk? Give a few comments.
I think Satish has been with me. He's just 1 year junior to me, and we have progressed from Amritsar Medical College to PGI Chandigarh, and then he was for some time in Ludhiana and then moved to Delhi, and I also moved to Delhi. So we've been sort of seeing the scenario of nephrology evolve over these 45, 50 years in this country, and fortunate to have been Dr. Chuk's students, and the progression of nephrology has been, he's been excellent in giving you the overall perspective. The only thing I would say is that how can we improve current practice of nephrology right now? There are a lot of new things which will come, but whenever they come, they will come. But till that period of time, what is it that I can do in my practice to improve? So the important thing which he highlighted is that identify people at high risk of kidney disease, even before they develop kidney disease. And physicians are the best people because patients are with you before they come to the nephrologist. So I think for physicians it's very, very important to identify people who are at high risk. And who are the people at high risk? He's already highlighted. People who have diabetes, family history of diabetic kidney disease. So somebody who's already had a family history of that diabetic is very likely to develop kidney disease. Can you do it 20 years before? Yes, you can do it. With all the new drugs that are available now, you can SGLT2, mineral corticoid antagonists, ACE and ARBs. Unfortunately, ACE and ARBs are not used by physicians for the fear of rise of creatinines and all that. And you use nonsense drugs like keto analogs, prebiotics, probiotics, which don't have any. He hasn't mentioned their name. He didn't put it in the list of drugs. But every nephrologist, every physician is using these drugs. But these drugs are not used. And you are increasing the burden of pill burden. Huge pill burden. And what is the patient going to eat? He is going to continue these keto analogs because he feels this is the kidney drug. He will discontinue antihypertensives in many other drugs and will continue keto analogs which don't have any significant role. These are low-hanging fruits, very easy for physicians to use to say that these are the kidney drugs. Whereas you should say SGLT2 is a kidney drug. ACE and ARBs are kidney drugs. Mineralocorticoids are kidney drugs. So these are the drugs which I would suggest you should be using more often in your practice in early stages of kidney disease. That is what will improve the quality of care till we get what he has said the future might hold. And I hope to live till that period of time to see some of these progresses, but we've had tremendous progress ever since I was a student. Thank you. Thank you, Srish, for enlivening us through all this history. And I know he and I at night would make these dialyzers, the keel dialyzers with the nurses for 4 or 5 hours at night. We would not sleep on the night duties and would make these. Dialysis was 16 hours those days, not 4 to 6 hours, 16 hours. And invariably these would leak also.
Dialysis used to start at 6 a.m. in the morning, finish at 8 p.m. at night.
4 o'clock in the morning.
Machines were, after the machines came, it used to take 2 hours minimum to put that bloody machine into the functioning order. Conductivity won't come. So won't come, so won't come. What can you do?
JP Narayan was the most famous person who was to dialyze in Delhi. And Irvin Hospital, I was registered there. Our department, we were Dr. P.D. Gulati and Dr. S.N. Rizvi. So a dialyzer was brought to us. It was huge. The whole room was occupied by us. And we and our technician, whole night we used to prepare some solution, which I don't remember today, and then go for dialysis. Eventually he shifted to Jaslok from Delhi, and where dialysis was carried out. That is how I remember about dialysis. And if there are no comments, very nice talk, sir. And what I propose today is, because East Delhi, he was the first nephrologist, still the most active. Let us name him the father of nephrology in East Delhi. Do you agree? So Dr. S.C. Chavra, father of nephrology of East Delhi.
I'm humbled.
So our pleasure, our honor.
I would request the speakers and the chairpersons to move to the felicitation, and I would like to request Dr. Vijay Arora to please facilitate our speaker and the chairpersons. For our next talk on infections in kidney transplant recipients, I would like to ask Dr. RPS Makkad, Senior Consultant Physician, Dr. Anivita Agrawal, Infectious Disease Consultant, Dr. Manisha Dasi, Nephrologist at Max, and Dr. Sushil Tyagi, Senior Consultant Physician, to chair the next session.
As Dr. Manisha Dasi is not here, I think I request Dr. Kuldeep sir to kindly come and chair the session. He is the treasurer of API Noida chapter. Dr. Kuldeep sir.
So next session is a very interesting topic again. None other than Dr. Vijay Kher, and he would be speaking on infections in kidney transplant patients. And after that, enlightening lecture by Dr. S.C. Chabra. I think the stage is set for Dr. Vijay Kher. Of course, everybody knows Dr. Vijay Kher. He is currently the chairman and of the Division of Nephrology and Transplant Medicine at Epidemiology Kidney and Urology Institute in New Delhi. And he has, of course, a huge academic career behind him. So without wasting much time, I will hand it over to Dr. Vijay Kher. Sir.
Thank you, Dr. Makkar, and all the chairpersons on the stage. And I must thank Neeru and the other organizing committee members to invite me again. I've been here many times, Dr. Chabra, who is the father of nephrology in this region, and he used to call me, but most often I used to dread is usually the late sessions that used to run in this. But I must congratulate them that today is all on time. So without wasting time, let me talk about the talk given to me, and that's about infections in the kidney transplant recipients. And Dr. Chabra has said that kidney transplantation is the best and the most cost-effective treatment for end-stage kidney disease. So compared to dialysis, transplantation is much better, both in terms of outcomes, in terms of cost, and including the quality of life. And he was also talking about 1 year survival of more than 95% currently with transplantation. Dialysis, 1 year survival is about, whether it is peritoneal dialysis or hemodialysis, would be about 80% or so. 5 year transplantation survival is about more than 90% now, about living donor transplants even more than 95% now, and 10 year survival of about 80 to 85%. So in comparison, dialysis, 10 year survival in dialysis is about 20 to 30%. So most patients of dialysis will die of cardiovascular disease. And if you look at this survival is even less than the survival of many cancer patients. So we haven't evolved yet in the technology of dialysis in such manner that we provide only 10 to 15% additional kidney function to a patient with end-stage kidney disease with dialysis, whereas transplantation will replace almost whole functions of the kidney. So transplantation is better. The only time where transplantation does poorly as far as survival is concerned is the first 3 months of transplantation, where mortality is higher than dialysis, but every point after that, transplantation is much superior as far as outcomes are concerned. So the survival of patients on transplantation is, so younger patients definitely, as physicians, I would say that you must push these patients to go for transplantation because the outcomes of transplantation are much better in these patients. This is the cost of transplantation. I had calculated it sometimes earlier way in 2002. This was, even currently, the 1 year cost of transplantation in most centers would be about 7 to 9 lakhs of rupees. 1 year, 1 lakh rupees is the cost of immunosuppression, maybe 1.5 in the first year, but usually about 1 lakh by the usually the second year or so. And therefore, preventing infections in transplant patients is an important parameter, and I think I would spend the next 15-20 minutes on that. How do we prevent and how do we so infections remain the commonest cause of death in a transplant recipient in this country. And what determines this is usually the net state of immunosuppressive. These patients receive lifelong immunosuppressive drugs, and therefore to keep that transplantation away from rejections, so there is a price which one has to pay from chronic long-term immunosuppression, and that is what is the infections and is the epidemiological exposure of these patients to that. So what kind of exposures they get. The epidemiological exposures could be, the infections could come from the donor kidney, cytomegalovirus, CMV IgG positive patient into a young child who is CMV negative, he will develop, or Epstein-Barr virus, he will develop Epstein-Barr virus if it is negative in the donor, in the recipient. So these are some of the infections. Tuberculosis in the donor sometimes can be transplanted. Malignancies can be transplanted with the donors and all those. So recipient-derived infections, the natural bacteriological strata of the recipients can predispose them to a kind of infection. Community-acquired infections, pneumonias and bacterial infections, or even fungal infections. And then they are in the hospital and obviously can acquire nosocomial infections as such. What is the net state of immune deficiency? That is the current and the previous immunosuppressive drugs that these have received. And I think I would say one thing. What is important is that many nephrologists as well as physicians who take care of these transplant or patients, prior immunosuppression is important. And if there is a patient, I am imploring that you should put your patients of chronic kidney disease for transplantation. If many of these patients have had glomerulonephritis, we do biopsies. Dr. Satish talked about late referral to nephrologist. These patients come when they are already, kidneys are end-stage kidney disease. We biopsy them many times. IgA stage 4-5, glomerulonephritis stage 4-5, but we continue to give them immunosuppression, trying to save the kidney. But if this patient is going to go for transplantation, I would cut down, because transplant is ultimately, that is what going to. And the outcomes of these patients who have previously not received immunosuppression will do much better. Those who have already received immunosuppression for trying to save these end-stage kidney disease will develop infections in the post-transplant period. So trying to prevent the prior therapies of chemotherapy or these immunosuppressive therapies is then extremely important, and this must be taken in the overall context of the management of these patients. When you look at these patients, especially young patients who are likely to undergo kidney transplantation. Then malnutrition is another thing which happens in our patients. We give them keto analogs, prevent protein intake in patients of our chronic kidney disease. You see these patients are lean and thin. Whether you do dialysis on them or you do transplant on them, they will die. They will develop an infection and they will die. So prevent malnutrition in your chronic kidney disease patients prior to transplantation. Don't give them reasonably good protein diet. Indians are taking as such very low protein diet. So there is no need for protein restriction in chronic kidney disease. Please remove this. protein restriction in chronic kidney disease in India leads to malnutrition. That's an important point that you must remember. Don't allow these patients to go. You are the physicians who see them, and you are the ones who can influence their thinking and thought process. So don't do low protein diets in these patients. And then obviously other viral infections, CMV viruses which are present in our body, BK virus disease, these can get aggravated whenever net immunosuppression is higher. So the treatment as well as management of these is sort of keeping the immunosuppression in such way so that you decide that there is an optimal immunosuppression given to your patients. Transplant patients, because they are on immunosuppression, also have less inflammatory response. So therefore, the symptoms, typical symptoms of signs of infection are not present in these patients. Tuberculosis is usually pulmonary in non-transplant or non-kidney disease patients. Tuberculosis in transplant recipients is extrapulmonary, hidden. You will have to dig in to make a diagnosis of tuberculosis, definitive diagnosis of tuberculosis in these patients. So the regular signs and symptoms of infection are, so there is even the radiological tests and the serological tests also might get altered because of the immunosuppression. And these patients, if they get mild, they are very good today. You feel that this is okay, you can manage them outpatient, but within 24 hours, they can deteriorate very, very rapidly. So be cautious of transplant recipients, even with mild infections. So you must make a diagnosis, definitive diagnosis quickly, and must treat them effectively. Many of these drugs can create problems. Like you have patients with tuberculosis, you can't give them rifampicin because rifampicin has an effect on tacrolimus and cyclosporin, CNIs. It decreases the levels and will cause an acute rejection if you use this. Erythromycin increases the levels of tacrolimus or cyclosporin. So therefore, giving erythromycin, which seems very non-toxic kind of a drug, to a patient will increase their levels and cause severe CNI toxicity. Then there can be other drugs which are nephrotoxic, like aminoglycosides, amphotericin B, high dose of cotrimoxazole, usually used for treatment of pneumocystis carinii. They can all create associations. So you must be aware of all these associations. Who are people who will be at low risk of infections? Those who have good matches. If full house match, brother or a sister is a donor, you don't need to give that much of immunosuppression, no induction therapy. Very good surgery, if the graft function is good. So if you don't get into complications, and fortunately, these days I can tell you with current immunological tests, if a physician is careful, if your surgeon is good, your matches are reasonably taken care of by immunosuppression, you can optimize immunosuppression based, individualized on a particular patient, depending on how much immunological risk that patient has, you might be able to prevent infections in these patients. Appropriate surgical prophylaxis, not giving too many antibiotics, but giving an appropriate dose of prophylaxis in these patients, giving antiviral prophylaxis. So CMV prophylaxis would be required. Prophylaxis for pneumocystis carinii like cotrimoxazole would be required. So these prevent infections in the post-transplant. And vaccinations. Adult vaccination is a neglected field in India. And physicians should be, this is a physicians forum, so physicians should be the ones who should start asking every patient of yours for age-appropriate vaccinations. And in pediatrics, we do vaccinations, but adult vaccination is a neglected, totally neglected area. No one talks about it, and as nephrologists, I would say that all kidney disease patients, cardiovascular disease patients, liver disease patients, they must be vaccinated, and age-appropriate vaccinations for pneumonia, flu, shingles, and many other vaccinations. Hepatitis B is very, very highly prevalent in kidney disease patients, so we must immunize them appropriately. There is an infection pattern in the first 3 months. Usually patients are in the hospital for some period of time. So usually bacterial infections, surgical infections are common. Urinary tract infection is the #1 reason for infections during, or donor-derived infections, like CMV in a patient, in his donor who is positive, if we haven't given prophylaxis, will develop cytomegalovirus infection. So these are viruses which, or bacteria which are there in the first months. 1 to 6 months usually cytomegalovirus, BK virus, pneumocystis carinea, or community-acquired fungal infections or urinary tract infection. Tuberculosis in our country is very, very common. 10 times commoner than in the general population. So patients with kidney transplant are at a very high risk of developing tuberculosis. And tuberculosis is common in our country, so one of the commonest causes of post-transplant infections. And beyond 6 months, you will get many opportunistic infections, especially fungal infections. They're very common, nocardiosis, tuberculosis, urinary tract infections. These remain as well. So there is a time frame during which the infections occur, and this time frame might change from place to place depending on what kind of bacterial flora in your hospital or around you are there. Those would determine what kind of infections will happen in these patients. So the common infections which a transplant patient is seen is the bacterial infections and urinary tract infections in the first month or first 3 months. Now, asymptomatic bacteriuria during early diseases of kidney disease, and as a physician again, another point which I would say, asymptomatic bacteriuria, please don't treat it. There are only 2 conditions when you have to treat asymptomatic bacteriuria. Asymptomatic bacteria during pregnancy and when you are doing a urological procedure. No other condition, medical condition, no other medical condition. I'm making very emphatic statement. No other medical condition deserves treatment of asymptomatic bacteriuria. But I see prescriptions loaded not only with routine antibiotics, aminoglycosides, cephalosporins intravenously being given for asymptomatic bacteriuria. And same is for transplant patients also. There was a fear that first 3 months prophylaxis for urinary tract infection must be given, but now there is reasonable enough evidence that there is no need to treat asymptomatic bacteriuria even in the transplant recipients. So there is symptomatic UTI, yes, that needs effective treatment. Pneumonia, tuberculosis, nocardiosis. Infections can be together. You might find tuberculosis, but don't neglect that if there is a lesion somewhere else and you find that that could be something else, it's very common in transplant patients to have 2 infections, CMV and tuberculosis, CMV and fungal tuberculosis and nocardiosis. Not common. So don't get satisfied that you have 1 infection, therefore you have found out what the cause of fever is. He may have another infection, co-infection in these patients. So that's again fairly common in these patients. Candida, aspergillosis, mucormycosis, cryptococcal meningitis, histoplasmosis. These are other fungal infections which are fairly common. Usually fungal infections may be given Candida for Candida. Candida is the number 1 fungal infection in the post-transplant period. So usually Candida prophylaxis, the fungal prophylaxis for Candida is given for about first 2 months or so in the post-transplant period. But otherwise, cotrimoxazole for pneumocystis carinea is given for 6 months to maybe a year also in some transplant units. Cytomegalovirus infection prophylaxis with Valgan cyclovir is given for about 3 months post-transplantation these days currently to prevent infections. But whenever you are treating acute rejections and all, these infections, these prophylaxis must be done. These must be done also when you are treating patients with glomerulonephritis, which is not being done currently in most patients. Most of the viruses which you come, suddenly these patients come with cytomegalovirus, could be associated with pneumonia, could be associated with fever, leukopenias, could be liver dysfunction, could be gastroenteritis, acute gastroenteritis. And it's very important that CMV IgM, which is commonly used as a diagnostic, be banned. It has no relevance at all. You have CMV PCR available now, which has a better sensitivity and specificity for cytomegalovirus. So stop using tests which are not going to give you any information. It wastes time. So use cytomegalovirus PCR for diagnosis. And in patients who have gastroenteritis, you will have to do a biopsy because serological tests, even CMV PCR may be negative in these patients. So therefore, you would ask the person who is doing the endoscopies to take biopsies from them to make a diagnosis of cytomegalo. Otherwise, you will miss these diagnoses. BK virus must be looked at in the post-transplant period because this is a common cause of dysfunction. It doesn't produce systemic symptoms. It is just kidney dysfunction. So anyone who gets a kidney dysfunction in the post-transplant period, look for BK virus nephropathy in addition to in rejection. Parvovirus, a virus which is again sudden decrease in hemoglobin post-transplant period. Somebody who had a hemoglobin of 15 comes with a hemoglobin of 5, parvovirus. Look of that, just decrease immunosuppression. These are cries of the body that you are giving me too much immunosuppression. Reduce the immunosuppression, these viruses go away without needing, except for cytomegalovirus, it can be very serious and all. Parvovirus and BK virus, just reduce immunosuppression and they get better. If they don't get better, then intravenous immunoglobulin could be given in these patients. But otherwise, usually they get. Herpes zoster, you can prevent these days by shingles vaccine. Herpes simplex, these are warts. Can be very clinical problems. Sometimes they get systemic warts. You have warts everywhere in the body. Just change the immunosuppression or decrease immunosuppression or give them a drug called everolimus. You will see they will disappear. Change mycophenolate to everolimus and you will have warts disappearing from the body all of a sudden in these patients. So the characteristics which I would again emphasize, you will have multiple infections in patients. I talked about it earlier. Again say, typical signs and symptoms of infections are usually lacking in transplant patients. So be on the lookout for infection and make diagnosis. Specific diagnosis is extremely important. I can tell you, I can give you a story. We were working in Sanjay Gandhi Postgraduate Institute. It was a highly super specialized institute. We didn't have pulmonary department with us. So right in our eyes, many patients with pneumonia would die because we were not able to make a diagnosis because we didn't have a pulmonologist who would do a bronchoscopy or do a lung biopsy. So it was frustrating to see all these patients die right under your nose. You would give them, like these days also many times, if you don't want to make a diagnosis, you keep on giving them antibacterial, one antibiotic, then second and third, then anti-tubercular, then antifungal drugs and all that. So you give everything to them. You will never be able to save these patients, I can tell you. Unless you make a specific diagnosis, giving them all kinds of therapies will not save these patients. So I convinced a cardiothoracic surgeon, young cardiothoracic surgeon, to do lung biopsies. These are very sick patients. Often clinicians would refuse to do biopsies on these very sick patients. But I can tell you, I convinced him. I told him, you be on my shoulder, I'm giving you my shoulder. We did it. All the patients we did open biopsies in this, we made the diagnosis, everyone survived. So making a specific diagnosis is extremely important. Giving them empirical drugs is not at all important. So always go invasive, make a histological diagnosis, make a bacteriological diagnosis, make a very highly specific and sensitive immunological test, molecular testing, which is becoming better in these days, but you don't have every disease having those kind of things. So those would become the most important things for making diagnosis. Vaccinations I talked about, so please vaccinate your patients. That's the best way of preventing infections. If you vaccinate your patients prior to transplant, because live vaccines cannot be given post-transplantation. So diseases which have live vaccines will have to be given before transplantation, although attenuated vaccinations can be done post-transplantation, but every physician must try to vaccinate these patients if you really want to prevent infections in these patients. There are many other ways I talked about. Prophylaxis of infections, and we use usually antifungal prophylaxis in the first 3 months by candid oral paints, or sometimes if the infection is higher, maybe oral fluconazole or so. But pneumocystis carinea, usually 3-6 months, maybe a year prophylaxis with cotrimoxazole has been used, and people even have used lifelong cotrimoxazole prophylaxis, but maybe most often, usually about 6 months of therapy. And cytomegalovirus, again, these days Valganciclovir becoming available, generic ones available, cost having been now almost all transplant units use. So prevention of infections becomes an important strategy in these patients. How do you manage infections? Well, if you have mild to moderate, then reduce immunosuppression. The usual drug which is reduced is either a metabolite, antimetabolite, mycophenolate mofetil, and if the patients are on azathioprine, then that is reduced. In moderate to severe infections, you might stop them also for some period of time till the infections get better. But if patients are with life-threatening infections, with hypotension in the intensive care unit, about to go on ventilator, then you should stop immunosuppression for these life-saving infections. And then, so stop tacrolimus and mycophenolate. Steroids can be given as an intravenous hydrocortisone for some period of time till they recover from infections. And surprisingly, you find that many patients, even though you have stopped immunosuppression for 2 weeks or so, 3 weeks, when they get better, the kidney function, after you restart them, the kidney function in many of these patients would come back. You will be surprised that yes, during infection, probably the immunosuppression is high, so therefore immunosuppression needs to be stopped for some period of time. So that's a general kind of a management issues in these. So I have some pictures which is not uncommon for you to see is tuberculosis in these patients, herpes zoster in a transplant patient. This is Candida esophagitis on an endoscopy, then cytomegalovirus inclusions, which you can see on a biopsy. This is lung not showing too much, but oxygen saturation going down, pneumocystis carinii, and this you can see a postmortem of a lung which shows severe involvement, and that can happen, and radiologically you don't see. So when you see a patient who is hypoxic, has mild radiological signs, look at pneumocystis carinii. This is aspergillosis, and this is cryptococcal meningitis. So a patient who comes with headache, fever of some duration, in a transplant patient, do think of cryptococcal meningitis. You'll have to do a CSF examination, and this is India Inc. preparation, although these days you have molecular tests also available, so you could make a diagnosis of cryptococcus in these patients. So ladies and gentlemen, I've told you that if you have to manage infections in the post-transplant period, the management of a transplant is a skillful navigation. There is a lot of science available to it, but it is still remains a lot of art in this. How you manage preventing rejection and preventing infection is something which is a seesaw kind of a thing. So it will, over the years, as you grow, you will, in your experience, you will see that you will be able to manage these patients much better. In the earlier times, you will have to err either on one or the other side. You will see most of these. So ladies and gentlemen, let me conclude. Infections remain a common cause of death in kidney transplant recipients. Early, specific diagnosis is essential to successfully treat infections and save life. Often trying to save the kidney, one loses the patient, and that's important. So it is important to save the patient. Survival of patient is much more important than the kidney. He can go back on dialysis, so it's important. So don't try to save the kidney sometimes if they have rejections, because you are likely to kill them by a severe life-threatening infection. So be cautious, which you learn. Patient's life should always take precedence over the kidney, which we sometimes overdo, and we might lose the patient. So these are some of the successful stories of patients. This is a mother who has donated to this young girl, and she's got delivered successful pregnancy. So she was having kidney transplant before she got married, then successfully after marriage had 2 kids as well, and her other daughter also had kidney disease. She also received a kidney transplant, is also successfully married and has children. This is another one, 10-year-old girl who came and we transplanted in Apollo Hospital, and then she is now grown and has a daughter also, so about 20, 22 years post-transplantation. Then these young ladies who are very beautiful, who they become now friends also, and they go for lunches. They don't invite me often, but they go for lunches and send me these photographs as well to see that they're enjoying. This is again another patient who was young and got married and has children successfully. This is the same one with an elder daughter who is now in college. And these are 2 transplants who are 35 years. The right one is 35 years post-transplant. The left one is 32 years post-transplant, and they are not on the current therapies. They were on azathioprine, and we haven't changed these therapies ever since then. So they continue to remain well, and so transplantation, despite these complications, is an extremely fruitful exercise and satisfying for the physicians. And thank you very much.
Thank you, Dr. Kher, and as expected, you've delivered yet again a wonderful lecture and clarified a lot of myths, especially for the physician community. And I think 2 or 3 very emphatic statements that you made. One, of course, is that do not delay the diagnosis. If you're suspecting an infection, go for the diagnosis and try to make a specific diagnosis. I think that's a very emphatic statement. Then, of course, not to treat asymptomatic bacteria in patients unless there are, of course, indications like pregnancy. So I think we are more enlightened as physicians with your talk on how to prevent and treat infections and how to suspect infections in post-transplant patients. I believe if there are more questions from the audience, we can have a few questions. If not, that maybe we can have questions from the co-chairs. Any questions from the audience?
Sir, how many cases those patients who had undergone renal transplant, they had adult immunization done?
How many? Yeah, we try to be, I have been very proactive on vaccinations, and so we tend to vaccinate our patients early. Hepatitis B vaccination should be done in CKD patients very early, because that's one infection which we can prevent, because if you in very early stages, the response and seroconversion rate with vaccinations are fairly high. So doing it later also, but whenever you get the patient, you should vaccinate them. And hepatitis B is one, pneumonia is another vaccines we should be done. And these days now herpes simplex, herpes zoster virus, that should be also done. And you have varicella, which should also be done in these patients. And obviously flu vaccination should be given every year. Nephritis or CKD. So there is evidence that they should be done much earlier if you can do it, but usually you would do it after 6 months when the small dose should be used, not necessarily one tablet daily. You could do it once a week or so, because fluconazole also has a sort of a reaction with tacrolimus. It raises the levels of CNIs. So therefore, the dosages will need to be. So we usually avoid using them in the regular doses, but one will have to modify depending on how severe the fungal infections are. I use other than fluconazole drugs.
And regarding tuberculosis, latent tuberculosis being so common in India, what is your strategy to detect latent tuberculosis, and then if you suspect, and how do you treat them, how do you manage them? Is there a prophylactic regimen?
Tuberculosis is something that we treat differently than rest of the world, I can tell you that. Patients of chronic kidney disease prior to transplant, if they have tuberculosis or latent tuberculosis in the Western world, we don't treat at the moment, at least nephrologists don't treat latent tuberculosis. We don't look for tuberculosis in patients who don't have any symptoms. But those who have been diagnosed with tuberculosis prior to transplantation, usually we don't wait like rest of the world. They will treat completely for 9 months to a year before they take them for transplant. But we usually treat them for 6 to 8 weeks with full therapy, and then once they become asymptomatic, we take them for transplant and continue anti-tubercular treatment. And we have published on this recently on our experience on this. This is in transplantation, and that has shown, because this was needed for the rest of the world, because they would usually not do, because latent tuberculosis in other countries where tuberculosis is not endemic, they will treat the latent tuberculosis prior to transplantation. But in our country, most nephrologists and physicians would usually look for tuberculosis in the post-transplant period and not give any prophylaxis also. There are some units which do use Isonex prophylaxis, but I think it increases the resistance, so we usually don't use prophylaxis.
Yeah, Dr. Gera.
Is everything. What if you have taken hepatitis?
Pardon?
What if you have taken hepatitis C?
Hepatitis C, fortunately, hepatitis C is a big problem in dialysis population, but hepatitis C is fortunately, now with the new antivirals, you give 3 months of therapy. So we would, if the patient is hepatitis C positive prior to transplantation, we start 1 month treatment, take them through, and many patients will take them earlier. So fortunately, hepatitis C has become an easier problem to tackle now. Pre and post-transplant, it is easier to give these drugs. They don't have that much of adverse effects in the post-transplant period as well, and so you can continue to use these drugs. Thank you.
So if there are no more questions, thank you once again, Dr. Vijay Kher, for that wonderful talk. Thank you once again.
Request all the faculty and chairpersons to move for felicitation, and I would request Dr. R.K. Gupta to facilitate our. So the next session would be on recent advances in kidney failure. I would invite Dr. Lalit Palsani, Professor Nephrology, Dr. Saurabh Srivastava, Professor Medicine, Dr. Amitesh Agarwal, Professor Medicine, and Dr. Ashok Grover, Senior Consultant Medicine, as chairpersons for the next talk.
So I have the pleasure of inviting Dr. Sanjeev Jasuja, who is a senior consultant nephrologist at Indraprastha Apollo Hospital and is also serving as academic coordinator for the Department of Nephrology at the Apollo Hospital, New Delhi. Over to you, sir.
Thank you. Good evening, everybody. In fact, I must say I'm thankful to the organizer, particularly Dr. Nehru, for this invite. And my talk has been made much easier by my two predecessors who just talked about it, Professor Vijay Kher and Professor Chhabra. Both another incidental point is that we all three belong to same alma mater from Amritsar Medical College, surprisingly maybe a Dr. Chog effect. So that must be intriguing most of the physicians from college to get into the nephrology field. I've been asked to speak about the recent advances in the kidney transplantation, but since the advent of the transplant, quite a few things which has just been talked about by Professor Chabra also, ever since this first transplantation happened in 1954, and between these two monozygotic twins, and the Indian first transplant which happened sometime in the year 1971 at CMC Vellore, which has been alluded to already by Professor Chabra. Since then, there is a newer and newer advances which has been coming up. No nephrologist or a physician or a transplanter could ever say that he's probably perfected the art of transplantation. The newer and newer things would keep cropping in every now and then you have to ratify your practice trends, outcomes, and you have to overcome all the barriers which keep coming across this. So I would just take you through the journey, how the transplant has evolved in the last about 50 years. But before we go through that, I would just try to share some amount of the epidemiology of the kidney disease, particularly the end-stage kidney disease. What is the quantum of disease process which would warrant the patients who should be given the supportive treatment strategies in the form of transplantation or the dialysis. All these are the slides which I had been presenting for the years in different kind of talks, but all have one common understanding. Since in India NCDs do not have any kind of a statute to mandate that, it doesn't mandate us that we should make any kind of a registry, so we don't have any data. All the data which we have about kidney disease, whether the all stages of kidney disease or end stage kidney disease, is all has been alluded to, which has been referred from Western world where Indian population is living, or we have done a small patchy studies from where we have evolved this. And what we have evolved is the incidence rate of end stage kidney disease, which is to the tune of about 250 per million population. Now since we are about 1400 million population, on an average you can say about 3,50,000 new patients in every year are there who are looking for the transplant or the dialysis support system if they are eligible for that. And at the same time, if you accommodate the previous year's existing patients, the load goes up to the, which is called as a prevalence of end-stage kidney disease, varies to the tune about 800. Now I'll put another figure about 50 to 800. I'm sure anybody who's epidemiologist who has got interest in epidemiology is going to ask why the number 50 has been referred when the incidence of a disease is 250. Now, it's a bit of a mind-scratching fact. Ironically, our patients do not live a calendar year. So it's possible that we have an incident numbers which may be higher than a prevalent patient. So this is a very unique condition, because CKD we don't have that kind of a catering abilities that we could cater to all of these patients who had become end-stage kidney disease. They could live on to the next calendar year. So that's why our prevalent, even this number of 50 could also be a true number. But since these are all extrapolated numbers, so they can't be dogmatically stated around them. Now look at the irony of the situation. Last year we did 16, this is the data from the Government of India, 16,000 transplants. That puts us on the global map as the third number country doing the kidney transplantations. Number 1 is America, number 2 is China, and number 3 is India. Now 16,000, now that mounts to roughly about 9 transplants per million population. And if you look at the CAPD insertions, about 4 per million population, and at the best, hemodialysis initiated by patients maybe about 20 or 30. So if you put all these patients together, the number is only 30 per million population. That means 220 patients are left with no options to get themselves treated, whether it's an end stage, whether dialysis or a transplantation. So we are nowhere close to giving them the requisite amount of treatment which they are looking for. That's why what Professor K just a few minutes back talked about it. As a physician, our major responsibility is to understand the patients who are vulnerable to develop end-stage kidney disease and to give them a treatment strategies or at least the advices which could be preventable. But in larger interest, with a country where the potable water is a problem, I don't know how the prevention strategies can be rolled out to the masses. Very, very difficult thing to state. But the things which we can do is capacity building. We can definitely increase our capacity by increasing the skill manpower, by improving the financial status, which of course these are the few changes which would come over the years of time, and it is apparently coming in the society. Then the important fact which most of the nephrologists would agree who have been practicing in the last 2 decades, we have seen there's a serious change in cadaver transplantation program in India. I mean, it's taking off, though it's in a very, very early stages. It's in an infancy stage, I would say. But the program has been rolled out at a pan-India level, and hopefully in, I think, next decade, if I continue to practice at that point of time, I feel there would be a decent amount of cadaver program in the countries. Then there are other things which we can tweak at my level, at the practicing level. We can tweak at few facts, like we can have the criteria for transplantation can be upgraded or enhanced so that more and more number of patients can be taken up for these procedures. Now see why we are talking about transplantation. The difference between the transplantation and the dialysis, something has been alluded by the previous speaker also. If you look at the patient who's on dialysis, even if he's on adequate dialysis, 3 dialysis per week, he has to go to the hospital 3 times a week, and they are always complaining of something like fatigue, fluid overload, breathing difficulty, and they have to invest their time, they have to take their pills, phosphate binders, multiple pills are going on. On the contrary, if you see the life of a transplant patient, which is approximately close to the natural normal life, 2-time pills, few follow-ups with the doctors, and almost living with some kind of restrictions around. It's not a completely normal life, but it is fairly normal life which you are living. So that's why transplant, and if you look at the other things, it improves the life expectancy, it reduces the chances of cardiovascular events or the mortality, and improves the quality. Of course, the quality is definitely far, far superior, and Dr. Kher has just shown the cost differentials between the dialysis. About 3 years cost of dialysis is almost approximate to the cost of transplantation, and the maintenance of transplant is fairly meager as compared to good quality dialysis. Now, this has already been referred. If you look at the survival facts of the patients who get a transplant versus the patients who are left on dialysis, you see the first line, if you see the annual mortality on a dialysis patient is to the tune of about 20 to 25%. While the annual mortality of liver-related transplant is only 4%, 5 times advantage of living better quality and longevity in a patients. And who is the most benefited? Invariably, it's a common question which comes to me when somebody refers me as a transplant patient with who's a diabetic. He asks, are you transplanting a diabetic patient? Look at the bottom of this particular line. I mean, just look at the bottom. The most advantageous fact comes in favor of a diabetic patient. If a diabetic goes on dialysis, his probable life survival is about 8 years. On the contrary, if he gets a transplant, it's 25 years. So yeah, that's to 25. And this benefit in an age group of 20 to 40 is probably the enormous. It's the maximum output which one can yield closest to the normal natural life. So most advantageous is to the diabetics, and most of the patients whom I'm transplanting, they are diabetics. Now, when I was in my training program, this is a list of large number of contraindications. These are the contraindications which were listed and handed over to us when we were trainings, that these are the patients which are not supposed to give them a transplantation. So these are the newer things which has evolved over the years. Number one is the blood group was complete. No, if it's no match or O group donor is not available, forget about the transplantations. But with the advent of ABO incompatible transplant, now this is the first Northern India's ABO incompatible transplant from Delhi, which was carried out between the two brothers. And since the advent of this 2012, we have been doing this kind of, we are running this program on a regular basis. Almost all the Delhi transplant centers from all the places, Delhi NCR, everybody is doing this ABO incompatible transplant. Now it's now a very regular routine. Now advantage of this kind of a transplantation is there is always an available 30% chance that you can include a donor who is available in the family, but because of blood group was earlier not offered the transplant donation option, which can be taken up. And our outcomes are almost similar. This is a very large study, about 1,800 patients, which has been published very recently. And if you look at the bottom line of this, is the unmatched univariate analysis outcome between compatible ABO compatible or incompatible transplant. They are almost similar outcomes. So we are almost achieving the same kind of outcomes. Now this is our working group from nephrology, which has given us the guidelines for the ABO incompatible. So it's almost pan-India level, which we are following a very specific kind of a systematic approach to these transplants, and outcomes are quite similar. Now this is the data which is published from Dr. Kher's unit, which they have shown 10-year graft survival and a patient survival, which is also pretty good and impressive data rather, I would say. Now another serious change which has come up was there was a patient who had HLA antibodies. They were excluded from transplantation program, but since we have overcome, we have started having a better understanding about HLA typings as well as the antibody levels, and we've got a much advanced platforms to identify these antibodies and quantifications, so we can approach these patients, we can offer them a transplantation without any major hitch nowadays. Now if you look at about 10% patients earlier had some kind of HLA antibodies for various reasons like blood transfusions, prior transplantations, pregnancy, and quite significant numbers had no reason why they would have anti-HLA antibodies, maybe across reactivity to some kind of fungal, bacterial or viral infection. So that was why these patients had developed HLA antibodies. Now if you look at the HLAs, now there are two things which we need to look at is, when you're doing a quantified HLA parametric assessment of a given patient, like between donor and a recipient, now if the HLAs are matching, it would ensure the long-term longevity of the graft. The more the mismatch, less is the longevity. On the contrary, if somebody has anti-HLA antibody on an assessment right at the beginning, at the point of transplantation, unless you negate these anti-HLA antibodies, the outcome may be catastrophic in immediate transplant period. So you have to quantify these antibodies well in time. Now this is the slide which shows how the matches and mismatches are carried out. I'll just skip some part of it, but I'll just choose the outcome. This is the ANZ data, which if you look at the top survival and the lowest survival, 0 mismatch and 6 allograft, still 6 mismatches shows about 40% survival difference at the time of 10 years or more. Now this is a similar kind of data has been observed in another study which is in a pediatric population. So matching is important in terms of non-generation of anti-HLA antibody over long term and loss of a graft. Now, how do we identify if somebody has got a preformed antibodies which could immediately impact the transplant outcome? So these include CDC cross-match, augmented cross-matches, flow cytometric cross-match, Luminex. Now, there are the newer additions are like Luminex cross-match, anti-HLA antibody screenings, and anti-DSA lysate-based testing, which is a bit in question now, but it has come up with the newer techniques in this. Even this has gone to the next level of advancement. Then we do the virtual cross-matches. We do high-resolution HLA typing of the donor and check the antibodies through this Luminex methodologies, and it can quantify their MFIs against those particular antigens against which these antibodies are existing in a particular patient, and then offer them a transplantation or we can nullify these antibodies through various procedures which I'll allude to sometime in my next slides. Now the basic test which we do is CDC cross-match or the augmented CDC cross-match, which has very high specificity and very low sensitivity in fact. But if somebody comes to me who's got a cross-match positivity, I'll have to think 100 times before offering him a transplant. On the contrary, if somebody comes with a DSA cross-match positivity, which has got a very high sensitivity, the antibody levels may not be very prudent, or it may not be specific to that particular donor. So I may be able to carry out the transplantation without much of the hitch or additions. Now, this is some of our own experience in transplantation, where we look for more specifically for pre-existing HLA antibodies is particularly when somebody is looking for a second transplant, third transplant, or the female particularly when the donor option is coming from husband or the children or the in-laws family. So there is a high probability that this lady has been probably some point of time during her pregnancy, if she is conceived, has been exposed to the antigens from the other family. So this kind of antibodies have to be identified and properly addressed before transplantation. If you don't address this antibodies, you probably may have issues immediately post-transplantation period. Now this is some of our data which we did in last 3 years, about 350 transplants we did, and out of these 350 we did about 400 plus cross matches. Our baseline CDC cross match positivity was only 1%. But when we started looking for anti-HLA antibody screening tests, it suddenly mounted to 4%. So there was inherent antibodies which could be missed by the conventional testing. So we have now superior tests which could identify these antibodies. And whenever you have identified antibodies, particularly beyond a particular level, I would not go into refer to those numbers because they are very specific ones. So there are ways to come out to bring down those antibodies with the help of these methodologies which we adapt in our patients, and once we have brought down the antibody levels, we offer them a transplantation. So all in nutshell, what we have to say is that there was a barrier which we have almost transgressed now, where we can offer the patients who are sensitized towards HLAs, we can offer them a transplant with a specific means which I've just alluded to. Now, very recently, in the last 5 years, I will just show you all the transplanters who are sitting here. If you look at this particular picture very carefully, Many times when the clamps are released, you find the kidney starts becoming flaccid and it starts developing the bluish spots like this. That means there is a preformed antibody which has been missed by your testing, and you have, the antibody has immediately got in action, and these kind of floppy kidneys were earlier thrown out. In fact, we used to dissect these kidneys, close the surgery and abandon the procedure and move out from the theater immediately. So this was the process which was carried out earlier. But in last 5 of our patients, we have moved in this is our paraphernalia of desensitization, which includes plasma exchanges on table in theater with large high-dose IVIGs. We could salvage 3 out of these 5 kidneys, we have these events in theater itself. So these are a few rare things which have started coming up now in transplantations as well. Now, something which Dr. Kher mentioned about a few minutes back about the malignancies. Now, see the malignancy, post-malignancy to get a transplant is probably not a common thing which we see as an Indian physicians, because most of our patients don't have that kind of a survival ability, financial ability, or many reasons. But if you look at the global data, the data is now emerging that these patients, whenever they get, if they had an end-stage disease, they have survived their malignancy first or a second for a particular period of span of time, which is otherwise eluded around 2 years. And since the advent of PET scans, we have come down to about 1 year time tenure. So if this patient is disease-free for more than 12 months, you can consider these patients for a transplantation. The reason for that being because if these patients are left on dialysis, their survival is about 25, the annual mortality is roughly about 20 to 25%, which we just talked about. Every 4th patient would die. On the contrary, if this patient gets transplant, if you look at this number, the lower bottom again, the recurrence rate of malignancy is only 2.4 per 100 patient years. On the contrary, the annual mortality is 25% per a patient. So it's much better that this patient is offered a transplant and is likely to have a better chance of survival if he gets a transplantation. These are the list of few malignancies which are seen in post-transplant period, and quite a few of these malignancies does not have a high recurrence rate even transplantation. There are very few of them. They are either specific to transplant or they have high rate of recurrence post-transplantation. This is some of our experience where we have transplanted post-malignancy patients, or we have encountered our malignancy, our set of issues in terms of malignancies in transplant patients. Now, active infections, I would just skip this because Dr. Kher has just given a very large overview around this. The infections are not uncommon, particularly the patient who comes to seek a transplantation. This is the data which we have put in here. Every 3rd patient of mine who is looking for a transplant is carrying some kind of infection during his pre-transplant assessment and treatment strategic planning. It may be simple bacteremia coming from the lines, or maybe something incipient tuberculosis which needs identification and treatment. This is our data which we published after COVID period, and unfortunately we had a very high mortality in a post-transplant COVID patients, roughly to the tune of about 28%. We published for both first wave and second wave, and a concluding data also. And antibody transformation, somebody had asked the question in the previous talk. The seroconversion rate, which is again our own published data, is just about 42% of the post-transplant patients when we give. But this is just a recent past. I don't think it makes any relevance now in coming times. As it looks, the COVID seems to be getting over now, or becoming a community prevalent disease which may not have any implications. So this is again a large data of published from the hyperactive transplanter centers which had been doing the transplantation during COVID period also, and according to them, the COVID didn't have much of impact on transplant selection, immediate outcomes. But I probably refrained during that period from offering any transplant to my patients. Now, another the area which has seen a sea change, that was considered a contraindication, was retroviral disease, but now there has been a well-balanced global data, and we have also experience of close to about 30 patients whom we have transplanted. Majority of them are black patients, but we have done a couple of Indian transplants, patients who had a retroviral positivity. There are selection criteria of CD4 counts, which is earlier it was about 6 months period, 2 counts which are negative, now it's about 3 months period, and if the viral load is negative, you can offer them a transplant, but there are certain caveats in terms of selection of antiretroviral drugs, which as a transplanters we are all aware about it, and the outcomes are quite similar in these patients as compared to the patients who are retroviral negative to treat with. Now coming to extrarenal diseases like pulmonary, cardiac or hepatic disorders, most of these patients, if they have a cardiac revascularization issue, so the PCIs or CABGs have been carried out and we offer them a transplantation. Similarly, in pulmonary patients, unless somebody has got a cavitatory large lesion and which is non-resectable, we don't refuse the patients to go for a transplantation. Similarly, for hepatic dysfunction, fortunately, I was the first nephrologist to be involved in a first combined kidney liver transplantation in India. So we did our first way back in 1998, probably the first first combined kidney liver transplantation. Since then, this is a regular phenomena. Anybody who has liver disease leading to kidney disease or kidney disease and a liver disease simultaneously, they are offered SLKT, which is a regular treatment strategy, and which is offered at multiple centers now. Now, lower urinary tracts incorrectable diseases or the glomerular disorders has the recurrence rate, but fortunately with immunosuppressants which we are currently using and the kind of methodologies which we have to identify the recurrence of a disease with the biopsy admits and the biopsy reporting criteria, probably we can manage these patients much better. Now, there was another serious no to patients who had a psychiatric illness, but large psychiatric bodies have come up with a wonderful statement. It states to exclude patients with affective and psychotic disorder on the basis of their psychiatric diagnosis alone is unjust. So most of the patients who have any kind of, with the current armamentarium of antipsychotic drugs which we have, probably we can offer them a good transplantation and good quality of life to these patients also. Another key area in a transplant which we see a change or which we see as a follow-up advent is non-compliance, which is pretty common. Fortunately, the drug, this is our own data, the non-drug compliance is less than 1%, drug non-compliance. But follow-up compliance is a serious issue. After the 5 years of transplantation, follow-up compliance is as low as about 70%. About 30% of patients do not turn up for their follow-ups to the respective physicians. This is not uncommon unless they have got another issue which is cropping up because of the transplantation, then only they start reviving their contact with the physicians. Otherwise, 25 to 30% patients. But I would say the non-compliance is a normal, natural human behavior, so it is not uncommon to see such issues with these patients. Now, morbid obesity had been at one point of time known with the advent of the robotic surgery, which is, Delhi is in fact a mecca of this surgery. Medanta started first, it's happening at Max, Dr. Kuller's station. Unfortunately, my hospital has yet not adopted this strategy, but this is a wonderful, for the patients who are obese, or those who had incisional issues, they can be offered the transplantations now. Ours is a country which we call as a young country, but still we have about 5% population, one must not forget, which is above the age of 60 years. So they also have to be benefited by their transplantations. Elderly survival on transplantation is still better than they being left on dialysis. So it is better if they have an option of a donation or a cadaver option can be offered to them. One should not exclude these patients, and these patients should be given a transplantations. And then rare diseases like primary oxalosis, coagulation disorders, there are very competent recombinant therapies are available, and in oxalosis we give them a combined kidney liver transplantation. That's how we have evolved ourselves in the treatment strategy in these patients. And now this is the latest which has come up now, the xenotransplantation. Unfortunately, the 3 transplants which has happened in last 6 months, 2 of them died in 2 months. The final detailings are still not available because the histopathological diagnosis, organ dysfunction disorders are being carried out. This man lived for close to about 2 months. And this is the team which did it at Massachusetts. And let's see, I'm quite sure we are very close to this kind of a transplantation to come with. And I'm quite convinced that one day my clinic would be on the left side. So pigs would be coming to nephrologists to say them hello. Every patient would come with their own donor, which may not be a relative. It may be a pig which has been genetically edited for him. The previous one which I talked about, this pig was edited at 69 genomic genes were edited for him to make it compatible. I think with this I'll stop my talk. This is my recent visit to Leh. Thank you very much.
Thank you, sir, for an excellent presentation. Just for our nephrologists, and since there are majority of physicians here, I don't think xenotransplantation would be possible in India even in next 2-3 decades, because there may be ethical issues related to that. You need genetically modified pigs. And as you showed your data, these all patients were really sick end-stage patients, advanced age or something. And what you showed in your data, 20 to 39, maximum population which we see in our clinic. Am I going to offer him a xenotransplantation? Still I don't know which is going to survive how long. So for me, xenotransplantation is there. But for recent updates, I think 2 or 3 things have come up. There may be transplant tolerance, which we might be talking in future. And again is rejection detection, allograft rejection detection, which is a newer thing right now in India.
Yeah, I agree, Dr. Lalit. There are new armamentarium which we have for rejection detection, which Dr. Satish has already alluded to, so that's why I've missed on that. But I think, yeah, you're absolutely right. Yes, I agree. Xenotransplantation, it's still yet have to evolve long way. We've been reading about it for the last 3 decades. There was a question when I appeared 27 years back for my national program, xenotransplantation. At that time, some questions were, one small note was asked, and it's 30 years. We are still nowhere close to that.
Yes,
I agree. I fully agree.
Any questions, or we can? So we can conclude the session, sir. Thank you, sir.
Thank you very much.
I request Dr. Rajiv Lochan to felicitate the speakers and chairpersons. Now next we'll be proceeding for lamp lighting. I request all the ETPA executives, past presidents and past secretaries to kindly come near the dais for lamp lighting. I also request Dr. Neeru Agarwal. I request our chief guest Dr. Dinesh Kular sir to kindly join us for lamp lightings.
ध्यान को मूर्ख हम नहीं जननी पूजन वंदन ध्यान को आदि शक्ति कर क्षमा हमें आदि शक्ति कर क्षमा हमें आके उदय कर दे पीरा पारी तार दे तार दे तार दे माँ सरस्वती शारदे।
Now we will proceed to our next session, which is going to be the oration. I request all the EDPA executives, organizing chairperson Dr. Neeru Agarwal ma'am, to kindly come over to the dais. Dr. Pankaj, Dr. Aman, Dr. Ajay sir, Dr. Paras, Dr. Vijay Arora, Dr. Sumer, Dr. Makkad sir, please. So this oration is dedicated to Shri Om Prakash Khare ji. This is our second oration. It was started in our previous Midcon 2023. So Shri Om Prakash Khare Memorial Oration was instituted in the year 2023 by Dr. Lalit, one of the senior members and past president of EDPA, in the memory of his late father. Shri Om Prakash Khare was born in a small village called Sisoli near Meerut, UP in 1915. He was the eldest son of 5 siblings. His father was a farmer who had the forethought of educating his children, as he did not want them to endure the daily toils of farming. As a young man, he studied and acquired a job as an accountant in the government sector at Central Defense Accounts in Meerut. He eventually settled down in Meerut, married and began his own family, which included 6 children. Influenced by his father's thinking, he decided to strive for better education and opportunities for his own children, which he could not envision happening in Meerut at the time. So, he decided to shift his family from Meerut to Delhi. The problem was, he was unable to get his government job transferred to Delhi, so despite the dilemma of having a job in Meerut, he went forward with that endeavor. To make it work, he used to leave at 4 a.m. in the morning every day, as there was no other available transportation at that time. He would walk 10 kilometers from his residence to the old railway station, then travel standing on most days in the packed rush hour train to reach his office in Meerut at 9 a.m. After he got done with his work, he used to take the same road back and usually reach home at 11 p.m. when most of his family was asleep. He used to make this arduous journey for almost 20 years. The family used to see him only on Sundays. An active person even in his twilight after retirement from his government job, he worked in the private sector for another 22 years just to complete all his responsibilities, like the marriage of his children, till the age of 82 years. As you can imagine, because of walking 15 kilometers every day for 2 decades, he was one of the fittest 80-year-old you're likely to encounter. But as life would have it, and a surprise to everyone, he suffered a stroke in 2006. He finally left for his heavenly abode in 2007 at the age of 92. Today, 3 of his children are doctors. Dr. Rajiv Lochan and Dr. Lalit are founding members of EDPA, and one is an advocate. From his family tree today, there are a total of 15 doctors in many different specialties. 2 young doctors, Dr. Anirudh and Dr. Anubhav, are also the members of EDPA. Dr. Kriti, Dr. Lalit's daughter, has passed MD dermatology recently. For his everlasting influence on his life, which still gives him a source of love, strength and guidance, even today, Dr. Lalit has dedicated this oration to the memory of his loving father. So this year, Shri Om Prakash Khare Memorial Oration has been conferred to Dr. Dinesh Kular. I request our Senior Vice President, Dr. Aman, to kindly escort Dr. Dinesh Kular to the stage. I request the executives to welcome Dr. Dinesh Kular.
Dr. Kular, sir. I think Dr. Dinesh Kular, you all know, is the, actually he's asked me to cut short his introduction. So we all know he's DM Nephrology, and he's the chairman and head Department of Nephrology and Renal Transplant Medicine at Max Super Specialty Hospital, Saket. He has numerous number of awards, and he has almost 75 publications in national and international journals. I welcome Dr. Dinesh Kular for this prestigious oration, Shri Om Prakash Khari oration.
I request Dr. Lalit and Dr. Rajiv Lochan to kindly come over to the dais for felicitation.
And it's a pleasure that both the brothers are here, and I request Dr. Kular to felicitate our Dr. Lalit sir and Dr. Rajiv Lochan sir. Sir, felicitate Dr. Rajiv Lochan sir. I think it's a great moment for easily history and switch, sir.
I request our executives to now felicitate Dr. Dinesh Kular. Request Kular sir to give the oration lecture, and definitely will sit downstairs. I request Dr. Dinesh Kular sir to kindly start with the talk. It is going to be on recent advances in the management of renal anemia.
Good evening, ladies and gentlemen. At the outset, my sincere thanks to EDPA for this big honor bestowed on me. I'm really humbled and consider it my proud privilege to be the recipient of the second Shri Om Prakash Khari Memorial Oration. What an inspiring life journey of a noble soul we just heard, making sure that he was able to ensure top-class education to his children and make sure that his virtues and noble values were passed on. And what indeed a perfect way to let the memories live on and his principles and legacy carried on. So well done by his children. So it's, as I said, a matter of great pride for me to be talking in front of this august audience. And I have in particular chosen a topic which is close not just to a nephrologist's heart, but it's very relevant to each and every physician, doctor associated with the management of patients of chronic kidney disease. Why we are worried about the CKD is because of the fact, because the numbers are staggering. It's generally believed good about 15 to 16% of our Indian population is afflicted with chronic kidney disease, which makes it something like anywhere close to 20 crore of Indian population having chronic kidney disease. And if we believe there are about 10 crore diabetics in our country, good approximately 4 crore have a meaningful chronic kidney disease as a result of CKD. They have CKD because of various etiologies, diabetes being the majority of the reasons. So there have been recent advances in the management of something which is closely associated with chronic kidney disease, and that's anemia. We know the definitions of anemia, the same apply to anemia in chronic kidney disease as well, but this is normocytic normochromic hyperproliferative anemia, which we are so well concerned about in the context of chronic kidney disease. There are reasons to be scared of because it just increases the morbidity and possibly mortality as well when we look at the influence of anemia in the chronic kidney disease. But what we need to remember is that good 90% of these patients who reach a stage of dialysis are likely to suffer from significant anemia. Even if you look at very early stages of chronic kidney disease, about 15% as against 7.5% of those who do not have CKD is the kind of prevalence seen in these patients. So let's recapitulate before we move on. Why are we talking about anemia in the context of chronic kidney disease? Because we know that erythropoietin comes from the kidneys, but it's not just about erythropoietin. It's about all other factors which are applicable to people who do not have chronic kidney disease are going to be applicable to those who have chronic kidney disease as well. But here on one hand, we have the problems associated typically with iron metabolism, iron assimilation, iron absorption. On the other hand, we have reduced production of erythropoietin on one hand, and at the same hand, whatever production takes place is not able to have its desired effect because of the presence of so many toxins and so many confounding factors, such as hyperparathyroidism. There is hyporesponsiveness to the erythropoietin, whatever little the kidneys are able to produce now. And as I said, all those factors which apply to the general population would apply to our patients with CKD as well. So I'm gradually wanting to take you onto a journey which I personally have lived over the last about 30-35 years. I have been in touch with the field of nephrology. I really hoped and wished my mentor, my guru, my teacher, Dr. S.C. Chabra, who initiated me into the field of nephrology way back in 1980s, was here to see how fondly I remember the days when we were taught by him, the only DM in the entire state of Punjab, forget about nephrology, but then of any other specialty, then for even a cardiology ailments, he would be the first person to be called. But he gave me a thesis which was on beta-2 microglobulin, a very progressive kind of thesis way back in 89 and 88, 89. No one had heard about beta-2 microglobulin in the context of hemodialysis, but then he had that faith, we will come out with something very useful. And I was equally delighted to see the examiner for that MD thesis was also here, Professor Vijay Kher, who subsequently was my DM examiner as well. And he liked the thesis. Why I'm remembering those days is because in 1988 and 89 rather, erythropoietin had been discovered, was being marketed in USA, and we were privileged to have a dialysis unit in the city of Ludhiana way back in 1980s. And few of these people who were traveling from abroad will bring those tiny vials containing erythropoietin, and we used to wonder what this is. And it was a game changer, we realized very soon. because in 1992, when Professor Chuk, and I am again privileged to be one of his last students, the famous legendary Professor K.S. Chuk from PGI Chandigarh, we were here from PGI to organize the Asia Pacific Congress of Nephrology in 6th of December 1992, and you would realize why I am mentioning this date. A lot of cancellations as a result of what had happened in Delhi then. But then we launched India's first erythropoietin in 1992 by the name Hemax. It was a game changer. We had released that huge big white balloon, I still remember, and it was a lot of fanfare. And we thought it was the end of the blood transfusions for our patients. We knew anemia was playing havoc with our patients' lives. We thought with the availability of erythropoietin to our patients, it's going to be a smooth sailing henceforth. Yes, it was indeed a game changer, but as is the case with many other drugs as well, there were shortcomings to erythropoietin as well. And I'll come back to that, and that is the basis of my talk over the next few minutes. So please bear with me when I'm going to talk to you about the absolute basics. As I said, I'm going to take you on a treatment journey for CKD anemia. As you can see on the left-hand side, nothing beyond blood transfusions. Then suddenly we realized we could give them iron dextran, and you will remember the kind of toxic effects associated typically with iron dextran. But still, in some subset of population, it was making a difference. Then finally, we came across erythropoietin, then the longer-acting erythropoietin analogs like darbepoetin, and then finally Sera. And then we realized they were not ideal kind of molecules. We needed something more. Comes in the recent concept of HIF-PHIs, hypoxia-inducible factor proryl hydroxylase inhibitors. So that's something which I'm finally going to take you through. Well, to briefly recapitulate again, when we are trying to address anemia in our patients, of course we have oral iron in mind, which is time-tested. But the unfortunate part is, in a vast majority of our patients, oral iron doesn't suffice because of the poor absorption, assimilation for whatever reasons, some toxins which I'm going to refer to, some molecules I'm going to again refer to you about, are sitting in there which will not allow that to happen. So many times we need IV iron, especially when you give them erythropoietin, there is rapid mobilization of this iron pool. Oral iron is not able to cope up with that kind of load. You will need intravenous iron, and we have learned as nephrologists a whole lot about intravenous iron. Again, our journey, which took a change when iron sucrose was made available, subsequently ferric carboxymaltose, and now more recently we have isomaltoside. I was just told the name got changed to ferric derisomaltose. But yes, there are safer intravenous iron formulations available which have really helped the cause of anemia management in our patients. But before I start talking about HIF-PHIs, we still have to accept there will be some situations whereby out of compulsion we may still need blood transfusions even in 2024 in our patients with chronic kidney disease. So why does iron metabolism happen? Iron metabolism plays a role. As you can see on the left-hand side of the picture, the heme iron can get transported via the heme transporter into the cell, while the non-heme, that's ferric, the vegetarian form, needs to be converted into ferrous by duodenal cytochrome B, and then finds a way into the cell via dimellant transporter, DMT1. Now on the other side of the story, why I am taking you back to your physiology classes is with a reason. And as you can see, this ferroportin is supposed to take the iron from the cell into the bloodstream. Now our villain, so-called villain hepcidin, is not allowing ferroportin to do its work, and it is not allowing iron to get absorbed. So please, I will draw your attention to this villain, hepcidin. Well, God did not make it to be a villain, but in our context, in the management of chronic kidney disease, we are labeling it as a villain here. Now, before we move on, the absolute iron deficiency, which all of you probably know much more than me, than what I do, is applicable to our patients as well. Typically, low iron, elevated TIBC, and low ferritin will make it an absolute iron deficiency because of some loss or some poor intake. While on the other hand, what we as nephrologists see is more of functional iron deficiency. Iron is there, ferritin levels are normal, in fact they are supranormal, yet there is a situation of functional iron deficiency where TSAT, transferrin saturation, is low, and this iron is of no use to the body. To overcome that, we have devised strategies. We realized that one of the causes of this functional iron deficiency was chronic inflammatory state. Hepcidin was sitting in there, and we had to find ways to take care to eliminate the wrath brought in by hepcidin, and we will talk about that later on. So, before we finally go to the topic of the day, it is again trying to understand the importance of iron. It is of no use talking about erythropoietin or the newer molecules if your patient is not iron replete. So with that statement, let's move on. Whether intravenous or oil, there have been enough data which tell us that it is basically intravenous iron, especially in cases of those who have more advanced chronic kidney disease because of various reasons. But yes, when it is a pre-dialysis state, you can always repose your faith in oral iron as well. Only if it doesn't work will you want to move on to intravenous, especially when you know giving intravenous, especially to people, to call them to the hospital, because it is not recommended to be given at home. We all know, even though the iron preparations are absolutely safe these days, not absolutely, very, very safe these days, there is still a scope for some potential reactions. So KDIGO says, before you move on, ensure your patient is iron replete. With that in mind, let's talk about the great molecule which was launched in the world scenario in the 1980s. To us, as I said, became available in 1992. And it is something which we know what it does. It acts at the level of the bone marrow, having in effect on the progenitor cells, finally ensuring that they transform into erythrocytes under the influence of so many factors, of topmost priority being iron. Well, there have been various kinds of erythropoietins available to us. The short half-life of erythropoietin makes it mandatory to be given once or twice or thrice in a week, as compared to those analogs which have a longer half-life, like darbepoetin, typically given once in 2 weeks to 4 weeks. And then we finally have SERA, the methoxypolyethylene glycol derivative, which has to be typically given once in 3 to 4 weeks. So that's an improvement on something which came in with a lot of fanfare. And this is what the sacrosanct guidelines, which are followed world over by all of us, including nephrologists, have to say and talk about erythropoietin, and they every time remind us, please ensure that your patient's iron stores are replete before you talk about erythropoietin. Now the game changer again, one more time. We realized over a period of time that more is not something which is to be desired every time. We would typically believe and label a patient as having anemia, a male less than 13, a female less than 12, but when we tried to achieve a hemoglobin of 13 via erythropoietin, we burnt our fingers. I don't know whether I think it's visible from the distance as well, but 4 landmark trials, the normal hematocrit trial, the CREATE, COIR, and TREAT, cautioned us that if you try to reach a supranormal level in your patients, you will burn your fingers, there will be a higher incidence of vascular thrombosis, strokes, MIs, cardiovascular morbidity and mortality. So we suddenly realized that we were not doing the right thing by aiming something like 13, 14 or 15. We realized that possibly 10 to 12 grams of hemoglobin was safe enough, was convenient enough. So, if that is going to be the case, why not try to eliminate the so-called problems with erythropoietin usage and try to evolve further? What are those problems? The increased viscosity and endothelial damage, increased platelet dysfunction, and hemoconcentration associated problems. Of course, you have to give very high doses of intravenous iron. You exceed ferritin levels of 700, 800 to up to ridiculously high levels of 1500, 2000. You're inviting hemochromatosis. So with that in mind, and at times, erythropoietin will not work at all. There is that element of hepcidin sitting which is governing, not allowing iron to get inside. So what will erythropoietin do in the absence of iron? So with that in mind, we realize there is scope for something called HIF, hypoxia-inducible factors. Why do we believe when we go to the mountains, or those living permanently in the mountains have a higher hemoglobin? We know there is a factor which is induced by hypoxia, hypoxia-inducible factor, which is sensitive to oxygen concentration. So the same holds true for this. And for this discovery, 3 people were awarded Nobel Prize in 2019 for their research much earlier than that. Look at the importance of what the discovery of HIF has the way it has revolutionized. As you can see, in 2019, the Nobel Prize went to Professor William Kaelin, Sir Peter Ratcliffe, and Greg Semenza for their seminal work on HIF-PHIs, or discovery of HIF. So I will now go slow, because this is going to be a very, very cautious journey henceforth, and I will want your complete and rapt attention, please, ladies and gentlemen. I think for the sake of our patients, we need to understand the newer concept of HIF-PHIs. As you can see, the top panel says that when your patient is exposed to normal oxygen condition, normoxemia, what happens is, as you can see here, there is proryl hydroxylase domain, PHD, which responds to oxygen tension and to alpha ketoglutarate. What happens is, these things will stimulate, and PHD, the proryl hydroxylase domain, will cause the hydroxylation of HIF-alpha. Now, HIF is something which was about to produce hemoglobin, was going to stimulate erythropoiesis. Now look at what is happening. They degrade HIF-alpha. There is polyubiquitination of HIF-alpha, and it undergoes proteasomal degradation when oxygen is there. In hypoxic conditions, as you can see in panel B, or when you cause pseudo-hypoxic conditions, what happens is the PHD gets inhibited. Now this proryl hydroxylase domain gets inhibited either via hypoxia or by giving them drugs called HIF-PHIs. Now what will happen? HIF-alpha will not get degraded. HIF-alpha now will get a chance to dimerize with HIF-beta. The two combine, get translocated into the nucleus of the cell, and there is a cascade of events. There is transcription of many genes. Now please, I will one more time draw your attention to what is happening under the influence of hypoxia. The HIF-alpha degradation does not take place. It gets a chance to dimerize with HIF-beta, and the transcription starts taking place. And what is that transcription? That is erythropoietin. But unfortunately, erythropoietin is not the only gene transcription that is taking place, and that is the cause of worry and cause of concern, because the proto-oncogenes, the genes are sitting right next. The vascular endothelial growth factor is sitting next. The cyst growth factors, the chloride channels are sitting next. So what will happen? Erythropoietin will get stimulated. There will be more of erythropoietin, but at what fear and what cost? There could be activation of oncogenic genes. You may get cancers. You may get retinopathies because vascular endothelial growth factor is getting activated. So these were the fears which we had in our mind when we started talking about HIF-PHIs. Thankfully, 10 years down the line, because I have personally been associated with 3 landmark trials with HIF-PHIs over the last 10 years, and the real world experience which we have in the last 2 years, it has not been confirmed. So moving on, this is in effect the overall ways by HIF-PHIs work, not by just stimulating erythropoiesis, but also ensuring that the iron gets absorbed. And it also, that's the beauty, why I was mentioning repeatedly about hepcidin, because hepcidin was not allowing iron to get absorbed. HIF-PHIs, they inhibit hepcidin, because as they say, there is a higher code for everything. If you have hepcidin and hepcidin not allowing iron to get stimulated, there is erythrophron sitting on top of hepcidin. So these HIF-PHIs, they stimulate erythrophron and they tell, please eliminate this hepcidin. So hepcidin gets eliminated, and on both the accounts, iron as well as stimulation of erythropoietin, you can expect a good erythropoiesis. But there are other pleiotropic effects as well. Not just iron metabolism, but also something to do with glucose metabolism. It has been shown to be improved. You can expect LDL cholesterol to fall. You can get mitigation, you can come across mitigation of acute kidney injury, renal fibrosis, inflammation. Why? Because everything gets mediated via HIF. So there are clinical benefits, why we have become so excited, but yes, that concern, that caution of what I alluded to will always remain, even it is still there. It will take some time before we can overcome that kind of fear, but so far not major concerns. I will reiterate one more time, but look at the positives. The oral route suits all our patients, especially those who are not on dialysis. They don't have to seek help to get themselves injected. Increases or maintains hemoglobin levels quite effectively in a certain range. It is a physiological range of erythropoietin which is produced, and not the supranormal ranges which you may come across when you are giving very high doses of erythropoietin. I am quite flabbergasted at times to look at 10,000 units of erythropoietin being administered 2 to 3 times in a week. I mean, that's obviously inviting trouble. So, and of course, whole lot of other pleiotropic effects. So what are the different HIF-PHIs? As I said, I personally have been associated with the trials with both roxadustat, Olympus and Rockies, and then daprodustat, which was Ascend-D and Ascendant-D, and finally, matter of pride for all of us, an Indian company came out with a new chemical entity, Zydus, came out with decidustat, which has been under various trials for the last 6 years, and now it was launched in the market about 3 years back, and it's done fairly well, and it's actually been a game changer. So what are the other factors, other things which we have in mind? You can expect mitigation of acute kidney injury if you are giving HIF-PHIs to your patients. There could be some cardiovascular protection, as you can see on the top panel, via reduction in myocardial ischemia injury, via attenuation of effects of angiotensin II. And that is again something useful for the patient. There could be a potential remission of atherosclerosis, direct effects, or via reduction of LDL. And also, you can expect some kind of neuroprotection to your patients as well. So it's not just about anemia. It's about managing their AKI, offering them cardiovascular protection, offering them neuroprotection. So what does the data say? All this was theoretical so far. So I have just sort of concised the whole thing for you in these few slides. Now these are the phase 3 randomized controlled trial data. 26 RCTs were analyzed, and where HIF-PHIs, the 3 ones available world over, except US, FDA has not approved except one in dialysis indication, whereby they were compared with the existing conventional erythropoiesis stimulating agents, and they were found to be effective in correcting anemia, and there were no safety signals. So before we jump on to efficacy, I think it's a safety which is of prime interest to all of us. Now, if you were to choose between the various molecules, be it daprodustat, roxa, or vedudustat, all these 17 trials said there is not much to choose from one to the other. All were safe, all were efficacious, so you can repose your faith. Coming back to what our own Indian data has shown with via this DREAM ND study, and which was in with desidustat by Zydus in non-dialysis patients. They compared it with darbepoetin, and look what 1, 2, 3, 4 and 5 are showing here. One says the time to achieve target hemoglobin of 4 weeks was comparable. The percentage of hemoglobin responders was comparable when you compared the existing with the newer novel therapy. But the importance, look at the importance. LDL went down by 9.4 milligrams per deciliter, and hepcidin, which is not taken care of by the conventional erythropoietin, came down when we used HIF-PHIs, and of course what we were fearing, the increase in vascular endothelial growth factor, the effect was not there. Same kind of data was with the DREAM D population. That's those people who were on dialysis, and a combination of about 1,000 odd patients over a year's time showed that these drugs were very efficacious, comparable, and safe at the same time. And look at why we are interested in hepcidin. As you can see on the left hand side, the reduction in hepcidin was remarkable. But when you compare it on the right hand panel, that means patients are already on dialysis, the effect was not there, which means there is something more which has to be viewed in patients who are already on dialysis, which means we need to study it further. The sample size may not have been large enough. So this is our own data from our hospital, the real world evidence where we have shown that from baseline to within 12 weeks, you can expect hemoglobin touching around 10 from 9, and then finally it is staying at 20, even at 24 weeks at 10. And mind you, we're deliberating wanting to keep it between 10 and 12. We're not wanting it to exceed beyond 12. And this is data from other parts of the country as well. And this is a post-marketing surveillance study conducted by the company who have found, again, the drug is quite efficacious. Obviously, all these patients were already iron replete, because we are not supposed to, as I have repeatedly reiterated, we are not supposed to go in for these expensive medicines till the time we have ensured that your patient is iron replete, a ferritin level of at least 100 nanograms. Now, one more thing where we try to see whether it can work. So many times we experience anemia, a significant one, even in our patients who are post-transplant. It does wonders there as well. There was data from roxadustat. Now, we have heard about some great stories about the newer molecules. But as I said, it is safety first and then efficacy. So what are the safety concerns? The safety concerns are, since it is going to stimulate many other genes as well, there could be some enhanced risk of thromboembolism, vascular calcification, heart failure may get precipitated or aggravated, risk of cancers, risk of aggravation of diabetic retinopathy, especially the proliferative form, and an increase in the size of those who have polycystic kidney disease. Also, another important thing, look at the positives which one can expect from a molecule called alpha-ketoglutarate. And I told you that by giving them HIF-PHIs, you are eliminating AKG. So AKG, alpha-ketoglutarate, has been typically associated with some great properties such as anti-aging, anti-osteoporotic, anti-inflammatory, anti-cancer, and protection against cardiomyopathy. So no, you are now taking away a very potentially useful thing. So you could have expected some problems. So this is like talking like a devil's advocate, and we must know that we are not harming our patients before we move on. And that's why it's taken more than 10 years to be convinced that all these fears were probably unfounded. The kind of dosage which we are using is not significant enough to cause any of these safety concerns. At least this is what the real world evidence is also showing the world over. It is being used, barring USA, in many other, Japan, China, Central Europe, so many other countries, and of course India. So the potential concerns, just to highlight one more time, are the safety factors as far as these few things I have tried to enumerate here. And I think, but again, to say that the adverse effects were in these meta-analyses found to be comparable. You name it, they had been studied, be it hyperkalemia, hypertension, cardiovascular disorders, or progression of kidney disease as well. Nothing was found to be of major concern. So with all this work, the guidelines have changed. The guidelines have started talking and mentioning about HIF-PHIs over the last few years. As you can see here, they say that anemia and CKD should be controlled using either ESAs or HIF-PHIs. They are talking about the two in the same breath, after, of course, sufficient iron supplementation. So these are the Asia Pacific Society Nephrology guidelines. The UKKA guidelines, which are again very important, they talk how best to use HIF-PHIs. So we have moved ahead from where we were struggling to say whether we should be using HIF-PHIs to a stage where we are now talking about how best to use them. And these are some of the guidelines which become very important once we start using them. And this also, the very important guidelines, the European renal best practice guidelines, they say, consider use of HIF-PHIs in the various categories of your patients, whether they are in the early stages of chronic kidney disease, whether you are dealing with your hemodialysis patients. Remember, our hemodialysis patients, contrary to what the data had shown, have a very high chances of having hepcidin because of the chronic inflammatory state that dialysis is all about. So giving them this useful drug at times does wonders. When we were struggling to alleviate anemia in our patients of CKD5D, HIF-PHIs were found to be a remarkable entry drug. And of course, they also tell us when not to use, especially when there is an active malignancy, when there is a very incidence of a cardiovascular or thrombotic event in the previous 3 months, when your patient has idiopathic pulmonary hypertension. These are the concerns before we have more data, on whether we can use it in the presence of mild to moderate retinopathy. I would certainly recommend not to use these drugs till the time we have safety data. So to conclude my talk, ladies and gentlemen, anemia is of common occurrence in chronic kidney disease and, as we all know, can have serious consequences. Its etiology is multifactorial. Iron metabolism on one hand, its absorption, assimilation, the hepcidin sitting in there on one hand, and erythropoietin deficiency and hyporesponsiveness on the other hand are the keys to effectively managing anemia in our patients. Discovery of erythropoietin was a game changer. I told you about what, with great fanfare, we had launched erythropoietin in 1992. Exactly 30 years later, in the same hall, I was talking about HIF-PHIs, and my introductory lines were, friends, I come here to praise Caesar as well as HIF-PHIs and not to bury Caesar, taking a cue from Julius Caesar. So which means there is a room, there is a scope for both these great molecules which have really revolutionized the way we look at renal anemia over the last 3 decades or so. HIF-PHIs, of course, are very promising agents, class of agents. They possess, as I've shown, many pleiotropic effects, not just anemia alleviation, also cardiovascular protection, AKI protection, neuroprotection, possibly role in various aspects of anemia, even post-transplantation. There are few, at least theoretical, big concerns, and we will be moving ahead very, very cautiously and all the time on the lookout for any of these safety concerns which I have shared with you. Thankfully, real-world evidence so far doesn't talk too much about any of these red flags. There is a real chance that the new compounds will be much more cost-effective in the long run, and of course they have the convenience of being oral drugs, and this fact will certainly improve the management of anemia, the quality of life, and hopefully also the survival of patients with CKD. With this, I end with once more gratitude from my side to the organizers of EDPA, as well as to the family of the great personality, Shri Om Prakash ji, his children, Dr. Rajiv Lochan and Dr. Lalit. Thank you very much for this great honor, and once again, I'll take you.
So thank you, Dr. Dinesh Khulla, for a masterly oration, I would say. As a customary, we don't have any questions for you, but definitely we have the standing ovation for you, Dr. Dinesh Khulla, sir. Thank you very much, sir. Sir, you can have a group. I request Dr. Rajiv Lochan and Dr. Lalit to please come on for a group photograph. Dr. Ajay, Dr. Paras, Dr. Makkad boss, Dr. Aman. Gera sir, if you could come. Dr. BK sir. Dr. Ashok Gowai, come. Right. Dr. Rajivan sir. I think ये पूरा स्टेज हमारा भर जाएगा, लेकिन इतनी ओल्ड एसोसिएशन हमारी सर, 25 years हो गए. So Dr. Anki हो सर. गोविंद सर आ जाओ सर. अपना ही एसोसिएशन सर. I think it's an honor for us to honor Dr. Dinesh Khulla sir for a masterly oration, I would say.
This is the 25th year of PDBA. Silver Jubilee. Big honor, big honor. I am missing both my Guruji to left little early. Chabra left, Dr. Kher left.
This will be a very huge memory, sir, for our association for 20.
Big honor. I'll have these cherished memories.
So we'll be at the 25th. So this masterly oration, actually this next would be tropical AKI. Tropical AKI, I think is a more relevant topic for physicians because we are dealing a lot of dengue cases, a lot of leptospira, scrub typhus, and definitely kidneys are involved in this acute infections. So it's my pleasure to announce that it would be delivered by Dr. N.P. Singh sir. Dr. N.P. Singh sir we all know, and he would be joining straight from Georgia, US. So I would try to connect him from Georgia, US right now. Yes, sir. Welcome, Dr. N.P. Singh, sir. So, sir, just unmute, sir. Let us unmute, kalo, sir. Sir, unmute, kalo, sir. Ashish, sound, yeah, sound. Ashish. Sir, we are doing, sir.
Moving on to our next session, now we would be inviting our chairs, Dr. Prakash Gera sir, Dr. N.K. Govil sir, Dr. Lalit and Dr. Varun Verma sir to please chair our next session.
इतनी जल्दी काफी महंगा कार इंश्योरेंस लिया
Pankaj, can you hear me? Good afternoon, everyone, and after this masterly oration by I'm privileged to be a part of DPA where this nephrology update is being held.
'Bites, other food. There's no better person than Professor N.P. Singh to just deliver his talk on this particular issue. I'll welcome you, sir. Thank you.
Thank you, Dr. Gera, sir, and recording.
Pankaj, can you hear me?
Yes, sir. Yes, sir.
So thank you, Dr. Gera, for a wonderful introduction, and thank you, Pankaj, for giving me a chance to be with my friends and colleagues in East DBA, and I always feel that I'm a part of them. And today I'm going to talk on a very, very important topic, as sir has mentioned. And if this recording cannot be played, then I can go live and I can present my slides.
We'll try for recording first.
Yeah.
ठीक है.
अच्छा, अभी शाम तक आ जाओ.
Minutes on this. That what is my Georgia team from here? I am thankful to the organizers, especially Pankaj, for giving me a chance. I bring greetings for you, and I know this program is going to be successful because of the sheer organization ability, and I have a great faith in EDPA, and I always feel a part of it. So today I am going to talk to you on a very, very important topic. I know it is a full house on nephrology, but one of the very important things which I am going to discuss is acute kidney injury in the tropics. I will be spending around 20-25 minutes on this. We all know that what is a tropical zone, and India, as you can see from here, that is a part of the tropical zone. Now, it extends from Tropic of Cancer and Capricorn is an area with an extreme heterogeneity. On one hand, we have Asian countries like India. On the other hand, we have South American and African countries. We also know that acute kidney injury is, as you must have heard by now, is a reversible decline in GFR, leading to retention of nitrogenous waste products. And also there's an inability to maintain fluid and electrolyte homeostasis this is one of the enigmatic problems, and the reported incidence can vary based on where do we have AKI, whether it is in community, acquired, or hospital or ICU. The incidence may vary from 25 to 80%. Now, how is AKI in tropical countries different from AKI in temperate countries? And we can differentiate this too based on the earning capacity of a country as well. So temperate country is typically represented by Western countries where we have a robust data, we have older age group more commonly affected. Patients are more likely to have a pre-existing comorbidity. There can be an acute or chronic kidney disease. Most of these patients are in ICU or hospital acquired, and they are multifactorial, and they have a high mortality. Also, AKI in tropical countries generally underreported. Most of this would occur either in the community setting or in the basic hospitals. The patients are younger. Often patients have no comorbidity, and it is referred to also as community acquired AKI. It is normally, as compared to AKI and temperate, it is of a single cause. Mortality, if not detected and treated earlier, can be as high as 40 to 70%. Though classically AKI, which occurs following gastroenteritis, the mortality is much less. So what are the common causes of tropical AKI? I would divide them into four important causes. First are the infections, and we know malaria, especially both Vivax and falciparum, leptospira infection, hemorrhagic fevers, infective diarrheas, HIV, scrub typhus is now emerging as one of the very important cause, and so are other rare disorders. Well, plant toxins, mushroom poisoning, herbal medicines, Trapezium wilfori can all cause poisonings which can cause either AKI as a part of multi-organ involvement or AKI per se. We know animal poisons, chemicals are one of the important causes, and snake bite tops the list with scorpion skin, jellyfish sting, carp, gallbladder, or bile. Similarly, drugs like copper sulfate or chemicals, ethylene dibromide, again a very common cause, formic acid. We know a lot of these which occurs, and then we have certain miscellaneous causes, including heat stroke, natural disaster, trauma, especially in a place where there is a fight going on, can also result. Let's start with the infections. Well, a patient with infective condition can present to us with various associated symptoms. So patient can present to you with fever and jaundice, and leptospira, malaria, dengue, yellow fever, etc. Rickettsial disorders can be the other cause, like differential diagnosis. Biphasic fever with thrombocytopenia, transaminitis, leptospirosis. We have continuous fever, severe respiratory symptoms. Of course, COVID now tops the list, but hantavirus is another important viral infection. We can have severe myalgia and acalculous cholecystitis, and all of us have witnessed dengue outbreaks where AKI can be one of the manifestations. Scrub typhus is one of the most difficult condition to diagnose. I know Pankaj has made many a diagnosis by just by looking at the SCAR, and AKI can be a presenting feature, and malaria presents typically with fevers, splenomegaly, thrombocytopenia. Brucellosis, I think one of the most underdiagnosed condition is brucellosis, which can present with fever in exposed individuals, and so are bacterial diarrhea. So what are the mechanism involvement? We go into the details of individual conditions, but we know there can be a direct involvement of kidney or the urinary tract by microorganisms. There can be a tubulointerstitial injury, toxicity. There can be an injury to glomerular endothelium, or there could be an injury to the collecting duct. There can be indirect involvement also, either in the form of hemolysis, rhabdomyolysis, hypovolemia, sepsis, and microvascular injury. And there can be drugs which we actually give to treat infections, but can also cause hemolysis or oculotubular injury. So we classically divide them into glomerular causes like immune complex glomerulonephritis. We know infection-related GN is one of the commonest glomerulonephritis seen in tropical countries. We can have TMA or secondary amyloidosis. We can have typically leptospiral infections can have acute or chronic tubulointerstitial nephritis. We can also have vascular involvement in the form of TMA, and rarely a severe AKI can cause acute cortical necrosis. So this is the important slide comparing all the 4 important causes of infections causing AKI in tropical countries. So we can, leptospira, the incidence is varies from 10% to 27%. Typhus, again, a very variable incidence, but AKI you can see is very common. Dengue, of course, not that common if treated early, especially with adequate hydration and fluid therapy, but still can vary up to 25%, and malaria can cause AKI. Generally, the endemic area, we know about it, and India, other Caribbean countries, South Africa, etc., are common endemic area. We know about these genuses. I'm not going to detail, and dengue virus, all 4 type 1 to 4, especially when the second attack occur, and plasmodium, both Vivax as well as falciparum can cause AKI nowadays. We know about reservoir factors, pathogenesis is in detail. We'll talk about these in greater details individually. Let's come to falciparum malaria. It remains one of the major tropical hazards, and AKI occurs in around 1 to 5% in all cases of AKI. And in terms of non-immune individuals, it can occur in up to 25 to 30%. It can be a AKI alone and a part of a multi-organ dysfunction also. One of the common manifestation of malaria-associated AKI is jaundice, which can present either because of hemolysis or liver involvement. Electrolyte imbalances are common: hyperkalemia, hypokalemia, hyponatremia, and other abnormalities, and volume depletion, GI bleeding, sepsis, nephrotoxic drugs, and hyperbilirubinemia. Though these all act as a precipitating factor. So here we see this is an infective erythrocyte. The malaria has affected this erythrocyte. We know these are the merozoites which are released. They cause cytoadherence. Now, one of the important thing is cytoadherence, which can cause capillary clogging. In addition to that, there's an immune response also. Malarial parasite can induce immune complex deposition and cause glomerulonephritis. And so is the release of the cytokine and inflammatory cascade, which can cause sympathetic activation, RAS activation, and arginine vasopressin release. All this can give rise to AKI. In addition, we have indirect toxicity resulting in decreased renal blood flow like hypovolemia, hemolysis, rhabdomyolysis, hyperviscosity. All this combination of all these factors can result in a severe AKI and malaria. So obviously, the management essentially consists of giving them fluids. Blood glucose level has to be maintained. Acid-base status has to be maintained. Intravenous quinine or artesunate remains the drug of choice. Gametocidal therapy with doxycycline is also recommended. And what is important is to recognize this entity and treat aggressively at early stage. Again, sometimes, occasionally, these patients might require overall the outcome might be good, but once the patient goes into a so-called severe AKI, then these patients might require an intermittent or a continuous form of dialysis. And of course, depending on where the facility is and where is the AKI occurring, even PD can sometimes be effective. But earlier on, people used to resort to plasma exchanges and blood transfusion. So, when I was in Loknayak Hospital, one of the first cases of AKI occurring in patients with leptospirosis I saw, and we know it's one of the very important zoonoses, especially in the southern part of our country and even in Delhi now, it can occur. There can be a direct contact with vectors like rodent, etc. But sometimes when there are floods, when there is a famine, then these things become important. Flooding, lacerated wounds, and history of contact with livestock is important. Again, there are various tropical countries which are affected, and its severity is associated with increased mortality. We know about wheel syndrome, which is a leptospiral disease which causes multi-organ dysfunction, and that includes AKI also. Typically, the presentation is non-oliguric, but I have seen one patient who I have seen as AKI, and then he progressed on to develop a chronic tubular interstitial disease, resulting in chronic kidney disease, and he probably required dialysis for almost next 10 years before he succumbed. This mechanism is almost similar. So we have indirect toxicity in the form of hemodynamic instability, hyperbilirubinemia, rhabdomyolysis, and there can be a direct toxicity. So essentially, it involves the tubular interstitium and tubuloepithelial injury, which can cause various mechanisms through toll-like receptors, through cytokines like TNF-alpha, and all these can cause severity of associated AKI. There can be patient factors like age, comorbidities, and immune status, and there can be disease factor also. So there's a combination of these mechanisms can lead to the AKI, and typically we see these hemorrhagic blisters. And one of the manifestation of AKI in all both leptospiral pregnancy snake bite is a severe acute cortical necrosis, which can be diagnosed earlier stages with the plain CT scan, where you can see a rim of calcification around the kidneys. And this is the histopathology which shows totally damaged glomeruli. It is almost like a fibrotic band, and this actually requires patients to undergo dialysis long term for various reasons. So management again consists of trying to do a MAT, which is microscopic agglutination test, and direct culture, and of course now recently some newer antigens have also been identified, which can be demonstrated for detection of leptospiral disease. Antibiotics are the mainstay. Oral antibiotics like doxy, amoxicillin, chloromycin, or erythromycin, or are given, or penicillin used to be one of the ceftriaxone is one of the treatment of choice. Doxycycline is also an effective prophylactic, and then there is a controversy regarding the use of steroids, but definitely when patients have a severe AKI, then renal replacement therapy may also be required, including ECMO in such situation. Well, here comes our dengue. We know that dengue outbreaks, and this year I am expecting that dengue might come back again because we had a lull last year, and almost affects millions of people, and India is no example where, no exception where we have had a widespread occurrence because of climate changes and clear water collection. The clinical spectrum we all know ranges from asymptomatic disease to severity of, not only thrombocytopenia, but evidence of plasma leakage resulting in hemoconcentration, and electrolyte imbalances are also common. A renal involvement can cause AKI, can include proteinuria, glomerular disease, atypical HUS, all electrolyte, all types of renal involvement can occur. Risk factors for AKI includes transaminitis, which can occur in thousands, metabolic acidosis, severe hypotension, nephrotoxic drugs, and patient factors like elderly, obese, and rhabdomyolysis. And AKI in dengue can have very, very high mortality. There can be a direct viral invasions of the kidney, and there can also be some indirect effects. An ATN is a major result. Rarely we can have a GBM disease. We have cases of IgA nephropathy, and low complement associated lupus nephritis have been described. People have gone ahead and done histopathology, kidney biopsies, EM findings, but all this actually are theoretical in nature, and ultimately we need to understand that there is a cytokine storm which can cause severe hypotension, direct virus injury, rhabdomyolysis, there are interleukins, all this can cause AKI. Management again essentially consists of giving them fluids, and at the right opportunate time. And we know once a patient has been diagnosed as HUS, especially nephrologists like Dr. Balla and others know that eculizumab has been found to be effective. We should avoid non-steroidal antiplatelet. Well, HIV and AKI, I'm not going into a detail, but we know AKI could have occurred as a part of the direct viral invasion in the kidney, resulting in severe HIV-related renal failure. But now, with the availability of the heart, that IVAN has reduced, but now we have so many other causes, especially opportunistic infection, chronic diarrheas, and other causes can cause AKI and HIV. As I said, medication again one of the important causes can due to crystalluria or obstruction, and potential risk factors are high viral load, reduced CD4 cell count, and successful prevention depends on optimizing immune status and aggressively treating them. Well, I can't go ahead with AKI in tropical countries without talking about COVID, though COVID is a pandemic and involves almost all the countries, but especially in our country, It can cause AKI both in the terms of asymptomatic phase, where there is a direct viral effects, invasion causing collapsing glomerulopathy, complement activation, inflammation. It can also occur due to multi-organ involvement or due to fluid management, mechanical ventilation, nephrotoxic drugs. There can be organ crosstalk. One organ can affect the other. And there can be fever, sepsis, diarrhea, and hypovolemia. And AKI has been described as one of the common severe manifestations of COVID. Now let's change again to talk about toxin and poisons. Well, we all know snake bite can cause AKI both in terms of vipers as well as the other cobra. Both can cause AKI. Bee stings can cause AKI, and spiders and scorpion stings can cause. So I'm not going to details of the type of AKI which we get and what causes it, what are the areas by which it can occur, and what is the characteristic of AKI. But definitely we know there are certain herbal toxins which can also result, especially related to herbal medicine. We all know about Chinese herbal medicine causing AKI, but there are certain plants or herbs like Zencola beans, star fruit, impella, raw bile carp have been, unless we talk about tropical AKI, we always talk about these plant toxin. They are very rare. In Delhi, I don't think we've seen many, but when I was in Jipmer, Pondicherry, we've seen many of these cases. And these are the active molecules. Star fruit can cause AKI due to oxalic acid. So the renal involvement occurs either in the form of intratubular obstruction or ATN, severe AIN, and of course, rare other manifestations. But snake bite has to be discussed for this next 2 minutes. It has the highest burden in Southeast Asia and some African countries. We know there are almost more than millions of types of snakes species described, and there are 130 snake genomes which have been described, which are complex chemical compositions mixed with various enzymes, carbohydrate, lipids. These compositions depend on the type of snake, sex, habitat, external temperature, and venomous snakes are classified into 3 basic types: hematotoxin, neurotoxin, and myotoxin. And this is what can cause, various types. As I said, hematotoxin, neurotoxin, and myotoxin. They are present in Asia almost, except there are certain varieties which are present in Australia. All are present. And how does it cause AKI? When again, snake bite results in release of various enzymes of the body and their non-enzymatic protein. They can result in either a complement activation, causes glomerular disease. They can cause direct inflammation and rhabdomyolysis. We know some of the snakes can cause rhabdomyolysis. They can cause endothelial injury and cause TMA. This is one cause of severe ATN resulting in acute cortical necrosis. Well, the patients can recover from that, or patient can go on to develop chronic kidney disease. Well, early biomarkers are needed to diagnose and treat snakebite associated AKI. Elevation of NGAL have been found to end cystatin C. We know about these markers. And more importantly, the cornerstone for reducing morbidity and mortality include early investigation of antivenom, tetanus toxin, and appropriate volume replacement. Delayed timing of receiving antivenom can resulting in tenfold increase in incidence and mortality. And therapeutic plasma exchange has been used in some cases, but TMA, but not effectively. Regarding the plant toxin, I can only say that these are very common in certain villages, especially in African countries, in China, in other countries. It can cause variety of renal lesions, including tubular necrosis, cortical necrosis. Almost 25 to 60% of all cases of AKI from medical causes in hospitals in sub-African countries are associated with herbal medication, and such medication are usually prepared under non-standard conditions and often contains many toxins which can cause. And I've already talked about this slide. I'm not going to go to this. Well, in the last, I think, 2 important things: G6PD deficiency. We know it is common in some ethnic tropical populations, and acute intravascular hemolysis occurs because of the precipitation of hemoglobin when the red cells are subjected to oxidative stress in patients who are G6PD deficient, and hemolytic crisis develop within hours of the stress and can get precipitated by certain drugs. And well, the infections can be these hepatitis, rickettsial, typhoid, urinary tract infection, and typically a cola-colored urine can occur, and treatment includes high fluid and dialysis for hyperkalemia. in the end, pregnancy-related AKI is again occurs all over the world, but much more commonly in tropical countries. The obstetric AKI continues to be a very important part, though in India the contribution of obstetric AKI has declined to around 8 to 10%, but they about 20% of develop, especially when they occur in the third trimester. In the next slide, we'll talk about it. Can cause acute cortical necrosis, and they are actually dependent on dialysis for a long time. So you can have in the first trimester due to septic abortion, but in the late trimester, it is due to abruptio placental, severe hemorrhage, HELLP syndrome, acute fatty liver, and TMA of unknown mechanism. And these are certain differential diagnoses, but when transaminitis may be raised in HELLP syndrome, we know that it can occur in an acute cortical necrosis. It's a frequent progression. There can be lupus nephritis, which can occur in pregnancy, and these are the various causes, and schistocytosis occurs in HELLP and HUS. So in the end, I would like to take you through this slide of algorithm of how to approach a patient. Of course, history, physical examination, blood and urine studies are the cornerstone. Well, you have to take a detailed step history, physical findings, try to find out what is the fractional excretion sodium, what is the urinary sediment, and divide these into either a pre-renal, intrinsic or obstructive causes. And based on this, we have to identify, treat the underlying cause. I think hydration is very important. We have to improve the micro and macrovascular, glomerular disease, interstitial nephritis. If it is due to drug-induced, steroids may be there. Then ATN, we have to support with dialysis. We have to give them specific therapy. If it is a snake venom, it is a toxin, we have to hydrate them. Then, of course, if the patient is not improving, we have to refer them to our colleagues in nephrology who will like to treat them. With this, I will thank, and I'm sorry if I have exceeded the time limit, but I thought it is an important topic, and each one of us should be aware about tropical AKI, which can be seen by each one of us, especially in this season when you have a hot tropical climate. Infections, I've not talked about many other disorders like typhoid, like sepsis, which can also present with AKI. Thank you very much for your patience. These are some of the references. If you want to, I've already shared the slides with Dr. Pankaj, and you can take the slides from. Thank you very much.
Thank you, Professor N.P. Singh, for such a wonderful talk. I think he has practically covered every aspect of AKI which we see in tropics. Invariably, the early diagnosis is the key to the management. And I'll request from the house if any question is there, so that I think Professor N.P. is still available.
Yes, sir.
Yes, sir. Dr. Gera, good evening. Can you hear me, Dr.
Yes,
Gera?
we can. Thank you, sir.
Right.
Any question from the audience?
So I think this AKI is, sir, you can have the question.
Sir, Dr. N.P. Singh, I have one question. Can we preempt the development of acute kidney injuries in tropical disease like dengue, malaria, or are there any markers before the development of AKI by which we can know that this patient is going to develop AKI?
So I think a very, very important question. What is important is to, have a high index of suspicion that one of the organs which can get affected in these tropical infection is kidney injury. Definitely, there are certain patient-related risk factors, there are certain disease-related factors which can make you aware that this patient is going to develop an AKI. Now, once the patient develops an AKI, then management essentially consists of hydrating them if it is a pre-renal, avoiding nephrotoxin agents, and if the patient has an established AKI, hyperkalemia, acidosis, then it requires dialysis. So, yes, you talked about an early diagnosis. I think there are markers which have been in vogue for last almost 1 decade, but unfortunately they have not been converted into a clinical use. Professor Kullar, who's sitting in front, knows that the MATS is started, the cystatin C as an alternative investigative tool to detect AKI and CKD, but we do not know whether still we have these NGALs and early markers of kidney injury which can be made available. So I think we need to rely on our old age friend creatinine, but more importantly, if the patient develops an oliguria, patient has other evidences to suggest that this is going to develop AKI, then we should be able to diagnose them. Dengue, with Dr. Gera and Pankaj and Ashok, we were there when I was in Max. We had many patients who presented to us with AKI. Vivax now also causes AKI, while earlier it was supposed to be a benign disease, but now, of course, we know Vivax is as bad as falciparum, and of course, leptospirosis should always be thought of, and in India, all over, especially when we were in South, we were having these cases, but definitely in Delhi as well.
Thank you, sir. One of the pertinent questions that comes up for physicians, sir, that sometimes the patient of tropical infections gets into anuric AKI, right? And patient becomes, dialysis dependent. So how many weeks, like sometimes patient takes longer time to recover. So is there any marker, sir, for those patients that would recover, the patient would be on permanent dialysis or for tropical infection-induced AKI, sir?
I think it's very important question. Many of these, especially snake bite related, pregnancy related or severe leptospira can cause what is known as severe ATN, or many of them can go into acute cortical necrosis, which can be patchy or which can be, full ACN. Now, of course, CT scan, non-contrast CT scan can rapidly diagnose ACN, but I think in my experience, and others can pitch in, almost patients may require dialysis for almost up to 4 to 8 weeks, depending on the severity, and many of these patients then suddenly open up. I remember when I was in Maths, we had a case where we dialyzed for almost more than 2 months, and then suddenly one day he presented with polyuria and his kidney function improved. But even if their kidney functions improve after 2 to 3 months, they will have a residual serum creatinine which will be higher, and they have more chances of going into chronic kidney disease. But definitely I will give them 2 months time before I label sort of them as dialysis dependent. We can ask Dr. Kullar on this more.
Well, thank you, Dr. N.P. Singh, for excellent presentation. Dr. Kullar, anything you want to say or give comments about it?
Thank you so much, sir, for joining in with us. I request... Sir.
No question is possible after that masterly talk. I mean, you don't leave scope for any further information. Just to reiterate what you have said, yes, timely dialysis for these patients, that can certainly bring down the mortality rather than delaying it. We debate as nephrologists also when is the right time to initiate dialysis. I think it has to be on a case-by-case basis. But point well taken, if the recovery doesn't happen, and a very pertinent question asked, if it doesn't happen timely, obviously you become little worried and start thinking about cortical necrosis. You can get a clue from a plain X-ray abdomen or even a CT scan as early as 7 days. But obviously, the true diagnosis will come from biopsy. Short of that, a contrast-enhanced CT scan to look that there is no cortical flow. Obviously, you may not want to give contrast to a patient who is already oliguric or is anuric. So it's best is, and since the treatment is not going to change, you will have to patiently wait for the recovery, which is going to happen in majority of the times.
Thank you, sir. I think next time we expect Dr. N.P. Singh to be physically present here when we have conference. That is our request from EDPA. Thank you very much.
Thank you so much, sir. I would request the chairpersons to please proceed towards the felicitation counter, and Dr. Grover, sir, to please felicitate our chairpersons. Moving on to our next session, I would request our next chairpersons to kindly come on the stage. Dr. Vijay Arora, sir, Dr. Mukesh Mehra, sir, Dr. Ajay Kumar Gupta, sir, and Dr. Aman Rohtagi, sir.
So good evening friends. So our next topic will be insulin therapy in renal failure patients. We all know that we have to be very sensitive while treating the renal failure patients. So to take us through this topic, we have Dr. Hanish Gupta. So he's a consultant in Life Aid Clinic at Mayur Vihar and consultant at Sri Krishna Medical Center. And he has been honored with various awards and he has got mentions. And presently he is the executive member of RSSDI Delhi chapter also. So over to you, Dr. Hanish.
Thank you, Dr. Ajay. Thank you, all the respected chairpersons and the August gathering here from EDPA. And as the things have already been put in perspective, my topic is on insulin therapy in renal failure. But I'll give a little bit primer of what we stand as a world statement in diabetes today. This is a picture that I took in some conference. This is a picture of a cartoon from 1992. And this is about a story, seven blind men and the elephant. So out of the 7 blind men, one blind man just went ahead and grabbed the tail of the elephant and he said that this is probably some kind of a rope. And one went and grabbed the leg and said, no, this is not a rope, this is a tree trunk. And this is exactly what was happening in diabetes for many years. From 1920 when insulin was innovated, insulin was discovered. At that point of time, everybody was looking at diabetes from different angles. Somebody was saying it's the brain, it's the beta cell, it's the liver, it's the genes, it's the fat cell. Everybody was trying to, find out a way to just label diabetes as something for which they can find a solution. The therapeutic advances in diabetes have now given us more than 40 new treatment options in the very last decade. Starting from 2005, when we started getting DPP-4 inhibitors, in fact in 2000, we started getting DPP-4 inhibitors, we started getting SGLT2 inhibitors, we started getting GLP-1 receptor RAs. We started to have a cascade of things by which we could treat diabetes. But despite that availability of numerous treatments, diabetes still is the 9th major cause of death globally. It is leading to more than 50% people developing microvascular complications, 25% developing macrovascular complications. 1 out of 4 patients in diabetes is having CKD. In our country, maybe more so. Every second person in India who's getting a dialysis is a diabetic. You go to any dialysis center, you ask them whether you've got diabetes, they'll say yes, we have. Every second person. But we all know that if you treat diabetes in the very first year and are able to bring down the HbA1c by a mere 1%, you can bring down the cardiovascular risk, the risk of myocardial infarction by 20% and the all-risk mortality by 19%. If you don't do that, the same risk, which was actually lessened and mitigated by 20%, will come back to 7%. And that's a very big loss because the risk which was mitigating earlier, it is not getting mitigated now. And the all-cause mortality, which was earlier being mitigated by 19%, is getting only mitigated by 3%. So very first year of diabetes, you don't mitigate, you don't lessen the HbA1c by a mere 1%, and this is what you get. This is metabolic memory. And everybody knows that despite the modern evidence-based therapy, people are still having heart attacks, people are still dying, people are still having problems with their eyesight, people are still having diabetic neuropathy. So why? You have done the best, you have got 40 new medicines in the pipeline, in the market, maybe 20, 30 more in the pipeline, and still your patients are not faring well. Diabetes, of course, we all know is a leading cause of kidney failure. More than 40% of patients with diabetes will develop CKD. And you can look at this graph, you look at the black rope, the black string, and you see that this is diabetes. Whereas you see the orange one, it is hypertension, and the purple one, which is glomerulonephritis. And many of us, when we see glomerulonephritis, we start fearing कि अब तो patient गया. Now the patient is going to develop CKD. But so many years the patient is with us with diabetes and we never look at him as a renal patient. We don't look at him as a cardiac patient. Whereas our view should be that the very first time that the patient is coming to us, he should be viewed as a renal patient, as a cardiac patient, as a patient who's going to have probably amputation because of peripheral neuropathy. And the moment we don't sensitize ourselves to that kind of a viewpoint, it's difficult for us to treat. Diabetic kidney disease shortens the lifespan by 16 years. This is a clear-cut message that comes after a study which was done in China by Wang et al. In 2017, when they did a survey on patients who were non-diabetic and diabetics. So if a clear-cut reason, if your patient comes and asks you that if I'm having diabetes, what are the chances that I'm going to have less number of years in my life, you're going to say, simply, there was a study which was done and it clearly showed that 16 years are going to get lessened in your life. So the world is changing as we talk. We are changing from biochemistry to molecular biology to genetic science. We are changing from population to ethnicity to individual. We are no longer looking at spot blood glucose. We are also not looking at HbA1c. We are more looking towards, glycemic variability. We are looking at time in range. We are looking from drugs to therapies to precision medicine. We are looking from pharmacokinetics to pharmacogenomics. Now, what is that? See, looking ahead, type 1 diabetes and type 2 diabetes are not going to be labeled as only type 1 diabetes and type 2 diabetes. They are going to be endotypes of type 1 diabetes and type 2 diabetes. Already we know that patients who are in type 1 diabetes, because they are living longer, they start developing type 2 diabetes in the later years of their life. So you say type 2 diabetes overlapping on type 1 diabetes. So there is an overlap syndrome which is happening. If the patient who's been treated for type 1 diabetes for 30 years, he crosses the age group of 40 years, 40 to 45 years, he started developing features of type 2 diabetes also. So the patient who was not responding to insulin earlier starts to respond to OHAs as well. And then the reason behind it, the explanation that you give behind it is that earlier this patient was only a patient of type 1 diabetes. Now he has started developing features of type 2 diabetes, and that's why OHAs have started working for this patient as well. So that is T2 overlap on T1. And many patients who have got genome sequencing in their records, they are now going to be endotype specific, ancestry specific, lifestyle specific, and a new generation of therapeutics is going to come into our way, which is going to be emerging technology for an individual. This is pharmacogenomics, by the way. You choose an individual, you know the genomics of the individual, and then you ask the patient that whether the medicine that is being given to you, it is toxic, beneficial. If the drug is toxic but beneficial, you don't give. If the drug is toxic but not beneficial, there is no point in giving. Only the drug, when it is not toxic but beneficial, it will be given. And there is going to be a time that genetics is going to decide, artificial intelligence is going to decide what kind of drug you are actually going to give to the patient based on the genomic sequence of the patient. And already the GWAS program is going on in US, which is Genome-Wide Association program, in which every individual can go and they can give their blood sample, give a simple signature, and then their genome is going to be sequenced, and their entire ethnicity, their entire ancestry is going to get labeled as per the requirement. As for the future, our task is not to foresee it, but just to enable it. Weight regulation is not a separate program from diabetes management, and personalized precision medicine for obesity and type 2 diabetes is now becoming a reality. So you have got GLP and GIPs which are working for some patients. You are having GLP-1 and glucagon which is working for some patients. You have got GLP-1 and dexamethasone. Now this is very strange. Dexamethasone for diabetes. You are giving dexamethasone as a therapy for diabetes. Why you are giving it? You are giving it because in the very early years you know that it is autoimmune diabetes. Because of the autoimmunity, the beta cells of Langerhans are undergoing apoptosis. If you know beforehand by the genetics of an individual that some kind of individuals are going to have some kind of apoptosis of the beta cell of Langerhans purely because it is going to be autoimmune phenomenon, you give dexamethasone and the patient is going to get better in diabetes. Now that's the beauty of it. That beforehand we are going to come to know about the sequences because of which diabetes is going to happen to an individual. And if we are going to enter into a phase in which diabetes is going to be not reverted but averted, we are talking about diabetes reversal programs. This is diabetes reversal program. Diabetes is not going to happen because you identified the individual's genetic sequence and you came to understand that it is autoimmune type diabetes that is going to happen to this individual in years to come. Let's give him GLP-1 and dexamethasone and he is going to respond wonderfully. And this is also happening with patients who are having hypothyroidism, and hypothyroidism, because of the nature of hormonal imbalances, patients are having some kind of a cascade events that is leading to diabetes. You give them glucagon and T3 and these patients revert, not revert but avert. They don't develop diabetes in the times to come. And tripeptide, we all know that nowadays is the time when we are talking about GLP-1 receptor analogs, GIP-1 receptor analogs, and also glucagon agonists. So All of these three together have the propensity, have the capacity to bring down the weight of an individual by 25 kgs to 22 to 25 kgs in a matter of just 3 to 6 months. So now you can run the slides. After this little primer that I wanted to give about the situation and the presence and the standing of diabetes today, this is not my slide. I'd like to take another just 10 more minutes for insulin therapy in diabetes, which I believe that everybody already understands quite nicely, but just as a refresher, we are going to take it up. Yeah, thanks. Can I run it from my end? No? I can? Thank you. So this is the treatment of diabetes. Diabetes and CKD, why it is a double whammy. We know that when there is diabetes, there is more hypoglycemia. We also know that there are more incidences of severe hypoglycemia. These are the KidGo guidelines. When you look at a patient of diabetes, you are not just looking at one aspect of diabetes. You are not just looking at HbA1cs. You are also looking at how bad the kidney is. You also want to know that whether the other macrovascular complications are taking the toll on the patient. What are the comorbidities by which the patient is getting affected? What is the life expectancy? The patient is already going to have a very short life expectancy. We all know when the kidneys have already gone bad. And hypoglycemia awareness, whether it exists or not, many patients come to us, they have got sugars less than 60, 50, they don't even know about it. Sometimes the patients are being assisted because they are having loss of consciousness. They never told any of their attendants that what is exactly happening to it. The resources for hypoglycemia management are also very scarce in many of the countries, especially in a scarce country like us. We do not have push notifications for our patients. We do not have 911 in our country. We do not have any kind of a push button by which patients are going to be immediately being attended by paramedical staff. And the propensity of the treatment to cause hypoglycemia is also very important. Unmindfully, many of us are prescribing sulfonylureas to our patients, not realizing that the half-life of sulfonylurea is much worse than the half-life of insulin. So why not insulin in patients of diabetes? This is the kidney heart risk management factorial that has been given by KidGo. SGLT2 inhibitors, of course, top of the chart, because not only they are having an effect on the glycemic control of diabetes, but they are also having an effect on the trajectory, on the progression of diabetes. And that's why so many studies after EMPA kidney study, we know that not only in patients of diabetes, SGLT2 inhibitors as a class of medicines are also effective in other ailments of kidneys as well. And RAS inhibition, we all know, it's very much required. Statins, glucagon-like peptides, non-steroidal, mineralocorticoid receptor agonist, the new entry Finerenone into this picture, forming another pillar of support after RAS inhibition, after glycemic control, non-steroidal and SGLT2 inhibitors, non-steroidal MRAs are also a very important effective tool that we have in an armamentarium. But of course, we want to use them only in patients who have got albuminuria. Just don't be guided by serum creatinine for non-steroidal mineralocorticoid receptor analogs. Look at albuminuria as well, and that's why the importance and the emphasis of getting a urine ACR for our patients done cannot be overemphasized. Sometimes we get a lot of, we get happy with whether when we see that the creatinine of the patient is fine, and we do not want to change that creatinine to eGFR values. Though there has been a paradigm shift in the laboratories also, now they have started giving eGFR values also for the patients. Though I don't understand that how do they get to know it, because they never ask the weight of the patient, they never ask many of the questions that are required for the formula, but then they give eGFRs. Well, having a simple formula on our phone is probably a better mechanism. So two very important tests that we should never let our patients ever go away from is actually serum creatinine translated into EGFR and secondly urine ACR. If these two tests are done, I think so, as physicians we have done our job and we can take things forward from there. KIDGO also talks about the therapies in addition to SGLT2 inhibitors to choose from. They talk about GLP-1 receptor analogs, DPP-4 inhibitors, insulin, sulfonylureas, probably in that particular manner. Insulin still exists, it's still there, it's very natural, it can be used. One very important question that keeps on popping in everybody's mind is that do we use insulin and in its conventional form or do we use analogs? Well, there is nothing against analogs. Let us clear that. So if you are using basal insulin or if you are using rapid acting insulin, whichever kind of insulins you are using, probably you will have to bring down the dose of the insulin, but analogs are nowhere not prescribed. Analogs will be prescribed, should be prescribed, can be prescribed. And evidence with insulin analogs is absolutely wonderful. If you compare them with the baseline, they bring down the HbA1c better than the NPH, and the number of nocturnal hypoglycemia episodes that a person encounters with insulin analogs is much lesser than the conventional insulin, especially NPH. Insulin glargine in type 2 diabetes also, it's changing in glycemic parameters, it is changing HbA1c, but the important thing is that the number of hypoglycemic episodes is reduced. Some people think 1 episode, 2 episodes of hypoglycemia, it's a training for the patients, what's the loss in that? Well, that episode can be a stroke, episode can turn into a nightmare because of the LOC getting continued over the night. That episode can turn into some kind of an injury to the patient. Imagine a patient having a hypoglycemic attack in the bathroom and hitting the head, having a head injury. So hypoglycemic episodes should not be only construed as episodes in which sugar has gone down. Look at them as an episode of a potential injury to the patient. Injury to the brain, injury to what? Myocardial infarctions also, by the way. If you have got many episodes of hypoglycemia, chances of myocardial infarctions also increase. This is the efficacy and safety of insulin glargine. I don't want to go into it because the conclusion is very simple. Insulin glargine has improved HbA1c and has been safe and well tolerated for patients with diabetic nephropathy. And in overt nephropathy, type 2 diabetes, Lispro also prevents glomerular hyperfiltration, offsets the renal effects of meal and meal-associated mechanisms of hyperglycemia. Now, if you have a patient, this is an elderly patient, very intelligently chosen by the people who have made these slides, 63-year-old man, 80 kgs, BMI 27, type 2 diabetes for 16 years, on linagliptin, glimepiride, metformin, glycemic control gone haywire, now starting to have an EGFR of 31. This patient comes to you for the first time in life, being treated by some other doctor. Your job would be to think about the fact that if you are going to leave this patient on a glimepiride dose, the chances of hypoglycemia are going to be super high. And that's why to get the glycemia under control, we have to make the patient first of all safe. Leaving the patient on a glimepiride dose of even 2 mg is a catastrophic scenario because the EGFR has gone super low, it is 31. So in dosing and titration of insulin in CKD, if the EGFR is less than 30, you do give multiple doses of rapid acting insulin analogs, and in such situations avoid basal insulin. Don't give basal insulin. Go from meal to meal. Teach the patient. Ask your diabetes nurse to teach the patient. It's important because empowering the patient. Doctors can't be everywhere. Ultimately, it's all about empowerment. If you are not empowering your patient, you are doing something which is going to cost you later. If you are going to teach the patient what needs to be done, if you tell them that the ball is in your court, take it from here, I am going to teach you everything and you should understand the logic while I am doing this, believe me, your patient is going to listen to you, the patient is going to abide by you. If the EGFR is above 30 and hovering somewhere above 30, we can say just above 30, at that point of time, 2-3 injections of insulin analogs along with basal insulin are recommended. But don't give basal insulin if the patient is having an EGFR below 30. It's again venturing into a difficult terrain. So this is the case management. They started with the patient and they stopped glimepiride and metformin, the right thing to do. Some scientific houses say that if the metformin is being there on the patient's prescription, just keep on continuing it. But they are silent about EGFR below 30 again. So many say that, okay, if the patient is entering into a stage of CKD3 or CKD4, probably that's the time that metformin should be thought about. But if patient is already taking metformin, might as well just continue it. But then again, they are also silent about a situation when EGFR has already gone below 30. So please, if EGFR has gone below 30, I think it's recommended that metformin, and of course sulfonylureas are of course off the charts, but metformin should also be given a thoughtful process. SGLT2 inhibitors will not be considered. Like I said, the people who made these slides are very intelligent. They made fever and UTI already a part of it. Otherwise, of course, SGLT2 inhibitor could have been there, and insulin was initiated, and they started with a basal bolus, with basal being very less. And another thing is that some of the better insulin analogues which are available, they have got half unit dosing also. Sometimes these half unit dosing are very good for patients, especially who are renally compromised. How many of us have actually used it, it's a question of survey, but yes, many of the colleagues that I have heard, they say that half unit dosing is also recommended for some of the patients as a titration. With that, I would just like to conclude that we should not forget that insulin therapy for glycemic control in patients with diabetes and renal problems is something that we all should be accommodated to, all should be comfortable with, and insulin type dose administration should be tailored. Don't use basal insulin in patients who have got eGFR very low. Use basal bolus only for patients whose GFR is more than 30. Give multiple dose injections, empower your patients, always tell them, bring them on the table and discuss with them that what are their possibilities. In that regard, insulin lispro in type 2 diabetes and nephropathy, it does prevent glomerular hyperfiltration and reduction in renal effects and meal-associated hyperglycemia. And higher is the patient's stage of CKD, more are the chances of hypoglycemia, and that should always be on our consideration. Thank you so much.
Thank you, Dr. Anish, for excellent presentation. I think you very comprehensively covered almost all aspects, actually, starting right from the fundamentals of diabetic kidney disease and then management part, and the importance of insulin analogs, actually, and the risk associated with the actually increased risk of hypoglycemia. So you have to be very, very, actually, I think, careful while managing diabetic kidney disease, risk of hypoglycemia, correct choice of the therapy, whether even if you have to give multiple injections, I think this should be preferred. And basal actually use has to be very, very cautious. And regarding the severity of the diabetes associated diseases, and especially kidney, is very, very high. You have said the more than 40% of the diabetic patient develop kidney disease. So I think it's a very, very important, I think, the insulin therapy and especially analogs. So any questions from audience or any comments from? Yes, sir.
While using premix insulin in these patients?
So, sir, premixes, they don't give us flexibility of use because premixes are coming already in a set pattern, 25-75 or 30-70. And in that, 70% insulin is already long-acting insulin. And these patients probably, they are living meal to meal. Sometimes they don't eat better, sometimes they are skipping their meals, sometimes they are having nausea and vomiting, which is associated with the entire carbohydrate load getting vomited out. So it's better always to go for plain insulins, conventional insulins, or lispro type analogs for the management.
No, the reason that I ask is because, if you give prandial insulins, you have to give 3 to 4 injections before every meal. Most of the patients deny that or, not willing for that. So in that case, and basal is something that we want to avoid. So
Sir, that's a very good question, and that's a real world scenario and a very, very practical situation. In this kind of situation, what we do is that we do not ask the patient to take multiple dose injections. We just ask them that please tell us what is the, which are the 2 large meals that you are taking. Because most of these patients, they are not taking 3 or 4 meals in a day. They are not, so if they are able to tell us, okay, this is the 2 large meals that I am taking, we try to keep our insulin dosage at that particular time only, so that we can at least cover that prandial part. And of course, if the patient is having a eGFR more than 30, then of course basal insulin is also there, which is constitutionally covering the control of glucose over the day.
Thank you.
Thank you, Anish. Ravinder ने मेरा question चुरा लिया. This was the question I was asking. So thank you for a wonderful talk. And this session is now. Yes.
Dr. Anish, I think it's a very wonderful talk, and you have covered, as Dr. Mehra said, all the aspects of insulin in CKD. right? We all know that in CKD now the GLP-1 receptor agonist is a part, right? So suppose the patient requires insulin, possibly we start basal insulin at the very go, because sometimes Dr. Makkar said sometimes basal bolus sometimes not feasible for them, right? So now we have the combination therapy is also available, but GLP-1 with basal insulin. So how you rate this combination therapy in patient in CKD?
So there is one combination that we have, which is Iglar-Lixi, which is Soliqua, which has come from the house of Sanofi. It is a combination which has got, in that combination for every unit of glargine, we are providing 0.5 unit of lixinoside. Problem is that GLP-1 receptor analogs, they actually increase nausea and vomiting on a much higher propensity in CKD patients because they are already having uremia and uremic gastritis is there, and these patients, they are already having they are very low on appetite. They're already very low on appetite. If they're so much low on appetite and on top of that we add some kind of a GLP-1 receptor analog, then their appetite, further gets mitigated. In that kind of a situation, we don't want to we don't want to get pushed against the wall that the patient stops eating altogether. The intake goes very bad. So I would try to peg the use of these kinds of molecules, especially Iglar-Lixi, which is Soliqua, to a EGFR level of more than 60. I would not like to use them below 60.
Dr. Anish, so according to you, then in patient of CKD, we should not use GLP-1 RA?
No, sir, that's not what I am saying. I am saying that the patients of CKD who have already developed uremic gastritis, who are already having nausea, vomiting, who have already lost their appetite, who are already losing weight, those kinds of patients should be spared from use of GLP, because we have got a very good armamentarium of drugs already available.
Yes.
We don't have to fit the drug accordingly to the patient.
Dr. Anish, I have only one comment to make regarding that Iglar-Lixi. See, in a patient of CKD, on one hand we even try to adjust half unit of insulin. On the other hand, with half unit of insulin, we are giving a funny dose of lixinoside. I don't think it makes any sense.
Yes.
In a patient of CKD, let us be very honest.
Yes.
Let us give basal insulin and give a small bolus as per his major meal. And this product to me looks very funny for a CKD patient, if you agree.
I agree with you, sir. Always.
Thank you, Anish. Thank you very much. And we close this session and hand it over to organizers. Thank you very much.
I would request the dignitaries to proceed towards the felicitation area, and I would request Dr. N.K. Govil sir to felicitate the dignitaries. For our next session, I would like to invite our chairpersons, Dr. L.K. Jha, Dr. Lavi Gaur, Dr. Anil Mota, and Dr. Amit Gupta on the stage, please.
I think we are towards the end of the session and we have got a wonderful talk. And I would request Dr. Manish Malik to be here for the talk. As you all know, Manish is a wonderful speaker and a highly academic oriented person who is the vice chairperson of the Department of Nephrology at Sir Gangaram. He has a lot of achievements and award, and to tell you honestly, I'm sure you can read it over there. The most striking award is the award that he won from the World Brotherhood Organization. And that was for his contribution to society. And that is the beauty of the person that I am inviting. So I request Dr. Manish to talk about Finerenone, a new treatment pillar for the cardiorenal benefits in CKD and type 2 diabetes. Please.
Thank you so much. Thank you, sir, for those kind words. And I have my teacher and mentor, Dr. Khullar, sitting here. So that gives me more pleasure here, sitting here. So can we have my slides, please? all the speakers before me got 30-40 minutes. I just have 20 minutes. I don't know why this is bias against me, but any which ways, I'll try to finish in 20 minutes. So the topic of my talk is Finerenone, a new treatment pillar for cardiorenal benefits in CKD and type 2 diabetes. This is a prototype patient, Mr. Raj, who all nephrologists know, because they probably have been using these slides in their talks. But so this is a general prototype diabetic we all see, 57-year-old, 10 years of diabetes, A1C of 7.4, and an office BP of 138/84. And like all others, Mr. Raj wants to say healthy forever, but the treating physician is concerned about his kidney health. And why is that? As the previous speakers were discussing, that in India, 74 million diabetics, this is 2021 database, now probably we have 100 million diabetics, and out of these 74 million, half of them are CKD. So the disease burden of CKD in India is very, very high. And why is CKD important in diabetes? Because CKD by itself increases the risk of cardiovascular mortality. So if you look at these slides, if you have diabetes alone, then the risk of cardiovascular mortality is twice. If you have CKD alone, it is 3 times of general population. And if you have diabetes and CKD both, then the mortality because of cardiovascular causes is as high as 19%, or 6 times of the general population for that age. So this gentleman got his creatinine and EGFR done, and he was found to have an EGFR of 60. I don't have a pointer here, but you see that he is now being labeled as CKD stage G2, which is on the KDIGO risk map in the green. This KDIGO risk map is very interesting, as I will tell you, but in some time. So now this patient has some CKD, so the treatment now the patient is on is telmisartan with diuretics, and of course DAPA has been added, as should be added for all CKD diabetic patients. As I was telling you, this KDIGO risk map is very, very interesting. This tells you the risk of progression of CKD. This tells you the risk of cardiovascular mortality. And since it has been designed by nephrologists, it also tells you when to refer a patient to a nephrologist. So if the patient sits on the green or the yellow, then the physician can treat them. But if the patient sits in orange or red, then the risk of progression of CKD is high, risk of mortality is high, and the patient should be referred to a nephrologist, and definitely follow-up has to be much more frequent. And how do you put the patients on this risk map? You use the GFR and the albuminuria. So for that prototype patient, using only the GFR to put him or her on that G2 stage was not a good idea. So as I said, CKD is defined by the presence of albuminuria more than 30, or a reduced kidney function less than 60, and you need to do both of these to place the patient on this risk map. So you need to do the eGFR and the UACR annually at least in all patients with type 2 diabetes. So my teacher, Dr. Khullar, is here. My student, Lavi, is there. So what an interesting place I am in. You can all imagine. Anyway, so all the guidelines, ADA, KDIGO, all of these recommend that both eGFR and UACR should be done to properly identify, stage and monitor CKD in patients with type 2 diabetes, as eGFR alone may miss the earlier stages of CKD. And it is recommended that either use a dipstick method or a urine sample, spot sample to the UACR. Over a 6-month period, do 3 tests, and if 2 are positive, then it is a high UACR. 24-hour collection is not required. A spot sample is recommended, and an early morning first sample is recommended. Why? Because when you are walking around in the morning, daytime, your UACR may change. It is lesser when you lie down, it is higher when you stand up. So nowadays it's recommended to take a first morning sample, which nullifies all these issues. And of course, no exercise, no infection, no fever, no CHF, controlled diabetes, controlled BP, no menstruation. It is only then when you take these samples for UACR. So this gentleman, his UACR should have been done, and when it was done, he was found to have a UACR of 352, which is A3. So this patient immediately moved from green to yellow to orange. So this patient now has become a moderately or high risk patient actually for CKD progression, for CV mortality, and of course probably referral to a nephrologist also. And why is USCR important? We normally say that the 30 USR is so-called normal or near normal, but even at this 30 USCR, there's a 2 times higher all-cause mortality and a 2 times higher CV mortality. So even a USCR of 30 makes double the risk of mortality, whereas GFR is not that important, because even at a GFR of 75, which is so-called less than the normal of 90, and even at a GFR of 60, the mortality is not much. Only when the GFR comes down to 45 that the mortality because of CV causes increases. So the albuminuria is much more important for CKD classification. And we all know that CKD and CVD progression in diabetes is because of 3 factors: metabolic, which is poor glycemic control; hemodynamic, which is elevated BP or intraglomerular pressure; and of course inflammation and fibrosis. And all these then contribute both to CKD progression and CVD progression. And that is where the talk now goes on to, that the inflammation and fibrosis is associated with what we call mineralocorticoid receptor overactivation through multiple mechanisms. This could either be ligand dependent because of aldosterone, we all know. This is also ligand dependent because of cortisol. And the problem is that the cortisol inactivation occurs in all cells, but not in the kidney cells and the cardiac myocytes. So in the kidney cells and the cardiac myocytes, cortisol in addition to aldosterone will cause receptor activation. This also happens because of oxidative stress and because of high albuminuria, and all this leads to cardiac and renal fibrosis. And the current therapies, whether RAS inhibitors or the gliflozins, our DAPAs and MPAs, do not address this primary target for fibrosis. And that is why we talk of this drug, which is called Finerenone, which targets the mineralocorticoid overactivation and slows the heart and disease progression in patients with diabetes. We all know that hyperglycemia, high salt load, and oxidative stress overactivate this receptor, and Finerenone blocks this receptor, so it suppresses inflammation, suppresses hemodynamic factors, and along with suppression of metabolic factors, you have heart and kidney protection with this class of drugs. We all are aware of the aldosterone antagonists used in the past, which was spironolactone and then eplerenone. The problem with those is that they cause hyperkalemia. So the usage was limited to either congestive cardiac failure or resistant hypertension, but not to CKD progression. So then they tried to design a drug which would block this receptor but not cause the side effect of hyperkalemia or the gynecomastia. So they came to this drug called Finerenone, which is a bulky non-steroidal MRA blocker, and it is more selective against the mineralocorticoid receptor, but it has a very short half-life, 2 to 3 hours. In contrast, spironolactone has many metabolites which are active, so they keep acting for 20 hours. So this drug, because of a shorter half-life, has lower risk of hyperkalemia, and because of the higher selectivity, has lesser risk of breast-related side effects. So to study this drug, they designed these 2 trials. One was the Fidelio DKD and one was the Figaro DKD. This slide emphasizes that the total number of patients who were studied in Finerenone trial were more than 13,000. This contrasts only to 1,500 patients for the Renal trial for losartan, only 4,000 patients for the Credence trial. Even our latest EMPA kidney trial had only 6,000 patients. So the point to be emphasized is that this was a robust investigation. So this was the trial. The difference between Figaro and Fidelio was that the Figaro was primarily a cardiovascular endpoint trial, and Fidelio was primarily a kidney failure endpoint trial. The drug dosing was 10 or 20 milligram per day, 10 milligram for patients with GFR less than 60 and 20 for GFR of more than 60. Now this is the KDIGO risk map in which we come back to again. And here we see the Fidelio DKD represents the late stage CKD patients who had higher albuminuria and lesser GFRs, and the Figaro DKD was the early stage CKD patients. And the reason behind this design was that they wanted that did Finerenone had cardiac protection even in early stages of diabetic CKD. So even with lesser albuminuria, Figaro DKD showed that even though renal protection may not have been there, but cardiac protection was there. Rather, I was listening to Dr. Rajiv Agarwal's lecture, who is the prime investigator in this trial. He came to our hospital yesterday, and he says that aspirin was invented in 1897, and this is the new aspirin for the heart, which has come after almost 1 century. Is it 1 century? Yes, I think so. Yes, more than that. More than that. So then they compiled the data of Figaro and Fidelio, and then they had this Fidelity, which is the complete set of these patients. If you were to see the EMPA patients or the DAPA patients, this trial covers much more than that. So you had a very, very wide spectrum of these patients. And these were the composite outcomes in Fidelity. The CV composite outcomes were time to CV death, non-fatal MI, non-fatal stroke, or hospitalized heart failure. And for the kidney endpoints were time to kidney failure, or a sustained 57% decrease in eGFR from baseline, or a cause of death was renal. It is interesting that HIF-PH was not a part of this study. So this was more of a preventive trial for the heart, not the therapeutic trial. In HIF-PH, you have a drug which is spironolactone. So this was more of a preventive study for the heart, not a therapeutic study for the heart. So this was the average patient, a 65-year-old average patient, diabetic 15 years, A1C 7.7, a BP of 137 by 76, a CV disease in 46%, and a history of heart failure 7.7%. So this is a good-looking mean patient, a good HbA1c, a good BP. But even in this set of patients, let's see what the drug said. And of course, 100% patients were on RAS blockade, but only 7% were on SGLT2 inhibitors. So this is what the study shows, that if in the placebo, the risk of kidney outcomes was 7%, in Finerenone it was only 5.5%. So the risk of ESKD was 20% less in the Finerenone group as compared to the placebo group, and the numbers need to treat was 60. This is the heart outcomes. So if the risk of cardiac issues was 14.4% placebo, it was only 12.7% Finerenone. So there was approximately a composite 14% prevention in the CV outcomes, and there was a 22% protection against hospitalization for heart failure, which has been emphasized with that red graph. So Finerenone demonstrated significant on-treatment reduction in the incidence of all-cause and CV mortality versus placebo, and lowered the risk of sudden cardiac death in the intent to treat population. This is what the nephrologists interested in, that at 4 months, there was a 32% reduction in UACR from baseline, which was maintained over the 4-year period. Why is UACR important? Albumin in the urine is a surrogate marker for endothelial dysfunction. So that is why albumin in the urine is not a kidney disease, it is endothelial disease. It's the brain and the heart also. So in Fidelity, Finerenone improved UACR in patients with CKD and type 2 diabetes, irrespective of SGLT use at baseline. So without SGLT2 inhibitors, there was a 31% reduction in UACR, and the 7% patients who had SGLT2 inhibitors, there was a 37% reduction. So this drug had independent reduction as of the gliflozins. So patients in clinical practice, which we all come across, have complex comorbidities or co-medications. How does this affect Finerenone use? So what if my patient has a high HbA1c, has a long-standing diabetes, is obese, is elderly, is on other drugs for the kidney like SGLT2 and GLP-1RA, and of course does have ASCVD. Finerenone has shown a consistent CV and kidney benefit across spectrum of type 2 diabetes and CKD, irrespective of comorbidities and co-medications. Finerenone also shows a modest decrease in systolic blood pressure of 3.7 millimeters. The sexual side effects like breast hyperplasia and gynecomastia, as I mentioned, were no different from placebo. The issue of hyperkalemia has been raised. The risk of hyperkalemia with Finerenone was 14% as compared to 6.9% in placebo, but hyperkalemia leading to permanent discontinuation was only 1.7%, and there was no difference in AKI between the groups. So after listening to all this, what are the takeaways? The simple takeaways were designed again by the investigators by the rule of 5, the 5 5s. So if your potassium is less than 5, you can start this drug. If your potassium is more than 5.5, you should stop this drug. You can initiate if the GFR is more than 25, but then the dose is 10 milligram per day. If the GFR is more than 60, then the dose starting is 20 milligram per day, and treatment can be continued up till a GFR of 15. Finerenone reduce the risk of ESKD by 1/5 and reduce the risk of heart failure again by 1/5. So this is the 5 fives of the treatment of Finerenone. So Finerenone is approved in India with the same indications as by US FDA. It is indicated in adult patients with CKD, with diabetes, reduce the risk of sustained eGFR decline, end-stage kidney disease, cardiovascular death, non-fatal myocardial infarction, and hospitalization for heart failure. There's a trial called FIND CKD, which is assessing Finerenone in the non-diabetic CKD. So those data must come out soon. And the guidelines have included Finerenone in diabetic CKD patients, whether you have the KDIGO guidelines or the ADA guidelines. The level of recommendation may differ, but Finerenone is now the third pillar of diabetic CKD management. The fourth pillar is now also in place, which is the GLP-1 RA after the FLOW trial. So now you have 4 pillars of diabetic CKD management over and above lifestyle modification and dietary education, which are RAS blockade, SGLT2 inhibitors, Finerenone, and the GLP-1 receptor antagonist. The key points, takeaway points, are that individuals with diabetes are 10-fold more likely to progress to ESRD than those with diabetes. Early stage CKD management is often missed. However, if managed properly, its progression can be slowed or halted. MR overactivation, which contributes to inflammation and fibrosis, is a potential treatment target to slow CKD progression. Despite RAS blockade and SGLT2 inhibitor, patients are at risk of CKD progression. Finerenone, a novel non-steroidal selective MRA, blocks mineralocorticoid receptor overactivation and is different from available steroidal MRAs. And Finerenone has shown consistent CV and kidney benefits across a spectrum of type 2 diabetes and CKD patients, irrespective of comorbidity and co-medications. I thank you all for a patient listening.
Excellent talk.
Thank you, sir.
Dr. Manish. And this is described all the, predominantly the first, like ACE and ARB had been there for almost 25, 30 years plus now. And later on came SGLT, which is also there with us for about 10, 15 years. Finerenone had been recent, not a very old that way drug, which has been used in diabetic CKD, the third pillar which you told. And the fourth pillar is now just getting approved and it started being used by us. So with all these, we have seen that the progression of renal disease, specifically in diabetic CKD, we can slow it down for few weeks to months to sometimes years and decades also probably. So that we have to see whether this third and the fourth pillar, how they're going to work in over the years. So it was an excellent talk. Any comments from the audience and Dr. Kulas? Yeah.
Question. You know, diabetic kidney disease, eGFR of 30, sorry, albuminuria 30 से ऊपर है तो आप दोगे. There are patients who have eGFR of 40 or 30 and albuminuria is let's say between 20 and 30. I mean, to my mind, pathological process is same. And you said Finerenone is the new aspirin for cardiovascular system. I think Finerenone is also aspirin for the glomerular system because it's the same vascular bed and they have a crosstalk. What is your take on such patients? I know there's no data to suggest that, but what is your take on that?
So I mentioned aspirin for cardiovascular patient. Why? Because the mean UACR was in the 50s for the cardiac subset of patients, where the mean UACR was 500 for the renal subset of patients in these trials. And it was found that even with lesser degree of albuminuria, this drug had a beneficial effect on the cardiovascular mortality. To add to it, in the EMPA kidney trial, the mean UACR was again in the 50s, but you had a renal protection. So as Dr. Jha said, that our armamentarium is increasing. We probably now have 4 aspirins in place for the heart and the kidney, I would say. And the aspirin is probably not the aspirin for the heart now. It is not to be used as a preventive drug, but it is probably for the therapeutic or tertiary prevention. But in secondary prevention, now you have 4 pillars other than aspirin, both for the heart and the kidney. And as you mentioned, the bed is the same, so that even the drugs are the same, because the entire issue is the endothelium and nothing else. Dr. Khullar, sir.
Yeah, excellent talk, Manish.
Thank you, sir.
As always. So few comments and then a question to you.
Only comments, no
Dr.
questions, sir.
So I think that's a very pertinent question which you have raised. And I will, of course, Manish, you've been referring to aspirin. There has been some controversy revolving around aspirin as well. So rather than, I think we should put our faith more in statins rather than, but that's on a different thought process. But when it comes to albuminuria, as you can see, we as nephrologists are all the time bothered, concerned about reduction in albuminuria. And we have done away with few of the terminologies which were very confusing. I personally would not want to use the term microalbuminuria or macroalbuminuria. We have replaced it with moderately increased albuminuria and severely increased albuminuria. So point well taken that there is no doubt and confusion when it comes to albuminuria more than 30. There are trials which like Fidelio. The difference between Fidelio and Figro was Fidelio had patients with more advanced CKD, but Figro had patients with less and wider spectrum. The heart was the primary composite endpoint for Fidelio for these kind of patients because there is an endothelial dysfunction. The point I'm raising, which is very, very pertinent for all of us here to remember is, we do not call even 30 albuminuria as normal.
No.
So the normal albuminuria according to the new guidelines is less than 10. That is something which we have to remember. So what is between 10 and 30, 11 and 30? It is high normal. So which means we are viewing even 11 to 30 with some kind of suspicion. Now KDIGO says, and that's a very interesting read when you go through the recent KDIGO 2024 guidelines on CKD, they say only those who have albuminuria of less than 10 are protected. You can't say the same about people with more than 10. The other spectrum, GFR of more than 105, view it with suspicion, because in diabetics, this is hyperfiltration, they could be in trouble. And especially if they now have albuminuria, it is bad time for them. So I think I would personally want to give importance even to the way you suggested. It is the endothelial dysfunction first. It is the mesangial hypertrophy first before it turns out to mesangial expansion and sclerosis, and then we know it's too late. Which you will be quite surprised to see the kind of pathology you can see even when the proteinuria is not too much. So yes, short of biopsy, you would certainly want to bring down the albuminuria to as low as possible. The question for you, Manish, is, I'll not spare you, you've done such a fantastic job. We, as you were saying, we're all the time talking about the role played by SGLT2 inhibitors. AMPA kidney had a small subset where there was no albuminuria. So we have answer to your question as well via AMPA kidney, where they had a patient between no albuminuria, GFR 20 to 45. So and there also, again, it was found to be useful. Now, we have talked about RAS blockers, we have talked about SGLT2 inhibitors, you have shown a beautiful data on Finerenone. Now, my question to you is, we are targeting mineralocorticoid receptor antagonists. And the problem here is the two phenomena which we always remembered in the context of Conn syndrome, the aldosterone escape, and now you also are viewing aldosterone breakthrough. Now, my question to you is, aldosterone has its effect even via non-MRA pathway. So what happens is supposing you are blocking mineralocorticoid receptor there at the level of the kidney, and you are now causing accumulation of aldosterone, you are giving it a chance to have its action via so many other pathways as well. Do you think there is data that it has not happened in the real world for quite some time? If that is the case, would you want to repose your faith in directly inhibiting aldosterone synthesis? Because the next molecule is going to be the aldosterone synthetase inhibitors, which is going to block aldosterone. They are specific now because the previous ones were also blocking cortisol and they were not welcome. And now you have very specific aldosterone synthetase inhibitors like baxdrostat and others, which could be the game changers. And whatever shortcomings we are seeing, or maybe we can expect with mineralocortical receptor antagonists, that's Finerenone, and a whole lot of other, Canrenone and whole many others, possibly may not be seen with aldosterone synthase inhibitors.
So I second your point. The whole research has been on filling those gaps. So probably the last gap probably which you have mentioned, or maybe the last gap will be filled by the drugs you have mentioned. But then there's never a last gap filler here. People thought that RAS blockade was the it thing. Then they found a huge gap of patients not protected. So I think it's all an evolving field, and nobody has the final answer to it.
Gap is there, Manish. What is going to happen with aldosterone inhibitors is the angiotensin 2 will be unprotected. So angiotensin 2 will then have some possibility. So I think we are going to get fascinated by our knowledge of physiology, and now the time has come where we are now evolving via what we have learned in our physiology classes. Once again, a beautiful job.
But the takeaway point is that cost or side effects should prevent us from using a wonderful drug. Hyperkalemia is manageable by diet modification and by the newer potassium binder which should be coming in some time. Cost of dialysis is immense, we all know that. So an 80 rupees tablet, I'm not marketing it here, sorry, my apologies for that. But or GLP-1 RAs. So the cost should not prevent us from initiating these medicines, and we all know we live in a country where the cost comes down very fast. Even that Dr. was saying that in the US the cost of one tablet of Finerenone is $20 US. We have it for 80 rupees. Once a generic comes, which will come in some time, we'll have it for 8 rupees. So we should all start getting into practice, and more importantly, this data shows that most of these patients are yours, not the nephrologist. So it is the internist or the first level care providers who has to start initiating treatments on these drugs rather than wait for the disease to advance. As sir said, it is the early stages which have to be targeted. So let's say a GFR of 60 with a UACR of 50 or 60, let's say, will never come to a nephrologist. And you will never want to send them to a nephrologist. But then you should initiate them on this class of drugs, either Finerenone or semaglutide, both of which we have enough experience to use, but probably still not using it the way we should be using it.
Dr. Manish, I wanted to make a comment that this study, Fidelio, they had only 4% patients on SGLT2 inhibitors.
6.7. Total was 6.7 in Fidelity.
Even the flow study which has come has now 15%. So with the robust data of DAPA CKD and AMPA kidney, now doing any study without a SGLT2 inhibitor, probably it should be like a baseline, like a RAS blockage. SGLT2 inhibitor should be also a baseline. And the benefit which we have got with this, this one, will it be translated then also when you have a SGLT2 as a baseline? I know there's a study going on that. But
so I was coming to that. That study is going to stop in 3 days' time on 31st, we'll call it. This is by the name Confidence Trial, so which is addressing exactly the issue you raised. There were just 6.7% people because SGLT2 inhibitors were not really in vogue during 2016, 17, 18 when these studies were being carried out. Flow trial, again we were part of trial, and again all these trials including DAPA CKD, AMPA kidney, and they were prematurely stopped because of overwhelming response benefits. Confidence flow had 15%. Confidence trial is what we are talking about. 3 arms. One is over and above RAS blockers. One is Finerenone alone. Second is empagliflozin arm. And third is a combination of Finerenone and dapagliflozin, which will tell us whether there is any point adding one on top of that. So we will get the recruitment is going to stop in 3 days' time, 6 months of study period, and 30 days of washout. So we'll get the answers hopefully in next May.
There was subgroup analysis done for those 6.7% patients, and who were on both, and hyperkalemia was less.
Yes.
Even in that number of patients, and the benefits were there.
Yes, agreed. So a combination, so as Dr. Khullar said, in the trial, confidence also, everybody is getting 2 pills. So when you have the 2 pills together, probably advantage will be much more, and definitely hyperkalemia is much less, so yes.
I think with due regards, we must thank Dr. Manish for a wonderful presentation.
Thank you, sir.
And such a wonderful interaction.
Thank you, sir.
My compliments to everybody and to the whole house for being interactive, so interactive. In the interest of time,
Yes.
I really thank you on behalf of us all.
Thank you, sir.
And let's hand it over to the organizers. Thank you.
I would like to request the speaker and the towards the felicitation area. I would like to request Dr. Mukesh Mehra to felicitate the dignitaries. For the next session, I would like to call on stage our moderator, Dr. Ajay Kumar Gupta, and the panelists, Dr. Manoj Singhal, Dr. Ravi Bansal, Dr. Naresh Dang, Dr. Rajiv Bansal, on the stage, please. And Dr. Setu Gupta, sorry.
So good evening everyone, and today like we have been discussing about the diabetes and the kidney diseases. So now we'll be having a panel, though means many of the questions which I had formulated have already been discussed in the previous talks, and many of the questions were answered by Dr. Kullar and Dr. Manish. But I still have some confusions. I don't know, means many of my friends may be also having such confusions. So I would like my eminent panelists to answer and kindly guide us. So sir, like what we talk like we talk commonly, CKD and DKD, chronic kidney disease and diabetic kidney disease. So sir, my first question will be to Dr. Manoj Singhal, that is there a particular difference between a diabetic kidney disease and CKD, or why have we, if there is no difference, then why do we have two different names? And one more thing means, is there a particular physiology in diabetics which lead to the kidney disease? And if yes, then are there any stages in which we can see or find it out, sir?
I think there is a change in nomenclature. So, for example, CKD and DKD is just that if the diabetes is the cause of chronic kidney disease, we call it diabetic kidney disease. Earlier, we used to use diabetic nephropathy as a generic term for kidney disease in diabetes. But that predominantly refers to glomerular changes related to diabetes. And traditionally, it has been a teaching that there is a stages of stage 1 like hyperfiltration, then mesangial expansion, decline in GFR, and advanced stage of kidney disease, which correlates with the diabetic glomerular changes, for example, mesangial hypertrophy and expansion of mesangial matrix, and gradually there is glomerulosclerosis and advancing renal failure. Clinical counterpart of that was proteinuria or albuminuria, which we now know that moderately increased or severely increased albuminuria. In early stages, there is microalbuminuria or moderately increased albuminuria, and then macroalbuminuria, and then declining GFR. But now there is a change in phenotype. So we see many patients who will not follow this typical pattern of kidney injury. We see more of non-albuminuric diabetic kidney disease. Almost 30% patients who have diabetes will never develop albuminuria, and they will have directly decline in GFR and progressive glomerulosclerosis. Probably there are different type of pathogenic mechanisms. So patients who have non-albuminuric diabetic kidney disease, they have predominantly interstitial and vascular changes. So a pathophysiology may be more like a hypertensive type of nephropathy or ischemic renal disease, which predominate in these patients, that lead to predominantly interstitial fibrosis and tubular atrophy. And then along with that, there is glomerulosclerosis, which later on comes. So they do not develop albuminuria and directly have declining GFR and land up in end-stage kidney disease. So if we just target glomerular changes or keep looking for albuminuria, we might miss these component of patients, which is almost 1/3 now. So that's why there is a change in nomenclature. So we call it diabetic kidney disease. So any kidney disease related to diabetes, whether it is a glomerulopathy, whether it is a tubular interstitial disease or vascular disease in diabetes.
So means the old teaching, like it was said that whenever you find a patient of diabetes with nephropathy, then you should always look for retinopathy, and if the retinopathy is there, then only it is diabetic nephropathy or diabetic kidney disease. So does that still stay, sir? Or
That correlation is good for patients who have type 1 diabetes. So almost 90% patients will have microangiopathy, so they will have retinopathy, they will have neuropathy and diabetic glomerular disease. In patients who have type 2 diabetes, we know that the correlation is not that good. So only 2/3 patient will have retinopathy. So 1/3 will have more of a changes related to other pathophysiological mechanism like hypertension damage probably will be more marked in these patients, or many other like repeated sort AKI or other pathogenic mechanism which may lead to diabetic kidney disease. So this correlation is not good in type 2 diabetes.
thank you very much, sir. So my next question to Dr. Dang, sir. Sir, you are a eminent diabetologist in this area and you are dealing with so many of diabetes patients. So what in your opinion or what in your understanding is the main cause of the progression of the DKD or the DKD diagnosis in our patients? Like whenever we are seeing a diabetic patient, so we always say that you should go for the urine albumin creatinine ratio. So what in your experience is the predisposing problems or predisposing conditions for the for this diagnosis, sir?
So India is, that way our control of diabetes is dismal. We have very bad control of sugars. We have associated hypertension, which also is uncontrolled in our patients. Statins are also used less. As Dr. Kula was saying, statins are the next aspirin, but I think a lot of inertia on the part of the physician, lack of education on the part of the patient, and everything comes 10 years, 12 years earlier. So one is that we must give good glucose control and use the therapies which will have pleiotropic benefits. So using SGLT2 inhibitors earlier on, GLP-1 receptor agonists earlier on, all our diabetic patients are obese. Most of them are obese and have, so obese, renal issues, heart failure with preserved ejection fraction, the CKM syndrome, and everything is going on together. And our patients are walking time bombs. And it gives me jitters. Honestly, I see them, and we have limited time. You do try to explain them and they don't understand. And if you really want to explain to them, actually it will take 1 hour and then maybe patient will run away. He'll say, "Main kahan aa gaya, mere ko to doctor ne dara diya." So poor glucose control, not doing urine for ACR in most of our patients. We should be doing urine for ACR in all our diabetic patients at diagnosis, at presentation. Today I had 3 patients from same family in the morning. All 3. One of the parents had urine for ACR which was 150-200. Son who was never taking any anti-diabetic also had 300 urine ACR, and so we must do it for all our patients. And we need a very holistic approach, and I hope we are able to do it. Our load is more and we have less time.
Thank you, sir, for these comments, because we all feel like we are facing, or we are heading towards becoming the diabetes capital of the world with nearly 11 million of diabetic patients and the similar amount in the pre-diabetic stage. So, Dr. Ravi, like what Dr. Dang has said, the inertia is the most important problem, means whether it is from the patient side or whether it is from the physician side. So, how what is your opinion to guide us? Like Dr. Manish said that many of the patients from 30 to 60 will come to the physicians only and will not go to the nephrologist. So how do you think we physicians can this progression, or we can arrest this progression, or we can diagnose it early? So what are the early diagnostic signs for a DKD for us physicians' knowledge, sir?
So diabetes, when it starts involving the kidney, signs could be pedal edema, signs could be hypertension, but signs may occur very late. So screening is important. So patients who are at high risk of kidney disease should be screened, and diabetes is a high risk group. So as Dr. has mentioned, at initial first contact, you should screen the patient for end organ microvascular, macrovascular complications of diabetes, which would definitely include a urine MACR. But I would also like to emphasize use of urine routine. So urine routine is very important because as physician, our role should be to rule out non-diabetic renal disease in a diabetic patient. So every diabetic patient who has a renal disease, maybe they are having non-diabetic renal disease. So that should be very important, and urine routine will help us in seeing if there are WBCs or RBCs in the urine. So I would like to do it at first contact. So this should be like screening, which will help us in early diagnosis.
So it is very important to go for the screening as per Dr. Ravi has mentioned. So Dr. Rajiv, like we see too many patients who are having multiple comorbidities also. Like if we talk about the diabetic patient, the patient must be having the comorbidities like hypertension, the patient also has retinopathy. So how do you address these comorbidities, or does your treatment plan or the prescription change if the patient is having other comorbidities or like?
Yeah, definitely. If the patient has
or what are the targets?
Other comorbidities, yeah. If the patient has other comorbidities, you have to be very aggressive because you cannot take the other comorbidities lightly. So the targets change. For a diabetic hypertensive, the target is 130/80, ideal target. Okay. Similarly, the other targets also change. The HbA1c should be around 7. Or if the patient is young, it can be lesser than that also, 6.5 to 7. If the patient is elderly, you can keep it 7 to 7.5. So the targets change because you have to be more aggressive so that the progression of the disease is not there, because multiple other factors are also playing the role. So as I said, the frequent screening is very important. I think we should make it a habit that on every visit, normally on an average, our patient visits in 6 months or 3 months, not before that. Even if at 1 month, they don't come back. So we should make it a habit that before every visit, whenever they come, urine microalbuminuria, UACR and eGFR should be there in every visit. And depending on the comorbidities, other tests should also be there, like lipid profile or the other tests which are required. So we have to be very aggressive. There should not be any inertia. Sometimes most of the patients, they say, my reports are absolutely normal, I have seen the reports and I'm not carrying the reports. So, but when you tell them that please show the reports, then you realize that urine MAU is more, UACR is more than 30, and then you tell them the importance of this. So I think frequent, monitoring is very, very important, and the targets are stiff when you have comorbidities.
True sir, मेरा यूरिया क्रिएटिन तो ठीक था सर, वो मेरा अल्ट्रासाउंड भी ठीक था, तो किडनी की कोई दिक्कत नहीं है मुझे.
Exactly, that's what this is the
so
common.
This is the common statement which we hear in our OPDs.
And when you screen their previous reports, you find dyslipidemia, you find, they think LDL of 110 is normal. They think, UACR of 30 is normal. So that is how we have to go.
True, sir. So just continuing this, like if we, Dr. Setu, we are having some hormonal disbalances also in these diabetic kidney disease patients. So what all hormonal disbalances as an endocrinologist would you like to address, would you like to see or screen for, and how do you deal with the hormonal disbalance, or what are the what are the common hormonal disbalances which we see in these diabetic kidney disease patients?
So diabetic kidney disease usually have the similar kind of hormonal imbalances as a CKD. They really do not have any particular changes by the virtue of being a DKD. So whatever we screen or we ask for in patients with CKD, I would just say that. So subclinical hypothyroidism is a very common finding, and almost around 50 to 60% do tend to have it, and if required, we usually tend to treat them. We do not follow the usual guidelines that subclinical is not to be treated. In such cases, we usually err on the side of error and caution, and we tend to treat them. That's going to be the most common, and we don't question the patient for this. We usually do run the test for it. Rest, the other thing that we run tests for is looking at the bone health, because again, questioning is not going to help. We usually advise for a DEXA. We look at, we ask the patient for previous history of fractures. We get a vitamin D and PTH done, and calcium, phosphate, ALP. These 5 are required to assess the bone health. and is pertinent because almost 30% do end up developing them if the duration has been more than 5 years. So that's regarding the bone health. Rest everything it's based on question based. So there is a male and female hypogonadism, so we usually question their cycles, we usually question their libido, their desires, particularly in male. And a very common cause of male hypogonadism is hyperprolactinemia. So CKDs tend to have some level of mild hyperprolactinemia, to the range of 50 to 70 nanograms per ml, and we do tend to treat them because they tend to improve the hypogonadic features. And if there is no hyperprolactinemia, then these hypogonadism can be treated by giving exogenous testosterone or OCPs in case of females. Then the other important ones would be about aldosterone. So usually if obese diabetic patients who are hypertensive, it's a good idea to screen for renin and aldosterone levels, because up till now we were under the impression that once a patient develops CKD, then screening for aldorenin is not relevant because it's going to be high renin. But 2 years back, Mayo data has clearly shown that the CKD with hypertension who are not controlled on 3 antihypertensives, at least 2 and aldorenin once. So I would say that is also an important test that we can do at least once. And I think like you were saying, in the past 1 year I have picked up 2 Cone syndrome with just screening.
Yeah, that we were discussing off stage also. So thank you, Dr. Sethu. So we are okay, means we have to screen the patient. So Dr. Bansal, what in your opinion should be a treatment approach, or rather patient education approach? How do you educate your patient, or rather how in your opinion should we educate our patient regarding this DKD for the prevention of DKD, early diagnosis, so diet and advice to the patient as compared to for education, sir?
Yes, very important. See, our patients are, whenever we tell them that your kidneys are getting affected, so they become serious, because dialysis everyone is scared of. Nobody wants dialysis. So you tell them that you have to have a very strict glycemic control. Then you have to have a good diet control, and a proper diet communication has to be there, because there are a lot of questions about diet. And then frequent monitoring with simple tests like microalbuminuria and UACR, and adherence to the treatment and follow up to the treatment. So these are the 3-4 most important things which there are a lot of patients who are following this, and they are maintaining and they are improving also for years. They do not go on dialysis, but there are a lot of patients who do not follow this, and so the communication, I think, has to be there. You have to spend some time, at least in the first visit, and then subsequently, it is very simple.
True, sir. Means in our primary care setup, when we are in the OPD setups, we are to give time and explain the patients. So Dr. Dang, how do you ask your patients to follow? Means, like if I am a patient, my UACR is though not between 11 and 30, but slightly more than 30, sir. 11 and 30 पे तो बहुत सारे हो जाएंगे, sir. Even अपन बैठे इनमें से भी कोई 2-3 निकल जाएंगे, sir. So if it is above 30, so what will your approach be for me? Means like, what would you advise? How frequently should I get the UACR done?
So if a patient has normal this thing, maybe yearly is also okay. But if a patient has UACR which is high, then it should be repeated. I would do it at 3 months. I know the guidelines say 3 to 6 months, but I would err on the earlier side, because albuminuria, micro or macro, whatever, is a sinister sign, and it tells that the whole vascular bed, the cardiac, the renal, the retinal, all are getting involved. And I would do it at 3 to 6 months.
So any treatment protocol would you like to change according to the UACR values, or what would be your treatment protocol for me, sir?
So I was listening to someone, he said SGLT2 inhibitors should be in the water stream of a diabetic patient. So SGLT2 inhibitors have to be there, ASARBs in the maximum tolerated dose have to be there. And I'll just, give me 1 minute. See, in 70s, the eGFR decline per year used to be 10 to 15 ml per year. And within 3-4 years, or 2 to 3 years, patient would reach end-stage kidney disease, and we could do nothing. In 90s, when the ACE inhibitors came, it came down to between 5 and 10. Now with SGLT2 inhibitors being added, the eGFR decline is between 2.5 to 5 ml per year in most patients. And with GLP-1 receptor agonist, we have to see how things move on. So all these 4 pillars have to be there on board in most of our patients, along with good blood pressure control, less than 130 by 80, and they say, I would still err on even better, 120/80 maybe even better. They say that the morbidity goes down, even the cardiovascular events go down. Between 120/80 and 129/88 or 129/84, there is an improvement if it is 120/80. So go for a good control of blood pressure, and of course statins, etc. have to be there. And lifestyle modification, very, very important. And dietary modification, protein restriction may not be that severe. Dr. Bhalla can correct me if I'm wrong. 0.8 to 1 gram, is that right? So 1 gram, that is the protein intake.
Thank you, sir. So, Setu, just to add on to what Dr. Dang has said, would you like to comment on these newer drugs? How do they help? Means like Dr. Dang had talked about the SGLT2 inhibitors, the GLP-1 RAs. So, according to a primary care physician, GLP-1 RA तो भाई sugar की दवाई है वो kidney में कैसे help करेगी? So, you would like to enlighten us about these newer drugs?
So SGLT2 inhibitors primarily work by reducing albuminuria. That's the primary mechanism of this. So SGLT2 receptors are present in the proximal convoluted tubule. It also, so when it is blocked, the pathways happen. There is a glomerular feedback, juxtaglomerular feedback, because of which even proteinuria tends to come down. So it usually prevents proteinuria, which further prevents glomerulopathy as well as tubulointerstitial pathies. So it primarily helps predominantly when, as we had already discussed, when there is albuminuria, it tends to work better, but even in the absence of albuminuria, it did show evidence, as was evident in the EMPA kidney trial. GLP-1 receptors, they tend to work at the vascular level rather than at the glomerular level, and they tend to provide a decline in the creatinine, decline in EGFR rather than prevention or reduction in albuminuria, because it primarily is acting at the level of vasculopathies. And the same goes with Finerenone, sir. It acts at the endothelial level, also at the levels of tubular MC4 receptors at the collecting duct and the distal ducts. So it tends to act at both two pathways. So these are the different mechanisms. Yes, they are primarily started off as anti-diabetic drug, but now they've become more of cardiovascular as well as now renal drugs. So they're gonna be the next statins as everybody's talking about it.
So one more knowledge from your side, like I had heard in a talk that if the eGFR is less than 60, so you should be cautious in starting the GLP-1 RAs. What is your comment on that?
So, the caution word was probably because of the side effects. Because, sir, if, for example, if we take somebody who is on dialysis or somebody whose eGFR is less than 30, they anyway have some uremia, they anyway have some nausea which is there, and GLP-1 tends to exaggerate that. But as far as the guidelines are concerned, or as far as the safety threshold is concerned, even up till 30, GLP-1 can be used, sir, and they are being used.
GLP-1s can be used even lower than
that.
And we have to be cautious. We can use them, start low and go slow. And I would not agree with that comment, whoever made it.
Sir, your comments, Dr. Manoj?
Yeah, I think I agree. GLP-1 receptors can be used, so there is no contraindication as such. Only thing is the side effect which Dr. Setu has enumerated, because once the patient becomes symptomatically uremic, so they have a lot of GI effects because of uremia, and if you add GLP-1, they have more side effects. So that's the problem there. But it's not that it is not effective, but it works predominantly for the vascular. Even GLP-1 receptor has been best shown in atherosclerotic cardiac disease rather than the heart failure. So probably SGLT2 inhibitors, they act more on heart failure and prevent mortality because of heart failure, whereas GLP-1 receptor will prevent more because of ischemic cardiovascular events. So, and similarly, they also prevent the decline in GFR by working more on the vascular injury rather than the proteinuria or hyperfiltration injury.
GLP-1s are an excellent drug, and we will see more and more usage in heart failure with preserved ejection fraction. We have data from STEP, HIF-PH in diabetics and non-diabetic obese patients also. There was significant improvement in heart failure with preserved ejection fraction, and in years to come, you will see GLP-1 receptor agonists being used more and more for this entity also. Of course, we have to wait for 1-2 years. But this is the preliminary data.
So, Dr. Ravi, one question to you. जैसे हम लोग बोलते हैं, हम लोग फिजिशियंस हैं ना, थोड़े से भीचू टाइप के होते हैं, इनर्शिया. एक और इनर्शिया होता है कि हम लोग एक हमें ये आप गाइड करें, मीन्स जस्ट गिव अस अ गाइडेंस व्हेन टू रेफर द पेशेंट टू अ नेफ्रोलॉजिस्ट, बिकॉज वी वुड नॉट लाइक टू रेफर ऑल आवर पेशेंट्स, बिकॉज all the diabetic patients, either they may be having a cardiological problem or they may be having a nephrological problem or nowadays liver problem. So when to send the patient, because ये जो मैंने word use किया था भिंचू, this was a word which was used by one of our teachers, stage से उतर के मैं बता दूंगा, everybody knows him. So he said that as a physician or a diabetes practitioner, you should not leave your patient till you are able to treat him. Till you are able to treat. So when to refer such a patient to a nephrologist?
I think you have given the answer itself. We all are physicians. I am also a physician. I am also practicing medicine. So I don't feel that all other practicing medicine people, they can't manage diabetic nephropathy. They all can manage diabetic nephropathy. It is information and practice and skill. With time everybody learns, and everybody who's dealing with diabetic patients should try to manage diabetic nephropathy patients. But then there will be times where you will feel that probably it is not diabetic nephropathy. It is some other nephropathy or some other kidney disease. So what could be those signs? Suppose patient has RBCs in the urine. Suppose the creatinine is rising rapidly, is not getting controlled. Suppose the ultrasound shows some other findings. So in those cases where you are in doubt that it is not a diabetic nephropathy, you should definitely refer the patient to a nephrologist. Second is that if you feel that in certain situations patient require further intervention, like patient require guidance for management of anemia, calcium phosphate balance, vaccination, these all can be done at physician level also. But if they are requiring intervention for fistula formation or further plan of a further treatment of dialysis or transplant, in those cases patient should be referred. So I would say you judge your line yourself, that till what level you are comfortable. And obviously we all are upgrading our knowledge. So nobody, you can't say that you have to refer the patient. It's not like that. You have to manage till you feel you are able to help the patient. If you feel you can't help the patient, you can refer the patient.
Your comment, sir?
So a very simple indication is when patient starts asking too many questions. So you should refer the patient to a nephrologist immediately, because you are not a nephrologist. And secondly, as he rightly said, if the patient is not improving, so you have to, at least, once you have to give the choice to the patient that please consult a nephrologist. And, we have seen most of the patients when we tell them to refer to, go to a nephrologist, they do comply, but they come back. That Dr. has written these things and now we can follow with you. So all the things are okay, so we can follow with you. So there is no harm in, referring the patient to a nephrologist given the choice, because the scenario is like that. And if the patient is asking too many questions, then obviously you have to.
Sir, a quick comment from all the panelists for a simple question. Dr. Sahab, मुझे जैसी diabetic kidney disease हुई, फला डॉक्टर साहब ने calcium, nodosis और एक नेफ्रोसेव लिखी, आपने तो बताया नहीं है सर. So what is your comment, sir, starting from Setu? Short. कि diabetic kidney disease होते ही, should I write calcium, should I write taurine, should I write alpha-ketone drugs, or should I write calcium, should I write vitamin D, or should I write alpha-calcitrol, or what should be done?
I think I haven't prescribed as many pills to diabetic kidney disease as I've cut down from the previous prescriptions. I think, and patients have always said that कि मतलब सर ये तो डॉक्टर ने बोला था कि यही किडनी को रोकेंगे, so it's very difficult to help them. Just one thing I just want to say that calcitriol is a very, very abused drug in DKD patients. I would say that it should not be used in every DKD patient. There are very specified indications for that. So I'm just very scared with calcitriol. And one more thing I just want to add to sir's comment, sir. You've listed down all the three criteria for referral. Just one you missed, sir. That was nephrotic range proteinuria, because we do tend to see them a lot. And that really requires a nephrologist intervention. That's all, sir.
So my comment is that we have two scenarios. One is ideal situation and one is the real world or practical world. So you have to satisfy the patient. So I write these things because If I don't write, the patient will not be satisfied because these are not causing any harm to the patient. So as long as these drugs are not causing any harm, I try to satisfy the patient. So apart from the essential drugs, I add these drugs also.
So I would say follow the guidelines. I mean, I would not write and I don't write. And as he rightly said, there are few nephrologists who write a lot of drugs and I run away from them. Because unnecessary medication, burden on patient's pocket is not recommended. I follow the guidelines, that is what I would say.
Dr. Ravi?
So actually I agree with Dr. Saab that burdening the patient with so many medicines is not required. But if you look into the physiology, like if a patient is developing renal failure, first thing what he requires is vitamin D, and he requires a control of metabolic acidosis, which can be subclinical initially, and even bicarb level can be normal. So early supplementation of little bit of bicarb and vitamin D is what I follow in these patients with early nephrosis. And as far as calcitriol, I think should be avoided until unless specifically indicated. Calcium supplements should be avoided until unless specifically indicated because they have their own problems. And iron supplementation can be given if required for anemia and iron deficiency. So what is left is the question about N-acetylcysteine, taurine combinations. So are they useful, are they not useful? I think they are doubtful, and as a blanket treatment should never be used. So I don't use in my practice that way.
Dr. Singhal, sir? Sir, I would like to comment on this, sir. I have a very learned friend who had commented कि अगर मैं नहीं लिखता हूँ तो nephrologist लिख देता है और अगर मैं लिखता हूँ तो nephrologist काट देता है. So this was the comment from one of my learned friends, and he is present here also, sir. So
I think what you said is we need to decide कि हम क्या practice कर रहे हैं, या हम खाली इसीलिए कर रहे हैं कि मैं नहीं लिखूंगा तो दूसरा लिख देगा, मैंने लिख दिया तो दूसरा काट देगा. I don't think that is the right philosophy, and one should not be guided by that philosophy. The few things which don't work, we know that. Protein restriction, for example, there is no question of restriction. Indian diet is so deficient in protein, most of the time you have to increase their protein intake and restrict their fat and carbohydrate. So protein restriction, there is no rule. Blanket treatment of soda bicarb, even nephrologists write it. Somehow I don't write it unless until the bicarbonate goes below 22. Generally, I don't write soda bicarb to more than 10% of my patients. Arginine, taurine, I have never written on my prescription. Keto analogs, I have never written on my prescriptions. Calcium, vitamin D, as Dr. Ravi has said, it's not a blanket treatment. Only if it is indicated for bone disease, you write it, otherwise no. So generally, there is no blanket treatment for you. When you deal with the patient, then you make a deal. Okay, these are the things which work. ACE, ARBs works. SGLT2 inhibitor works. Finerenone definitely. Blood sugar control. As Dr. Dang has said, most of our patients are not controlled as far as blood sugar in blood. Who is responsible for that? We are responsible for that. So I think emphasize on these effective treatment where you get the incremental return. And hyperuricemia, I mean the moment uric acid goes from 6.4 to 6.6, it becomes bold and everyone writes febuxostat. Is there a data? No. Just because we have a medicine which can bring it down and we can show the patient, okay, now your uric acid is less than 6.4. Why unnecessary? And every medicine has a side effect. There is no medicine which doesn't harm. Even B complex may have some harm to the patient. So I don't see anything which is harmless. Even the food is harmful. It makes you obese. Very harmful. So I think one has to strike a balance and work for your conscience as well, rather than for a peer pressure or comparing with other people.
Thank you, sir. And just in continuation, sir, any recent advances in either diagnosis or treatment which you could enlighten, sir?
No, I think a lot of it has been highlighted since morning. Most of the medicines which are already there, we have discussed. Few things was come up in the comment. For example, there is a lot of redundancies. So Finerenone, as we have discussed, mineralocortical receptor antagonist. So we can give these antagonists to block the receptor, but now people are working on synthesis inhibitors. So if we block the synthesis of aldosterone, that is maybe the next step. So there are trials going on. It has not come to the clinical practice, but soon we will see. Then there are double blockers like ET receptor blocker. So there are blockers which can block angiotensin receptor as well as endothelin receptor. So they have been tried in non-diabetic kidney disease, but sooner I am sure they will also be tried in diabetic kidney disease. And then there are other things like gene therapy and other things which we have to see the light of the day. But I think most effective therapies are these 4 pillars which we have discussed since morning. So if we use these judiciously, I'm sure we can control a lot of these patients who have diabetic kidney disease.
So Dr. Setu, one crisp comment from your side, like obesity has been earmarked as the isolated marker of progression of DKD also and early DKD also. So any new thing in, like we all know that obesity has to be controlled, and once the obesity is controlled, then you can slow the progression of DKD also. Rather, some medicines have shown to bring out the patient from macroalbuminuria to microalbuminuria. So any new things in pipeline for these, like we have GLP-1 RAs,
yes, sir.
so we have got some glucagon antagonists also.
Yes, sir.
Just
so
a small crisp comment on
just basically, sir, ADA 2023 was all full of anti-obesity drugs. They introduced 6 drugs in the form of phase 2 trials. The paradigm for obesity treatment is going to change in the coming 5 years. We have, like you said, we anyway have dual tirzepatide is already in the market. So it's a dual antagonist, and we have dual plus triple, which is glucagon. So we have retatrutide, we have stuvitide, we have so many drugs that are coming up. So I think obesity is going to change, and indirectly as obesity improves, the diabetes, the hypertension and the DKD is going to get managed pretty easily.
So there has been 2 bells from the organizers. So one single line crisp comment from all the panelists, sir. Start, Setu. Comments?
Comments.
Take home messages for our delegates.
I thank Ajay sir for managing it so well.
Yes, sir.
So I have a comment to make here that most of the conference, there is a difference between what we preach and what we practice. Ideally, that difference should not be there. That is one comment. Because on the dais, we say something else, and when we see the prescriptions, there's a lot of difference.
Disclaimer
There
is
was
that
a time about a drug, tenaligliptin. Everybody used to, on the dais, everybody used to, just say bad things about that drug. Useless drug. No need to talk about that. But everybody was writing it. So, this then ideal situation and the practical world.
True, sir. You have pointed out very true statement, but there is a disclaimer that this talk is not sponsored by any of the companies, and you can say your own comments, whatever you want.
No. I'm not talking about, I'm just giving an analogy.
Yes,
yeah, this is an analogy.
I think it was an excellent discussion. Thank you.
Thank you very much.
I want to make one comment is that there should not be communication gap with the patient. Like some patients, they fear coming back because either you have told them so much or they fear paying fee again, coming. So what I tell the patient is don't worry about the fees. At least come every 3rd day, 2-3 times. Initially because, you have to up titrate sugar and BP medicines. So that phase is important. So they should not be like, they should not run away and go and come after 2 months saying it is not controlled, doctor. Your BP medicine is useless, your sugar medicine. So initial communication, repeat visits. They will educate also and build confidence in the patient. So that is very important.
I think I would partially agree with Rajiv Bansal that what we say here on the dais, we don't do it in the practice. And let me just tell you, as a nephrologist, when we see patients who come to us with diabetic kidney disease and creatinine is 4, 5, 6, many of them would not have their albuminuria checked or have serum creatinine checked. Right. So I think we should feel that these are very important tools, should be used more often for screening, and once we find them as abnormal, we should pay some attention to it and say titrate our treatment and try to because there are effective treatment. At least on that part, most of us are convinced that now there is effective treatment which has brought down the deterioration of GFR from 10 ml to 2 ml and maybe to 1 ml per year in future, which is a normal aging phenomenon. So there are effective treatment for kidney disease, and we should use them more often. And that can only be used if we screen these patients and start this treatment in early stages.
Thank you. Dr. Makkad?
I think I'll go back to the SGLT2, not a controversy. The usage pattern. So we have an endo here, we have two physicians, and we have two nephrologists, and SGLT2 seems to be one of the big pillars of renal patients. So what is, as a nephrologist, as a a physician practicing diabetology, and as an endo, what is the threshold in your practice with regards to using SGLT2 inhibitors? And when I say threshold, I'm talking about two, one is of course the albuminuria, or the level of albuminuria, whether it is micro, macro, and the level, and the GFR. Because there's always a risk of the ketoacidosis with SGLT2 inhibitors and so on and so forth. So what is your, as an endo, what is your threshold? As a physician, what's your threshold? And as a nephro, what's your threshold?
So, sir, I think the guidelines for this are, I'm just going to be very brief. The guidelines are very clear. SGLT2 inhibitors can be used for the glucose reduction or for the management of diabetes reduction. It's very effective with an EGFR of more than 30. So that comes with when we're managing diabetes. When we're coming to the management of DKD, albuminuria reduction occurs till an EGFR of 20. There have been different trials with different GFR thresholds for albuminuria reduction, but KDIGO 2024 and 2023 had very clearly said that this is a class effect, and they have made it 20. So up till an EGFR of 20, there's going to be a significant albuminuria reduction with the usage of SGLT2 inhibitors. Earlier, when you with an EGFR of 30 to 45, when we initiate SGLT2 inhibitors, in the early 2 weeks, you're going to see a decline in an EGFR, which is going to be very normal, which is nothing to be scared of, because this early decline means that later on, the rapid reduction is not going to be there. And creat reduction will occur early on, but with an albuminuria reduction, over the years, it's going to settle down.
So let me put my question in a different way. So let's say there's a patient who, let's say 48-year-old diabetic patient, diabetes for the last, let's say 10 years, maintaining his albuminuria between 10 to 11, 10 to 15. Now he comes to you with an albuminuria of 20. Would you start an SGLT2, keeping everything else normal?
Yes, sir. No, ACE ARBs are going to be there.
So he's already on all these drugs.
All these drugs, yes, sir. SGLT2.
So would you start an SGLT2?
Yes, sir.
Okay. What about physician? His albuminuria
definitely, with the new cutoff of urine microalbuminuria of 10, and if the MAU is increasing, say you are saying 2 times from 10 to 20. So I would like to have a concern, and I would like to, if the patient is already on ACE ARBs, I would like to add another drug, maybe SGLT2, maybe. So I think yes.
Okay.
Add one more thing, to repeat the albuminuria again, just to confirm whether it's rising or not. It has to be.
Not only urea, I would like to give SGLT2 inhibitor earlier on, because we have so much data that patients who had eGFR even between 60 and 90, their progression and worsening of kidney disease was much less. They had less heart failure in years to come. And we know that in today's era, all the complications are coming much earlier. You get a heart failure within 5 years, you get kidney disease within 5 years, sometimes you get kidney disease at presentation. So I think anyone who can tolerate SGLT2 inhibitors, they should be on board, maybe immediately after metformin in most of our diabetic patients.
Nephro?
So yeah, I will definitely want to treat everybody with SGLT2 inhibitor. Every kidney patient, because it has been proven, even in DAPA CKD, that non-diabetic kidney disease also you can use SGLT2 inhibitors. But only problem is that of the side effects, of the tolerance, as Dr. Sir has pointed out, should not combine with diuretics, can get dizzy, postural symptoms, dehydration. Whenever patient is admitted, you should stop it, because they can land up with euglycemic ketoacidosis.
Yes.
And when the patient is not taking diet, that time I should be very careful. So you have to monitor the side effects.
True.
That's also. Otherwise, it's a very beneficial drug. I would want to use in all patients, and UTIs. So
I think you talked of threshold. So if you look at the guidelines, even if we talk of guidelines, these are the first line medicines for diabetes. Same way ACE inhibitors, ARBs are now first line medicine for hypertension. So anybody who has diabetes or hypertension, he should be on ACE ARBs or say SGLT2 inhibitors, irrespective of their GFR and proteinuria. The indications now are widening. For EMPA kidney, for example, including patients who had no microalbuminuria, so when the albuminuria is less than 20. And if you believe the cardiovascular benefit of these medicines, then irrespective of renal disease, these patients should be on these medicines. Why not? Only precaution would be when the GFR is less than 20. So whenever we start these medicines, there is a fall of GFR of approximately 25 to 30%. So their creatinine will go up from 4 to 5 on next visit, and that may create some sort of a panic or alarm in the patient. So that's where I probably would not start it, but if I follow these patients on 2-3 visits and once I have a rapport, at least I can explain these issues to the patient and may start it in a lower dose. If the patient is already on SGLT2 inhibitor, irrespective, till they go and on dialysis, we continue these medicines.
Fair enough.
So starting at that point may be a little tricky, but it can be started if you have a good rapport with the patient. Otherwise, I don't have any threshold. So any patients, I would start these medicines.
Perfect. Thank you.
Thank you very much. And I thank all my panelists for such a descriptive description of the DKD. So with the note that patient education, early approach and intensive approach, we can all thank our panelists. Thank you everyone. Yes, sir. Sir, usually
it is calculated with three parameters. One is the age, gender of the patient, and serum creatinine. So they use CKD EP formula, and that's all, because they have the age of the patient, they know the gender of the patient, and they know the creatinine, and that's all. Sorry? No, sir. Weight is required for Cockcroft and Gault. This CKD EP, which is based on the population study, MDRD study, where they have a large number of populations. So initially there were 4 parameters, then they removed the race from that. So we take these 3 parameters and calculate eGFR.
And it has been mentioned and mandated by the RSSDI guidelines also that in the future all labs will be having eGFR in their KFT reports. So that's why some of the labs like the standard labs of Max, Agilus, Lals, they do mention eGFR, sir, in the KFT. Sir.
There are eGFR calculating apps also on the Play Store. You just have to put the patient's age, gender,
calculator करके app आता है, sir?
creatinine.
So they have these 3 data, so they can calculate eGFR and report it. And ideally now, as he said, there are guidelines to report the eGFR, just to make them more aware. So whenever the eGFR is less, in fact, only thing which I still feel is lacking is they mention like less than 59 is abnormal, whereas they should mention that more than 90 should be normal. So we still miss that 60 to 90 window in these. So that's the only missing in that report.
A very small question from my side. Sorry for the delay further. The link between asymptomatic bacteriuria and SGLT2 inhibitors. Suppose we plan to start a patient on SGLT2 inhibitors, we get the urine routine done, there is asymptomatic bacteriuria, first situation. And the second situation, the patient is already on SGLT2 inhibitors, as the matter of routine we get it done and we find asymptomatic bacteriuria. A very short take, please.
Asymptomatic bacteriuria should be treated only in certain conditions. One, you should not screen for asymptomatic bacteria. Ask for a urine culture only if the patient has symptomatic urinary tract infection. If patient is not symptomatic, don't ask for urine culture report. Except in few situations like pregnancy, where you need to screen them. If the patient is planned for some urological procedure, that's where you need to screen them. Otherwise, don't ask for urine culture.
So, sir, in such a patient, will we confidently start SGLT2 inhibitors? And if such a patient is already on SGLT2 inhibitors, will we continue them?
Say, urinary tract infection, one should not start them on SGLT2 inhibitors. You treat urinary tract infection. Unless until they have a recurrent urinary tract infection or some predisposition for UTI, then probably SGLT2 inhibitors would not be a good medicine. But if they just have one freak incidence of urinary tract infection, I would restart SGLT2 inhibitors in these patients.
Thank you, sir.
If a patient is on SGLT2 inhibitors and gets asymptomatic WBCs 10, 12, I would ignore it. I would give them more water and,
Right, sir.
you know.
Thank you, sir. I would request the dignitaries to proceed for the felicitation area, and I would request Dr. RPS Makkad to for the felicitation. I would like to call on stage for our expert talk show, Dr. Pankaj Nand Chaudhary sir as the moderator, Dr. Dilip Bhalla, Dr. Neeru Agrawal, Dr. Naresh Agrawal, Dr. Paras Gangwal and Dr. Meenakshi Jain on the chair, please.
So this is the last session before we close this meeting. So I think most of the things have been covered, and the one point I think I would like to highlight in the previous talk, that yes, we could start SGLT2 up to 20, but definitely they would have some glycemic effect even. But previously we thought that there was no glycemic effect, but renal safety would be there and glycemic effect would also be there. So it's not there that we should not write, SGLT2 in the questionnaire. Okay. So I think there are some ceremonies going on, so we can have 2 minutes time so that they can.
My only request to the moderator is that I think it's been a long session. Most of the people are uremic, I think, by now. So let's keep it short.
Yeah, very short, sir, very short.
And concentrated nephrology.
So by moving from the hardcore nephrology to a nephrology of physician's perspective, right? So there may be some questions which would be in our minds and probably because of inertia that would not be answered. So I would take that question only, right? Because of physician's point of view. So Dr. Setu, I think we can, Dr. Ajay, we can have. So now moving on to nephrology to infections, right? I think the bread and butter of physicians are patients of infection. Okay, sometimes patients come with urinary tract infections and you want to treat it. So first question would go to Para. Dr. Para was sitting idle for some time, right? So so how do you define? Suppose sometimes it has been written in the text that this patient having uncomplicated UTI and patient having complicated UTI. So how you define these terms so that we would be easy to us to treat those patients? So the definition of this terms like.
So I think we all know simple is simple and complex is complex. So simple UTI means somebody coming with just dysuria, increased frequency and a little suprapubic pain. Then you call it simple UTI. If patient is having severe fatigue, high fever, is having features of sepsis, going further with renal angle pain or pain in the costophrenic region, drop in the blood pressure, increasing heart rate. So the features of sepsis taking up would be a complicated UTI. So going further would mean, is the situation with complicated UTI more complicated would mean the both host factors and the agent factors. So host factors would be if somebody is diabetic, old age, immunocompromised, on certain drugs which make him immune compromised. So that's the situation that we need to decide when we say whether the UTI is, as we are saying, asymptomatic bacteriuria to a simple cystitis, then to complex UTI.
Right, I think Dr. Pala, you are absolutely right. I think in the last Midcon, the annual conference, was a quiz like, say if the patient comes in simple or uncommon UTI, which is the feature which is not present normally? So the answers were 4, like patients have dysuria, frequency of micturition, some suprapubic and fever. So they were the 4 things. So I think that's
right. Once you have fever, it is complicated UTI.
So in uncommon UTI, there should not be any fever. So if the patient come into you, कि सब बता रहा है आपको सब problem आ रही है और fever नहीं है इसको, तो possibly this you are dealing with the patient of uncommon UTI, and this can be managed in outpatient department as well. If the patient is having fever, then you have to actually screen for patient which would complicate it. I think this is very simply in the quiz actually, and most of the postgraduate students, they don't answer rightly. So I think fever is there, so it means you are dealing somewhere in the complicated, and definitely you have to. So Dr. Paras, the patient comes with UTI symptoms, so how would you treat? Definitely you would ask for patient to have the urine culture. And regarding the antibiotic duration, there is some very issues over. Some guidelines say yes, only 3 days of antibiotic would suffice. Some say that only 5 days of antibiotics would suffice. And sometimes we are actually, the physicians, give more 7 days, 10 days antibiotic. So patients of simple UTI, suppose patient coming with dysuria and some culture positivity like E. coli, female patient coming to you. So what would be your duration of antibiotics to those particular patients?
So it's like simple UTI patient coming to you. That's why we need to know the whole profile of the patient. First, the patient is having simple UTI or complicated UTI. Then the host factors would also become important. In patient with simple UTI, obviously you will send the urine culture ideally, but you have a regimen to choose. So what they say is that you also need to define that the patient coming to you, what are the chances in which strata the patient lives or the zone the patient lives, chances of fluoroquinolone resistance. What are the chances of patient having a MDR bug? So how is it defined? In India, the fluoroquinolone resistance is now increasing, it's more than 10%. So most of the guidelines say that if the resistance is more than 10%, you have to at least be aware of that fact that if I am prescribing a quinolone, how much are my chances of failure? Same is, your patient is coming to you after already visiting another physician who has prescribed him some medicines in the past. So what they say is that you define what are the chances of a MDR bug in that patient. So how do we define the possibility of having an MDR bug? If somebody has received an antibiotic in the recent past, if somebody has been hospitalized, if somebody has been catheterized, some urological intervention has been done in the patient, or if somebody is staying in the nations where MDR bugs are more. So India is one of the nations where MDR bugs are more. So you have to actually see the profile of the patient. So by going this definition, India being the host nation for MDR bugs, we have to be really wary in choosing our patients. More so when patient is coming with frequent treatments for the UTI with your colleagues who are treating. So then your chances of taking up an antibiotic has to be accordingly to a category where your chances of success are more. So making that further simple, maybe it was first occurrence of UTI as a simple cystitis in a patient, you may still continue to choose a quinolone, knowing that the chances are 10% you would still not be able to treat. You can still treat him with Septran. You can treat him with a single shot of phosphomycin sachet only once, if it is a simple cystitis. If patient is having complicated UTI, then you have to define it further that if patient is having, again, if it is complicated UTI, you have to see again how many things are involved. If it is just fever without pyelonephritis, your duration of antibiotics would still be 5 to 7 days depending on the agent that you are choosing. If it is pyelonephritis, then your duration of antibiotics is going to be, if it is early pyelonephritis, it is going to be at least 14 days. If it is again with some chronicity, the duration of antibiotic would go to 2 to 3 weeks. If it is again severe, the duration of antibiotic in pyelonephritis would go 3 to 6 weeks also. If the patient has developed renal abscess, you would have the duration of antibiotic going to 4 to 6 weeks at least. Similarly, if patient is having prostatitis or prostatic abscess, your duration of antibiotics is going to change. In prostatitis, it is going to be at least 2 weeks. If it is prostatic abscess, it is going to be 4 weeks. Again, as the complexity of the situation arises, your cultures have to be very well sent at the first go so that you don't get trapped. Otherwise, it's all going to be empirical according to the available data in the area that you practice.
Right. So Dr. Bhalla, this patient comes to you in OPD, like simple cystitis, female. Yes, sir. So we'll have the audience question. This is just a few flow, then definitely we have the audience.
No, I don't think you don't have to give 2 drugs. Yes. So I think what is important, Dr. Paras has mentioned very nicely, it's a simple UTI, it's a cystitis, it's a complicated UTI is there. Now you have to realize where the infection is. Is it in the lower urinary tract or in the upper urinary tract? Lower urinary tract symptoms, you will have features of lower urinary tract symptoms, dysuria, pain, frequency. Cystitis, you will have suprapubic pain. If there is upper urinary tract infection, you will have fever along with some suprapubic dullness. Now that is when you will decide, you will investigate. Ideally what is to say that a good urine routine examination, if you can see WBC CAS, which we don't see nowadays, that would tell us that the infection is in the kidneys. That is, it's an upper urinary tract infection. Right? So that is what number 1 to tell you. The duration of treatment is important. Simple UTI, 1 dose to 3 to 1 dose to and the treatment can vary between 1 to 3 days. If it is a infection that is there, if you are having cystitis, you can go for 7 days. If the patient is having pyelonephritis, important if the patient is having fever with pyelonephritis, you must treat the patient with parenteral antibiotics. Parenteral antibiotics, no oral antibiotics. And the dictum is that you must give parenteral antibiotics until the patient is afebrile at least for 72 hours. If he is afebrile for 72 hours, that is the time you will switch the patient to oral antibiotics. Give for 14 days. And then go do a repeat culture, and then you decide what is to be done. Then other chronic conditions, I think abscesses and all, I think that can be, the abscesses and prostatitis, they become a different category altogether. So this is how, as nephrologists, we go. In addition, what is important is the hygiene that is there, very important. And one is you to must change the pH of the urine. If the patient is having E. coli, it is very important that you must make the urine acidic, as opposed to the all other drugs. So a common problem that we see that every patient who has dysuria, Alkazol is given. That should not be given. We hope that it's symptomatically better. If the patient is having E. coli, make the urine acidic, just give him simple saline, vitamin C. In an acidic urine, E. coli does not grow. So give the patient saline, maybe you can give it for a month, and then treat with the appropriate antibiotic for the appropriate duration of time. So this is how we approach patients with UTI.
As you asked for the dual antibiotics, if it is complicated UTI with ESBL organisms and it's a risk category 2 or 3, you may have to give dual antibiotic in that situation, but not for the simple UTIs.
It's a simple question. Patient comes to you with simple UTI. You want to confirm with the urine culture, and you also want to prescribe medicine on day 1. Very right. How do you manage? If a patient, when you prescribe medicine, antibiotic, patient will start taking antibiotic in the same day, and you get the culture the next day.
So it is a simple, if a patient comes to you with UTI, what you do is that you tell him that you please give your urine for culture, adequately hydrate the patient and put him on a quinolone, right? Wait for the culture report to come after 3 days, and then change accordingly.
That is the problem. Patient will not get the sample done on the same day. Most of the lab refuse the samples on that day. They will say, get the fresh morning sample.
No, that's wrong. You have to take a midstream sample.
That's what I'm saying. Yeah. Even Dr. Lal patient, they refuse the patient. They said, come tomorrow morning.
I think we as physicians need to realize that this concept of morning sample was for ease of work, right, and managing the work hours. They used to fool people. Now it is point of care testing. We need to counsel patient that आज अभी sample देगा अभी मतलब अभी और sample देने के बाद ये antibiotic शुरू करेगा. That's very, very important that we stress on that. But still there are situations. Then in those situations, Dr. Balla, do you advise them to keep the sample and start the antibiotic and give the sample next day?
What I do actually in this situation is, I tell the patient that if you have infection, it would be picked at any point of the day. So you can give the culture now also. So they are convinced that it is not necessary to give the morning sample. Then whatever local nearby nursing home or hospital is there, you send the patient there and let them give the sample there only. It will be taken away and put for culture.
So I think very important point that cultures can be given at any point of time, and in fact, patient usually comes because normally we do the evening clinics, right? And patient comes with symptoms of UTI, so we can't wait, So there you can give the sample, but problem that lab is functioning for 24 hours. That's more important because some labs are not functioning in the evening, right? Suppose the patient gets into max is 24-hour working, then you can have the sample. But if you get the sample at this culture won't go to the lab, then it would be suddenly could get some infections. So it's very important that culture should, the sample should be sent there and there only. Not you have to wait since morning के आपने culture रख लिया आपने urine आप सुबह भेज रहे हो को. I think that should not be done. Right. This is the practical problem with the patient. So this is a misconcept. Yeah.
You set them right, otherwise I'll come and set them right tomorrow.
So that is where the physician has to be proactive.
Yes.
We have to be proactive. We are talking about being proactive. This is where you have to be proactive.
But how you investigate those patients of complicated UTI, right? Suppose patient comes with this flank pain and fever and high counts, and the patient have some urinary symptoms. So how you investigate those patients?
So urine routine and culture we have already discussed. So you need to take the complete history is very, very important. So if suppose it's a patient of structural malformation, polycystic kidney disease or some posterior urethral valves or something like this. So our patient is a neurogenic bladder case. So these things are usually diagnosed early and the history will give you this answer what type of infection it could be. So depending upon the history of stone disease or any such thing, you will initially do an ultrasound. If ultrasound suggests that there is some hydronephrosis is there in one or other kidney, then of course you would like to go for the CT scan of the patient. And hemogram and KFT are routinely done for all the patients. Urine culture, since patient if has complicated UTI, that means having high grade fever, so a blood culture should also be sent along with this.
So what you would advise me is contrast enhanced or non-contrast enhanced?
Normally for kidneys, non-contrast enhanced CT scan is good enough. It gives us sufficient information.
Sometimes you feel like because if you give contrast, the contrast has its own problem.
So, yes,
right?
if patient has acute pyelonephritis, yes, it can sometimes cause contrast associated
Because sometimes
nephropathy
radiologists say that you have to do a contrast enhanced just to look to promptly diagnose the case of pyelonephritis. But normally in renal stones, definitely we do the
So
non-contrast.
sometimes what happens is you can see emphysematous pyelonephritis. That is one of the most dreaded complications. Like Dr. Neeru mentioned, a simple non-contrast CT can be done immediately. You should not miss out these conditions. That's important.
Right. So moving from infection to very important pertinent, problem with the physicians are PPIs, right? So today we have a very talk on GERD and we are, having.
I have a question from Dr. Ballas. Since the context of contrast was going on, so we have a lot of patients which we want to do contrast CT scan, and for liver contrast CT scan, there is no point getting a non-contrast. The creatinine is around 0.9, 1.1, 1.3, 1.4, but the patient has good urine output. So how do we go? The radiologists always refuse.
Yeah, I think first of all, there is a myth about contrast nephropathy. What we were taught around 15, 20 years back that it is to be avoided, there is no contraindication for giving contrast. Now, I was lucky to do a debate in my parent institution where we discussed the pros and cons, contrast versus non-contrast. So what we found was that when we do a propensity scored analysis, that is when you compare two groups of patients, one given contrast and the other patient not given contrast, it was found that the patients having renal failure was more linked to the other factors rather than contrast. So in simple terms, contrast is not such a bugbear and it is not such a thing to be scared of. Number one. Number two is that the dye that we're using non-iodinated contrast across the board. So it is safe. Third thing is that adequate hydration is the only thing along with statins to be used to prevent contrast nephropathy. And the fourth thing, if you feel that the benefits are going to outweigh the ill effects of contrast, don't hold back contrast.
So any cutoff for?
No, we don't give any cutoffs. We don't give any cutoffs. If you feel that it is very important, even because we see this every day, we get consults. Yeah, no, if we see patients with we get these consults every day from the cardiology department. We tell them, you please go ahead.
Okay.
If you feel it is life-saving, there is no contraindication to that. Please go ahead.
One more query regarding infections. See, majority of cultures report that you get, azithromycin always there, and 90% it is sensitive. Now, do we give azithromycin renal infection?
Sir, if I have nothing else is available and the culture is from a good lab, if that is the only drug that is available, I will use it. So, see, it is a macrolide antibiotic, mainly it causes hepatotoxicity. It is good, can be used in patients with UTI, you can use it in patient UTI. But having said that, it will not be a first line drug, we will not use it.
I have a question on contrast only. Some labs say metformin band karo, फिर आप contrast work करेंगे. What is your take?
Metformin in general, is actually related to the GFR of the person. If patient has comorbid conditions, he is a diabetic, GFR is less than 30 ml per minute, and he has other comorbid, then it is likely to be some complication. But metformin, if GFR is good, is not supposed to be stopped if patient is taking it already for long.
Dr. Dang, is it about lactic acidosis you are talking about?
I don't stop it.
Yeah, we don't stop it, yeah.
I send a patient for a contrast study and they said ki metformin band karo.
No, I don't think there is any data saying that any drug of drug, bicarbonate to be stopped, there is no data which tells you.
See, before the surgeries, yes, metformin is stopped, but before the investigation, it is usually not stopped.
Yeah, no,
So I think in contrast, I think hydration is more important.
Yes.
And
hydration and statins now, right?
And statins have got some role in preventing the contrast nephropathy, and NAC is actually out probably because
So
a
yeah,
lot of studies have come up.
see, a lot of things with the dopamine, NAC, everything is out. Only thing now is that only statins and this. So we get this from our cardiology. We tell them you give them statins 40 milligrams, just hydrate them.
Yeah.
So that is all.
Yeah. So
Hydration is the best treatment for this.
So I think moving on to this PPIs, dilemma, right? So I think Dr. Naresh is here, and I think dyspepsia or GERD or whatever acidity, hyperacidity, is a national problem, right? Every patient is on some or other PPIs for months or years altogether. So I would see that if those patient comes to you, right, and patient is having some sort of kidney issue, some amount of proteinuria. So can it be attributable, or Niru would be getting this answer because I framed this question for Dr. Niru, that what is the ill effects of this PPI on kidney acid? Then I'll come to Dr. Naresh.
So as such, there are not many studies about it, and the only thing that has been, it is the circumstantial evidence that patients were being given PPIs and they were not on any medication, but the renal function deterioration was seen, some urinary sediment was seen. So it was observed that if it is given for 6 months or more, then PPI can cause acute kidney injury. If it is given for 4 years or more, then they cause this chronic interstitial nephritis. But as such, there are many more studies are required before coming to a conclusive data. But these are actually some small studies that these evidences have come.
I think the original of PPIs came as Dr. Arora. He was a professor in SGPGI. He went to US. He was working in Veterans Administration Hospital. So he has looked at almost 18,000 people who were in Veterans Administration, and he compared the incidence of CKD in patients given PPI versus not. And he found that the patients who were given PPI, the incidence of CKD was slightly elevated between 1 to 3%. So I agree with what Dr. Niru said, that again the fear is more than what is there in the real world. So we should not hold back, and it's long-term effect that is.
But 1 to 3% is a low incidence,
So
right?
yeah, so long as the gastrointestinal is concerned, now the European and American companies want to put some warning on their leaflets that it can cause chronic kidney injury apart from osteoporosis and osteomalacia.
Right, because
So
yeah,
it's one of the most seen side effects of PPI on prolonged use. I don't know about acute kidney injury, but chronic kidney injury is known.
Right. So I think
hypomagnesemia, hypocalcemia, and
so a lot of electrolyte disbalance, osteopenia, osteoporosis, metabolic bone disease, and AKI, as you rightly said, has been reported. But actually, most of the patients say that if you stop PPIs, definitely I have some issues. So I cannot stop PPIs. So Dr. Naresh, just out of the box question.
So now for last 1 month in India, what is happening? There is a search of a newer molecule. Let me get the opportunity to discuss that molecule is vonoprazan, and it is called potassium competitive acid inhibitor, PCAB. And it is proclaimed to be better than PPIs in terms of causing toxicity to various organs, particularly kidney, bone, and so-called dementia. But the matter of fact is that PCAB is in market for last 5 years only, It got FDA approved 4 years back. PPI have been used since 1991, and this warning came in 2007. So this was 17 years after the introduction of PPI in market that this was noticed. So we need to wait for PCAB what it does or what it does not.
Right, I think today there was CME on GERD on this same vonoprazan upstairs also. So I think a lot of companies are coming up and they say that, you know, it is safe, it is effective, and only once a day, 10 gram or 20 gram dose. So I don't know whether what will happen. This would actually, another PPI, the future will tell us.
It's a new generation proton pump inhibitor.
Right. Dr. Naresh, another very...
Sorry.
Yeah. So, Dr. Naresh, as you answered this question, the other question that comes to it that actually we wanted to cover because of the paucity of time we could not cover. I think this HRS issue was actually we discussed Dr. Bhalla that the hepatitis syndrome sometimes comes with physicians also at times, right? Okay, what is this entity and how you diagnose? Just a few pearls about it because it's a very long topic, but just few pearls for physicians. So how you diagnose HRS, hepatitis syndrome?
To talk in short about HRS, HRS is one form of AKI in patients who have gross ascites, moderate to tense ascites with portal hypertension. So we don't diagnose HRS in patients who do not have portal hypertension. Particularly acute liver failure patients, if develop acute kidney injury, will not probably HRS. So HRS is some entity in which kidney structurally is normal. So AKI we have either pre-renal or acute tubular necrosis. In HRS, tubules are normal, glomerulus is normal, and this happens because of hemodynamic effects in the systemic circulation because of portal hypertension. And kidneys are absolutely normal. The definition is, by definition, is 50% increase in creatinine above the level of 1.5 milligram percent compared to the previous definitions in 2 weeks time. And previously it was called as HRS1, now it is called as HRS AKI. And HRS2, the so-called, which is a form of chronic kidney injury in patients of portal hypertension, is more or less similar to chronic kidney disease and does not have any different treatment than CKD, but except for the liver transplantation, either solely liver transplantation or combined with kidney transplantation.
So Dr. Bhalla, are you agree with this HRS?
Yeah, I agree with what he's saying. So now it is very important to know that HRS type 1, type 2, the whole classification is changed now. So HRS type 1 is HRS being called as HRS AKI. That means the renal dysfunction is there for 14 days. If the renal dysfunction continues from 14 days to 3 months, it is called HRS AKD. And if it goes more than 3 months, it is called HRS CKD. So the treatment, as Dr. Naresh has mentioned, is very clear-cut. When you have a patient with HRS type 1, you give them albumin, dietary infusions, you give them telepresence. HRS, AKD and CKD, these are the patients you go in for liver transplantation with concomitant renal transplantation depending on the GFR that you have. This is how you treat, you classify and treat.
And I want to emphasize here that these patients initially, because there is an extreme vasoconstriction that lead to AKI basically, and their fraction excretion of sodium is usually less than 0.5 even. So these patients should be given enough amount of IV fluids in the form of saline rather than restricting fluids that they are not passing urine. We should restrict the fluids. They should be given fluids even if their albumin is normal. They should be given albumin for 3 days at least.
Some small comment. If we have diagnosed a patient of portal hypertension with HRS AKI, then we have to rule out pre-renal AKI by giving a fluid of 1 to 1.5 liters. If it does not respond, then we classify it as HRS AKI. Pre-renal patients will improve with infusion of 1.5 liters fluid. After that, we must restrict the fluid because patient is already overloaded with the fluid, and this happens because of reduced perfusion of the kidneys. And the treatment after that, when we have given 1.5 liters, is terlipressin and albumin. And terlipressin initially was given in bolus dose, now in the infusion form, and has a response of at least 70% in reversion of HRS AKI.
Correct.
I think for we as a physician, whenever we are having a patient with AKI, 3 things probably would be of immense importance. One is replenishing their volume, right? So rehydrate them either by taking the history of how much they have been having GI loss, how much is the poor intake that they have. So you need to rehydrate them first. Second is going to be taking care of the sepsis. So send the cultures, take care of whatsoever focus of infection is there. Third, in any given scenario, I think the intravascular volume is very important. So when we talk about any debilitated patient, the albumin comes into the play. Whenever we talk of a CLD patient, the albumin comes into play. So you need to give them that intravascular volume by way of albumin. So I think for we physicians, it's always going to be those three things: taking care of hydration, taking care of sepsis, and if albumin is too low, please take care of the albumin also.
So I think last two questions.
Then avoid those nephrotoxic substances.
Diuretic should be avoided, Lasix should be avoided in this.
So last two questions. Dr. Bhalla, as a physician, because the patient comes with stable CKD, creatinine hovering around 4.5, 5 or even 6 or 7, and patients are non-heavy uremic symptoms, patient is output is fine. Okay, so we refer to nephrologist, okay, the creatinine is 7, this patient would need dialysis. Right, so I would have the concept of, we can hold the patient for dialysis early versus late. So what is the take home for the physicians?
So I think the take home is that one is guidelines and the real world. Now the guidelines say that a patient, anybody with a GFR less than 15 ml. Now let's talk about GFR. Less than 15 ml is stage 5. That is the time when the patient needs renal replacement therapy. Let's forget the creatinines because now all the labs are giving us a GFR less than 15 ml. So basically, this is the time you advise the patient to go in for renal replacement therapy. If the patient wants it slightly earlier, we start preparing when the GFR around 20 ml, we start preparing them if they want to do that. But in the real world, what we do is that, at least what I do is we look at uremic gastropathy. If the patient is having nausea, vomiting, weight loss, lethargic, this is the patient who requires dialysis. Other than the urgent indications being, we all know, fluid overload, hyperkalemia, acidosis, pericarditis, that is that the patient will come to you in the emergency. But if the patient is coming to you in your clinic, GFR are less than 50 ml, compliant, educated person, wants to go in for full, that is the time you advise. 20 ml, if it's a long-term follow-up, 20 ml, you start preparing him. Or if the patient is having features of uremic gastropathy along with the other constitutional symptoms, that is the time as a nephrologist I advise him to go in.
So uremic symptoms, go for albumin dialysis. No, uremic symptoms are not there, but eGFR is less than 20, start preparing, and if it's less than 15, stage 5 CKD, you have RT. Dr. Neeru, your comments on that, because it's a very important question for physicians.
They say if GFR is less than 30 ml per minute, at least introduce about renal replacement therapy to them. So whether it is an elderly patient who is above 70, at least introduce about that, because I am talking about the real world scenario, because if you tell them for dialysis immediately at 15 ml, then they will jump and they will start searching for other people who would suggest to not to go for dialysis. So RRT should be introduced, and if they are agreeing, then go for AV fistula formation. It should be done in all the patients, and it is going to mature, it's going to take time. They should be apprised about the need for dialysis and how it is done. If patient is young, then discuss about transplant and guide the patient as per their requirement.
So last question.
Again, some set of 10-15% would be those CIN types who are not having hyperkalemia issue, those who are not having fluid retention issue. So then they tolerate that urea up till 250 and they are still happy with that urea of 250, creatinine of 10 or 11, and still they are devoid of any hyperkalemia.
So Dr. Paras, just to bring about this confusion of CIN and CGN, that is why our national foundations are just giving you stages of CKD. The CIN, CGN, all that, when I was doing my DM, there was a lot of debate. Now nobody is talking about that. The stages of CKD, that is for you to decide how to go about for renal replacement.
What I am saying is that in the real world scenario, those who are with tubular disorders, they do not have issue of fluid retention, they do not have issue of hyperkalemia, so they continue to feature a little bit better than those who are fluid retainers.
So see, but the offset is that then they have bone disease, they have anemia.
That's true.
Yeah, so I'm not saying that.
In the real world scenario, they continue to get delayed.
Right, so last question, I think Dr. Bhalla, you must be visiting ICUs and all. Dr. Paras was also there. Now the concept of this this ultrafiltration or the cytosorb or this heme adsorption. So what is the role? Because sometimes there's a very contradictory trials of that. It may be beneficial, it may not be beneficial. Because we do a lot of get of sepsis. Sometimes nephrologists say, okay, this patient needs some sort of, hemo ultrafiltration or some sort of cytosorb. So what is the current statement?
So first we talk about, so when you're talking about giving cytosorb, first of all you have to get the basic IL-6 levels done. Yeah. We had a lot of experience, we are doing it we learned from what we did in COVID times. So the normal IL-6 levels are around 8 nanograms, but if there's a more than 10% rise, that means around 80 to 100, that means this patient is having what we call a CRS or cytokine relief syndrome. Now, what your heme adsorption and your absorbent therapies, including cytosorb, is doing is basically, they are just absorbing the cytokines that are there. Endotoxins that are there. So you have various filters. You can have oxares, you have cytosorb, and things like that. So that is an indication. One is that you start early. One is you get an IL-6 levels. If there is a rise of more than 10 times, it is indicated. Now, the second is that start giving them early. You start within 24 hours, you will get the best response. There are studies from our institution, Max PPG, and follow-up studies in Vedanta. What our experience has shown in around 40 patients is that giving this has brought about only a hemodynamic stability in our patients, which may give us some time in increasing and improving the outcome.
Bridging therapy is called.
And also the experience has shown that in patients, in non-sepsis patients, especially in situations like dengue, in situations like pancreatitis, the response and the outcome is far better than in patients with sepsis. So this is what our real world experience is.
So any one or two short comments or questions from the house, then we can close the session. Dr. Gira wanted to ask you. You want to ask? Two short comments. Statins
So all the studies have talked about atorvastatin, but we are okay with thing. First of all, as nephrologists, at least I am very scared of giving statins because they cause a lot of myopathy. So my patients will not tolerate that. But if a cardiologist is already giving them, then we don't stop them. And unless there is a situation when the patient is having active CAD or things like that, that is the situation we give them. And then you can choose between atorva and rosuvastatin.
So, myotoxicity is slightly more with rosuvastatin. So that's the reason it is not allowed. But only thing is atorvastatin, as we are seeing more patients who have high LDL levels and the direct risk factors for the major vascular events. So atorvastatin is being used. Fenofibrate is not used. If required, then ezetimibe can be added along with. So rosuvastatin, myotoxicity is more. That's the reason it is not used. And studies, as Dr. Bhalla has said, more on atorvastatin. So this is from our side, atorvastatin is the drug of choice.
For physicians, if there is anything renal involved, before calling a nephrologist, change the prescription from rosuva to atorva.
You can ask this question.
Good evening, sir. Sir, if the patient is developing the AKI, the creatinine value is increasing and the eGFR is less than 15 and it's acute setting and the urine is passing, then we have to initiate the dialysis or we have to wait for decreasing. And if we have to wait, then how long we have to wait?
So I think that is a question that Dr. Pankaj had given me. So this is deciding between early and late dialysis. So acute setting. Not about chronic, acute setting. So there are two landmark trials. One is called the Akiki and the Elaine trial. They both looked at this acute, that means a drop in the urine output of more than 0.5 ml over 12 hours. Vis-a-vis a late, that is an acute indication of dialysis, which is acidosis, hyperkalemia, fluid overload. What they have found is that there is no difference in the outcome between acute and slightly delayed dialysis. So you have to individualize the patient and decide. The only difference that was found was in the Elaine trial, where they found that patients with polytrauma, there was some statistical difference in the outcome. So there is no difference between early and late dialysis and acute AKI setting. That is important, right?
Sir, one more thing. If a CKD patient is developing HRS AKI and usually we hold the diuretics, and if usually we hold the diuretics for the
the diuretics, what did you say?
Diuretic. Lasix we have to hold. But if the patient is passing the good amount of urine with the Lasix, then we have to continue our hold.
So one is that HRS AKI, one of the criteria, oliguria is one of the criteria.
Yes, yes.
Now the important thing is that you must realize that the albumin that is there in a patient with some hepatic problem or chronic liver disease, it is a dysfunctional albumin, right? So that is why it is not acting adequately. So that is why you have to tag your 20% albumin with Ditor or with Lasix for it to become effective. So one is that oliguria will be one of the symptoms. Secondly, your endogenous albumin will be ineffective, so you have to give them exogenous albumin along with tagging to bring out good amount of dialysis. That is where what Dr. Naresh was mentioning, that adequate hydration and give good amount of albumin to these patients. At least they say 60 grams per day, but we are not going more than say 30 grams.
Yeah, it's 40 to 60 grams. One bottle contains 20 grams.
So I think I thank.
One second, his answer. If you are in doubt whether patient has HRS AKI or it is AKI other than HRS, go for the fractional excretion of sodium. If it is more than 1, it means it is ATN and you can treat different manner. If it is less than 1, it means it is HRS AKI. Although later, in the later part, all HRS AKI converted to ATN.
Of late now the NGAL, some substance in the urine, that is a very good substance coming up
These
nowadays.
are the biomarkers, they are the biomarkers of
Yes,
AKI.
yes,
Yeah, they can be used, but I think more of clinical criteria has been used.
Yeah, upcoming.
So I think we thank all the panelists for an excellent show. I think we have covered I think most of the questions that has not been answered during this thing, and have deliberately, did not discuss GLP-1 and HA2 that was discussed previously. So with this, I thank everybody who are here, still here, right? And I would hand over to our dynamic secretary, Dr. Tuchar, to continue and to felicitate our chairpersons and panelists.
I would request Dr. Naresh Dang sir to please felicitate our faculty. With this, I would like to conclude today's academic feast. First and foremost, I would like to express my sincere gratitude to our esteemed speakers. Your insightful presentation and in-depth discussion have been cornerstone of this conference. Thanks to our sponsors and partners. I would also like to thank my Midcon organizing committee and executive committee members for your hard work, dedication and meticulous planning. Finally, thank you all the delegates and the participants for your active involvement and enthusiasm in the conference. Thank you once again.
All the people who are actually involved in this would come, and we had the group photograph. Dr. Vijay Rodat, the chairman scientific committee. Dr. Anirudh Lochan is actually finally here. So I think Dr. Ajay, our vice.
And sincere congratulations to entire EDPA, the organizers Pankaj, Ajay and all the eminent nephrologists around the area. Dr. Balla, please come on the stage.